Good morning, everyone. A warm welcome to the esteemed faculty and dear delegates on a Sunday morning to a CME of its kind. A CME which commemorates the World Immunization Week, which is celebrated in the last week of April. For you, we have a plethora of experts to give us insights in the field of vaccinology, because today is the time for facts, not fears, a time for rationality, not rumors. To start the proceedings of today's CME, I would like to invite our scientific convener for the meeting, the pioneer in vaccinology, Dr. Nitin Shah sir.
Good morning, delegates. It's indeed a proud privilege that Dr. Rajesh, who is the president of the Mumbai IAP, who is the host, has actually given the honor of welcoming you to me. So I am really thankful to Rajesh. This vaccine CME is very unique, as Shikha said, that today is the last day of the Immunization Week celebration. So we are celebrating the week and ending it with a bang by having this CME. Early morning, I got a phone call from someone saying that I want to come to the CME. I have not registered. I said, but it is physically full now. I cannot accommodate you. He said, no, I'll come very briefly and go away. I said, okay, you come. And then came the rain god and there were showers in Mumbai. Beautiful venue, as you would understand, Geo. I am sure all of you would go around and do go to Nita Ambani Cultural Center and sometime have a show there. It's one of the best operas I have seen in my life. Okay. I want to show you something that you're going to get in the delegate kit. So we have a very vaccine-specific delegate kit, which will have your ethyl alcohol sprays and cottons and syringes and whatnot. But most important, we are going to give you this IAP FAQ book, which is actually costing 1,200 free of charge. And you'll be proud to hear that you are the first recipient of this purple book. This is the IAP guidebook on immunization by the ACVIP. I had to really sort of burn midnight oil and cajole with the current president, Dr. Upendra, Dr. Ramesh, Vineet, and everyone, that I want this book. They said, no, it can't be given. It is to be given through distribution by micro against a phone call and a OTP and all that. I said, I don't care. As a past president, that's my only demand. And they were very happy. These are the first 200 copies printed and sent to us yesterday. So please do collect your delegate kit after tea break and during lunch break from the next hall where exhibition is, so that you get your delegate kit and especially these two books. Well, the topics have been chosen in such a way that all the new vaccine or any new data in the existing vaccines is in the form of monologues, and all the common questions that you have in other vaccines are in the form of dialogues. So it's a mix of monologue and dialogue, and I hope you will enjoy it. And last but not the least, I cannot but thank the faculty, and faculty has been chosen from who is who in the world of vaccinology. So especially the outstation faculty who took their time out and came here. So all the delegates, please do enjoy the entire day's session. And the last session will end with your questions. So I have 45 minutes for audience participation. So please do stay back till evening and ask whatever question you want to ask. Now I'll ask Dr. Kasi to please come up the stage. Where is Dr. Kasi? And Kasi, I will want you to formally inaugurate your baby, and that's the purple book. Yes, sir. So without much ado, I think we will start with the scientific deliberation for which we have all gathered here. I hand over mic to the MOC, Dr. Tanushree, to take forward the proceedings of the day. Thank you.
Thank you so much, sir, for this. So we will directly start with the science today. And for the first topic, we have pain of blisters or pain of prevention. So I call upon Dr. Srinivas Kasi, who is a consultant pediatrician from Bengaluru. And sir, we all know he's contributed chapters on vaccinology topics in various IAP textbooks. Just a small announcement for those who are seeing us online. They can put their questions on the chat box and someone will take up during the discussion time. Thank you. Over to you, sir.
At the outset, my sincere thanks to the organizers of today's vaccine CME, Dr. Rajesh, Dr. Nitin, and all the other team members for giving me the honor of inaugurating this very, very unique vaccine CME. Believe me, I went through the topics, and I think there's a lot of things that I can learn today, and I'm sure all of you all will benefit. So my topic is pain of blisters or pain of prevention. You may be wondering, what am I going to talk about? I'm sure most of you all have realized I'm going to discuss herpes zoster, the pain associated with the disease, both over a short period of time and persistent pain, which may persist for years and be very debilitating for that individual subject. I'm also talking about the pain of prevention. Why, as I will discuss later, the vaccines are very effective but also quite reactogenic. So this is a vaccine not for your patients, but for all pediatricians above the age of 50 years. So important to know something about it. The primary event of any herpes zoster infection is entry of the virus, development of chickenpox. Following the chickenpox episode, the virus remains dormant in the dorsal root ganglia. It remains dormant for many, many, many years. Ultimately, when there is some depression of the cell-mediated immune response, either because of age or disease or drugs, this virus gets reactivated. Formerly, it went in a retrograde manner. Here it comes in an antigrade manner, reaches the nerve terminals at the skin, infects the epithelial cells, and you develop the typical rash. Difference, chickenpox is a generalized disease, whereas herpes is a dermatomal restriction in one particular dermatome. Of course, multiple dermatomes may get involved. Right. Herpes zoster not only causes acute disease, one of the most debilitating complications is post-herpetic neuralgia. Apart from that, there's one more concept which I would like you to understand. It's called burden of illness. Burden of illness is the disease, the pain, the duration, the complications, the impact it has on the life of that particular sufferer. Everything is combined, given a score, and you have the burden of illness. So burden of illness is something which is also important to consider in herpes zoster prevention. Generally, an incidence of 3 to 5 per 1,000 population has been reported in most of the Western countries. There is some data from Asian countries, but more Japan and Korea, nothing from the South Asian countries of which India is a part. All the studies have shown that there is a marked rise of herpes zoster above the age of 50 years. As you can see, above the age of 50 years, there's a marked rise both in the incidence of herpes zoster and in the incidence of PHN. The lifetime risk for developing herpes zoster is almost 50% for anyone above 80 years of age. About 3% may need hospitalization, and 3 to 5% may experience recurrences of episodes. And that gives the importance of taking the vaccine even if you have had herpes zoster in the past. Post-herpetic neuralgia is the most debilitating complication of herpes zoster. It is conventionally defined as dermatomal pain, persists for more than 3 months or 19 days after the onset of the acute episode. Approximately a fifth of patients have some pain at the end of 3 months, and almost 15% have it even after 1 year. Treatment is rather disappointing, complex. It increases with age, so anyone developing herpes zoster after 80 to 84 years, almost 1/5 have post-herpetic neuralgia. It causes considerable impact on the health of an individual and also on society. A systemic review of all studies from India showed that in India, post-herpetic neuralgia incidence has varied from 10.2 to 54.7%. And other very important complication of herpes zoster is secondary bacterial infection. And that incidence is almost about 3.5 to 21% in Indian studies. So it is essential to prevent herpes zoster. It's an important, I won't say public health issue, at least from the individual point of view, it's extremely important to prevent it. We have two vaccines, as I put in the first. We have one Zostavax, the older one. I will briefly describe it because though it is not the preferred vaccine, it's not available in India, but many countries are still using it. This is a live attenuated vaccine. It contains about 19,400 PFUs. Compare it to chickenpox, 1,400 to 1,500. This is almost 12, 15 times the amount of virus present in the chickenpox vaccine. Why? Because you're giving it above 50 years of age. 50 years, your cell-mediated immune response is very low. You need a much higher antigen content to stimulate your cell-mediated immunity. It also contains gelatin, traces of neomycin, cough serum. This is important to know when you have allergic reactions to any vaccine. No preservative. You cannot use it in patients who have had anaphylaxis to gelatin, neomycin, or any other component of the vaccine. Being a live vaccine, you cannot give it in the immunocompromised, and it cannot be used in pregnancy. The initial Zostavax was a freezer vaccine. You required minus 56 degrees. But the present batches are refrigerator stable. It can be used for a shorter period of time at 2 to 8 degrees. Zostavax and Pneumovax 23 should not be given together. They should be separated by about 4 weeks. This is the only interaction that has been observed. The first study which showed the efficacy of Zostavax was known as the Shingles Prevention Study, or SPS. This was done in subjects above 60 years, 3 cohorts, 60 to 69, 70 to 79, above 80. And as you will notice, the efficacy varied from, overall efficacy was 51%. The highest efficacy was those between 60 to 69 years and reduced gradually as age advanced. Post-herpetic neuralgia, the efficacy was about 39% overall and practically no efficacy in the older age groups. All in all, moderately effective vaccine. The second study was the Zoster Efficacy and Safety Trial, ZEST trial, which was done in individuals between 50 to 59 years of age. And as you notice in this study, the efficacy was much better. Overall efficacy over the entire follow-up period of 1.5 years was about 70%, and it reduced as time progressed. There was a rather moderate fall in the efficacy over the 1.5 years of study that this undertook. Now, if you look at the long-term persistence of protective efficacy with the Zostavax, if you look at herpes zoster burden of illness, which is rather broad category, some efficacy was there till year 10. If you look at efficacy against herpes zoster, it reduced to very low level from the 3rd year. If you look at the, post-herpetic neuralgia, if you look at the efficacy against herpes zoster, 3 to 4 years. That's all. It was generally a safe vaccine, but definitely more reactogenic than the placebo. And especially the local adverse effects were definitely much more compared to the placebo, and that's why we said it's a reactogenic vaccine. There are 2 effectiveness studies, one from Sweden and another from UK. All of them had figures almost comparable or slightly lower than that which was observed in the pivotal phase 3 studies. For example, Sweden, overall it was only 34%, higher in the younger age groups. Even in England, the first year it was 62%, but at least over 3 years the efficacy was fairly well maintained. Now we come to the other vaccine which we are really interested in today, and that is Shingrix. That is the vaccine by GSK which has been released into the market, and I think it will be available very, very shortly. Now this vaccine is a recombinant glycoprotein E vaccine. Glycoprotein E is a surface antigen, and almost all the protective antibodies are targeting the GPE antigen. So they have isolated the gene, truncated it, inserted into the Chinese hamster ovaries, where it multiplies. They have then isolated the protein, combined it with AS01, which is a very unique adjuvant made of MPLA and saponins, and they have packaged and produced a wonderful vaccine. Each 0.5 ml contains about 50 microgram of the E antigen, 50 microgram of the first component of the AS01, and 50 micrograms of the saponins. No preservatives. It can be stored in the refrigerator, should not be frozen, should be used within 4 to 6 hours of reconstitution. 2017, it was approved for adults over 50 years. 2021, it was approved for immunosuppressed patients who are high risk for herpes zoster above the age of 18 years. So this vaccine, normal populations above 50, immunocompromised above the age of 18. The first study was called ZO50, Zoster Efficacy Trial, which was done in subjects above 50 years. They were 3 groups, 50 to 59, 60 to 69, and 70 years older. And look at the efficacy. 96.2 overall, and even in those above 70, almost 98% efficacy, an extremely efficacious vaccine. All reactions, the local reactions in number, plus the grade 3 reactions were statistically much higher in the vaccine group compared to placebo, indicating that it's a fairly reactogenic vaccine. The second study was the ZO70. So in this, they took a population above 70 years, 2 age groups, 7 to 79, and above the age of 80 years. And if you look at this, overall in ZO70, the vaccine effectiveness was close to 90% and remained at that same level irrespective of the age of the vaccinee. And if you look at the follow-up, it was followed up for about 3.9 years. Efficacy was fairly well maintained throughout the 4 years of study in all the age groups. Now, if you look at the pooled data of ZO50 and ZO70, overall, the vaccine efficacy is 91%, remaining almost the same in the other age groups. If you look at the year-wise, fairly good vaccine efficacy maintained till the end of 4 years. Even here, it's around 88 to 90%. If you look at its efficacy against post-herpetic neuralgia, which we are so much concerned about, which is the most debilitating complication of herpes zoster, you have very good protection in 50 to 70 years. It's close to 100%. Very good efficacy. Of course, above 80 years, the efficacy is not very good, though numerically you have a good figure. The confidence intervals are in minus figures, so statistically not very significant. What about immunocompromised? This vaccine has shown very good efficacy in the immunocompromised, 68.2%, and very good efficacy against PHN as well. Even the other immunocompromised groups, like adults with hematological malignancies, 87.2%. There has been demonstration of good humoral and cell-mediated immune response in subjects with solid tumors, recipients of solid organ transplants, HIV, rheumatoid arthritis, inflammatory bowel disease, and other acquired immunodeficiency and chronic medical condition. In many of these conditions, they have demonstrated a good immunological response, so though there are no studies showing its efficacy in these studies, except in autologous bone marrow transplant and patients with hematological malignancies, adult patients with hematological malignancies. Now, if you look at the follow-up, how long will the protection last? At the end of 10 years, the efficacy was still about 73%. You see, it began with about 81% overall, very high efficacy in the first 3-4 years. Then there was a gap in the study. From year 6, if you notice, there's a gradual reduction, but still 73 to 75% at the end of 10 years. A very, very good record for any vaccine. There has been a very good persistence of both the humoral and the cell-mediated immune responses till the end of 10 years. This is the CMI, and these are the anti-GPE IgG levels. Now, this vaccine is in use for almost about 4 to 5 years. The first study which looked at the effectiveness, after all, it is how much it works at the community level which is important. It's not a trial efficacy. So this was a study done in a insurance organization where they looked at the data of 1 dose and 2 doses. And as you will see, 2 doses, it was over 70%. Whether the interval was less than 180 days or more than 180 days, it was almost the same. Good efficacy in the immunocompromised, those with autoimmune disease, and those who had received zoster vaccine live in the past 5 years. This is another study which was done again from a Medicare, And here you will find that the efficacy studies has been much more robust in this particular study, showing 85 to 87% efficacy even in those above 80 years, and a good efficacy in even those who had received the live vaccine in the past 5 years. Why they have studied is because now there are new recommendations, and study when you give a live vaccine, the antibodies persist for a longer time. Are these antibodies going to interfere with the take of an inactivated? That's the reason why they have even looked at patients who had received zoster vaccine live. This is a study done in Hawaii, where again they showed a good efficacy, 83.5 overall, 100% in the 50 to 59 age group. So the importance of taking it early, and good efficacy even in the older age groups. Right? So let's compare the two. Okay? Live attenuated, recombinant VZD, adjuvanted, inactivated. Two composition both have to be storage. I think there's an order though. You have a refrigerator stable component, 2 to 8 degrees. Shorter shelf life, longer shelf life. Subcutaneous single dose, 2 doses, intramuscular. First dose, the second dose should be given 2 to 6 months after the first dose. I'll come to it a little later on. Low reactogenicity, very high reactogenicity. Overall efficacy, 51.3, 97.2. Against PHN, 66.5, 91.2. Some amount of protection against burden of illness till 8 years. Defined efficacy against herpes zoster till 10 years of age. Till 10 years. FDA approval, and I think I'll come to the recommendation next slide. So ACIP, not ACVIP, ACIP of USA has recommended the zoster vaccines routinely to everyone above the age of 50 years. The recombinant vaccine is recommended for the prevention of HZ and related complications for immunocompetent adults aged more than 50 years, irrespective of previous history of varicella or herpes zoster, implying even if you had herpes zoster in the past, you have to take the vaccine. It is advisable, preferable to take the vaccine. The recombinant vaccine is preferred over the zoster vaccine live for obvious reasons, which I just mentioned in the previous slide. Following the first dose of the recombinant vaccine, the second dose should be given 2 to 6 months later. If the second dose is given less than 4 weeks after the first dose, you have to give one more dose at least 4 weeks after the early dose. That is common for many of the vaccines that we use. For those who have received the live vaccine in the past, the recombinant vaccine should be offered at least 2 months after the last dose of the recombinant vaccine, after the last dose of live vaccine. In October 2021, the ACIP recommended 2 doses of the recombinant zoster vaccine for the prevention of herpes zoster and related complications, adults aged above 18 years who are or will be immunodeficient or immunocompromised, either because of disease or therapy. This, in a nutshell, is everything you need to know about the Shingrix vaccine. So, thank you. Thank you very much. We'll take it in the common or?
1 second, sir. I would request Dr. Tanushree to kindly felicitate Kasi, sir. And thank you so much, sir, for a wonderful session. So we'll take up the questions after the second session. So we proceed to the next session, which is on a topic where we would be all interested in, because we are all interested in Pani Puris. So now you can eat Pani Puri safely. And this session has an unrestricted scientific grant by Bharat Biotech. For this, I invite Dr. Nitin Shah, sir, who is a consultant pediatrician and hemato-oncologist and section head pediatrics at Piri Hinduja Hospital. Over to you, sir.
Thank you. So I think I will take you through a journey of some very recent efficacy data that is available from field efficacy studies done on this vaccine from Bharat Biotech. This was the first conjugate typhoid vaccine ever produced commercially in world, and I think we must really feel proud that an Indian company, in fact now Indian vaccine manufacturers are going to take over the world vaccine manufacturer in the next 5 to 10 years. We already have seen in COVID, then we are seeing now in HPV, we have seen in typhoid, we have seen in mumps, measles and rubella, where more than 80% of the world's vaccine comes from single company from Pune, and so on and so forth. So very exciting data is available through international agencies which have studied this vaccine for the efficacy in the field trial. So that will make us even more robust to recommend this vaccine for prevention of typhoid. So that's my disclosure. If you are still thinking that typhoid doesn't exist, then you should read this very recent paper in 2023 by none other than Dr. Jacob John's group. It's a study done in 3 urban and 1 rural parts of India in the last 3 or 4 years under the National Surveillance System for Enteric Fever. So year for which these enrollment were in 2017 to 2020. And you can see, depending upon which site, the overall incidence of typhoid in children who are 6 months to 14 years was as high as 1100 to as low as 35 in Pune. So you leave Pune as an exception. Generally, you can see it's anywhere between 600 to 1100 cases per 100,000 population. So that's really huge and needs to be prevented. And if you look at this overall in the age group, then you can see children as small as 6 months, 500 per 100,000. And I think that's the reason why we must give this vaccine early. And this vaccine is now licensed for use from 6 months of age onwards. So there's no need to delay it. By 6 months to 1 year, you should give this vaccine. And you can see the incidence is almost the same, though it's peak in the young children between 5 to 10 years, but is there throughout till 14 years of age. So India contributes to 50% of the global burden disease of enteric fever. I think that's the reason again why we have to find solution to our own problem. No vaccine manufacturer from the Western world was ever interested in making a typhoid vaccine, even when the conjugate polysaccharide vaccine were existing for years in the form of Hib, meningococcal and pneumococcal. So I used to ask this question when I was young, I'm still young of course, that as to why there is no typhoid conjugate vaccine, which is the only polysaccharide for there is no vaccine. Very bluntly I was told, I won't name the scientist, saying that is your problem, you find a solution. So we have found a solution. To complicate the matter, this was an eye-opener, what happened in Pakistan. There occurred a huge outbreak of XDR, which means these typhoid patients were resistant to first line and even to ceftriaxone. So only drug which would work was azithromycin. And if you think azithromycin is going to be a panacea, now this is a study done from India very recently, again published in 2021, which talks of de novo azithromycin resistant typhoid, S-typhi, seen in some parts of the country. And this, when they were sequenced, this gene mutation which led to azithromycin resistance were not related to the Pakistan's MDR or XDR TB. So they were de novo in India. Abuse of antibiotics is going to lead to more and more resistant bug. The only way you cannot worry about all this is by having vaccines. And you have now very exciting new data with this type bar TCV vaccine. Besides the 7-year long-term immunogenicity, which should tell you that, okay, 1 or 2 doses, how good they are in long term, and a co-administration at 9 months with MR is what is confirmed, and probably this vaccine is going to be part of national program soon, along with MR at 9 months. So again, we have to show non-interference, and I'll show you that what data we have. It started with human volunteer study in the form of efficacy, and you'll be surprised when I show you the data that even in country like UK, it is perfectly ethical to actually infect people by choice and then show how much is the efficacy of the vaccine. Then the zero efficacy study of the original immunogenicity data which was there in India, and then the last 5 studies, Nepal, Malawi, Bangladesh, Pakistan, which were all part of the TIVAC, which is the association or consortium which looks at this vaccine's efficacy in the world. And lastly, if you use this vaccine in the national program, what happens is what Zimbabwe showed us in their data. So first, non-interference in measles and MMR. So this study was done where there were 4 groups. Group 1 received both the vaccine at 9 months. And you worry that sometimes you give vaccine so early, whether it will work, you need a second dose. So they give a second dose of typhoid conjugate to these children. In one group, 1 month after the first dose, in other group, 6 months after the first dose. The second group, they gave first measles and then after 1 month typhoid conjugate vaccine. In the third group, they gave typhoid conjugate 8 months and then measles containing vaccine at 9 months. And the fourth group was only measles containing vaccine as a control group. And all children received an MMR again at 15 months of age. And this is a very busy data. Just read the last few lines, which shows that there was no statistical difference in the seroconversion or the titers between the groups, which means whether you gave it together or one after, the titers and the seroconversion are just the same. So that should now reassure you that when you give this vaccine along with measles containing vaccine, there is absolutely no interference for either the measles, mumps, rubella component or the VI typhoid conjugate antibody are concerned. There was no difference in the safety. So again, by giving two vaccines together, no additional risk factor. And very important, the last line, there was no incremental value of typhoid booster given at 1 month or 6 months after the first dose in the first group which received a second dose, telling you that you actually need a longer interval between the two doses if you are going to use 2 doses in your life. And I will touch upon the second dose need, contrary to what IAP CVIP is saying and what WHO is saying in my last few slides of the talk. Okay, this is the human volunteer study done in UK. They took humans who were naive, not received vaccine, nor had typhoid, they were antibody negative, 18 to 60 year healthy volunteers. They were first given a typhoid vaccine or a control vaccine, which was meningococcal vaccine. And after a month, they were challenged by a live bacilli of West typhi in the form of given the solution. And then they were daily followed up after that for vitals, daily blood culture for 2 weeks. And then an online diary for side effect for 21 days. Typhoid are diagnosed if there was either a positive blood culture without any symptom also, or if there was a fever of more than 38 degrees of more than 12 hours duration. Once this diagnosis was made, of course, you cannot allow them to suffer, so they were aborted by giving them antibiotic, which is ciprofloxacin azithromycin. And those who did not develop either fever or culture positivity, at the end of 2 weeks were anyway given antibiotic to prevent a delayed typhoid happening in them. What was the efficacy? The efficacy of the vaccine was 87% with the typhoid conjugate vaccine, and we know that the vaccine, the polysaccharide vaccine is just 52%. So first it clearly shows that there is good efficacy even in people who are naive to any typhoid in the past. What is important is those who had been given the vaccine, conjugate vaccine, they had less severe typhoid in the form of less fever, less severe symptom, etc., and less CRP compared to the people who had not been given the conjugate vaccine. This was the retrospective sero-efficacy analysis of the original study where the Bharat Biotech gave the vaccine to small children and older people and followed them up serially, now up to 7 years. But this study was done when it was around 720 days. And what they looked at is the decay in the antibodies in these subjects and whether any one of them developed a breakthrough typhoid. And they presumed that they had a subclinical typhoid because none of them had clinical typhoid in that period of follow-up. They presumed that there was a typhoid subclinical infection if either there was a rise in the antibody or the decay was not as expected. And again, what they found? They found that the efficacy of the vaccine was, the relative risk was 0.37 compared to people who had received the polysaccharide vaccine. So when the polysaccharide vaccine in the field has a 59% efficacy, 60% more efficacy over and above that makes it an efficacy of around 85%. Very similar to what you saw in the human voluntary challenge test done in UK. Okay, then came these 5 studies back to back, and these are very important because these are field efficacy study. First was in Nepal, in Lalitpur area, a phase 3 efficacy study was conducted in the form of an observer blind and a placebo controlled. So look at the baseline incidence of typhoid, 290 to 400, much lesser than what is there in our country. I showed you we have 600 to 1100 in children. So 9 months to 16-year-old children were randomized to either receive the typhoid conjugate vaccine or a meningococcal A vaccine. And primary endpoint was efficacy against blood culture proven typhoid fever at 1 year and 2 year follow-up. What was the data? The data showed that the efficacy after 14 days after the vaccine was given was 81.6% overall and 85.1% against blood culture proven typhoid. And very recently they have shown, they have published the 2-year for long-term data which shows that the efficacy persists at around 80%. So there isn't much drop, at least over the 2 years, in the efficacy in this Nepal study. The second study was done in Malawi. Now Malawi is a very unique country because Malawi is like the, a mirror of what happens in the developing countries. It has a infant mortality rate which is like at the middle of all the extremes of the developing countries infant mortality rate. Malawi also has HIV infected or HIV exposed children and so on and so forth. So this was important to do a study in this country. So they did a phase 3 double-blind control trial, again in 9 months to 12-year-old children. Again, you look at the incidence was 243, half of what I have shown you what is there in India, even as recently as 3 years back. Again, the same thing. They received either the typhoid conjugate vaccine or they received the meningococcal A vaccine. And simultaneously, they also received MR vaccine. So this study also proved field efficacy. Initially, I showed you non-interference on immunological study where you give MMR or MR and typhoid conjugate at the same time. This is a field efficacy where an MR vaccine was given to children who are 9 months of age and look at the study efficacy. So they had an enhanced surveillance for typhoid by making calls, by sending messages, etc. And the primary endpoint was the same, vaccine efficacy against culture-proven typhoid at 18 to 20 months of follow-up. And they are going to continue to follow up the children up to 3 years. And again, what they found, per protocol analysis or intention to treat analysis, per protocol is very perfect, like everyone has received vaccine, the count starts at 2 weeks, etc. Whereas intention to treat is the vaccine might have given haywire and the typhoid may happen even immediately after the vaccine is given. So you can see there's no difference between the two as far as the efficacy is concerned, which was overall 83%, and which was 75% in children below the age of 5 years and 88% in children above the age of 5 years. And they looked at year by year. So you can see at 1 year the efficacy was 84%, at 18 months 82%, at 2 years 78.7%, and very recently they have published the 3-year data which show the efficacy persists at 80%. So now for the first time we have an efficacy showed persisting year after year and at least till up to 3 years. So you can see here, this is the typhoid conjugate vaccine recipient, these are the men A recipient, and you can see around 100 days after the vaccine, the disease starts going up in the meningococcal A group because they have not received the vaccine, whereas it remains almost a flat course in the patient who have received typhoid conjugate vaccine. 4-year data will be soon published and it will be good to see, and my gut feeling is that the efficacy would persist even up to 4 years. Now Bangladesh, very near to us, very similar to us, have a similar types of environment in most of the parts of the country, and in a way it's an advanced country from the vaccination point of view. By the way, you should be knowing this, that Bangladesh routine immunization coverage is 95%, whereas we have not been able to achieve anything more than 80, 81%. And for measles, well, I'll speak in my second lecture, post-COVID, the MR coverage has fallen to as low as 60% in children in Maharashtra at least. That's the reason why you see so many outbreaks of measles. So this was a participant observed mass cluster randomized. What is cluster randomized? You one area you give the vaccine, in other area you have a control. So it's not individually randomized, it's a cluster randomized. And very recently done in 18-19, before COVID. There were 150 clusters, half of them received the typhoid conjugate vaccine, half of them received the JE vaccine, because you know JE is a problem in Bangladesh, so they gave JE vaccine so that the placebo get some benefit. Huge number, you can see 30,000 on typhoid arm and 30,000 on the JE arm. Again, there were 9 months to 16-year-old subject who received either of the vaccine, and the average follow-up was around 18 months or 1.5 years. And they did a 2-weekly home visit for detection of febrile cases and do a culture if they had fever. So, in an active surveillance for typhoid patients. Primary endpoint was vaccine efficacy against culture-proven typhoid cases. And secondary endpoints were, of course, safety, indirect vaccine protection. So, which means in a cluster where you are given typhoid vaccine and there are subjects who have not received the vaccine, whether they were benefited of an indirect benefit or herd effect because there are a lot of people who have taken typhoid vaccine in that cluster. So this gives you an advantage of doing cluster study. You can study the indirect effect. Just to give an example, when you do the cluster study in China following live hepatitis A vaccine, they showed that not only children who were vaccinated below 15 years, the disease disappeared, the entire population, the disease disappeared, because children were the source of transmission to the adults. So they wanted to study whether there is any herd effect seen with typhoid conjugate vaccine. And what they found, overall efficacy of 85% at 1 year, 1.5 years follow-up, which was almost equally distributed in children between 9 months to 2 years, 81%, 2 to 4 years, 80%, and 4 to 6 years, 88%. And a personal communication with Dr. Firdausi, who was the principal investigator of this trial in Bangladesh, we wrote to him as to whether he can share a 2-year data, and he said that the 2-year efficacy is 83%, which means again it's persisting at the original efficacy, which looks out around 80 to 85%. Now, 5-year data will be published soon. So this will be like the highest follow-up on an efficacy trial in a randomized control way. So it will be very interesting to see the 5-year data, which is going to be published by end of this year. Now, an important thing you see here about the indirect effect. So they had a group which received JE vaccine, SA1442, the live vaccine of China, and they had a typhoid conjugate vaccine group. So there are 2 groups, as I said, 30,000 on each arm. Now you can see here there are a lot of people who had not received vaccine, and a lot of people who had received the vaccine. So those who received the vaccine, I showed you the efficacy. But those who had not taken the vaccine, you look at the indirect effect, then the efficacy is 19%, statistically not significant, which means you have to take vaccine yourself to prevent typhoid, no matter which area you are living in. There is not going to be any indirect effect or herd effect, unlike what happens with pneumococcal vaccine or hepatitis A vaccine. So you can see here, statistically not significant incidence of typhoid as a part of herd effect. So there is absolutely no herd effect with conjugate vaccine. They also did one very important thing. People ask, what if you improve the hygiene? What if you improve the water? What if you improve the sanitation? Is that not enough to prevent diseases like typhoid, which are essentially fecal-oral route? So they had 4 groups. One was the JE vaccine group. There was nothing changed. So people ate, drank, whatever they were doing, they continued. Another group in the JE group, but they taught them wash. What is wash? Clean water, clean sanitation, and hand hygiene. So they did JE without typhoid vaccine but wash. Then they had typhoid vaccine without any wash and a typhoid vaccine with the wash. So you expect the typhoid vaccine and the wash together are going to be the maximum efficacy as compared to JE without wash, which will have the minimum efficacy. So JE without wash was the reference. If you just introduce wash without typhoid vaccine, also you will prevent 44% of typhoid cases. If you have only vaccine without the wash, the efficacy is going to be 57%. And if you have vaccine and wash together, it's going to be 74%. So alone vaccination is not enough. And I think it's absolutely standard 4 or standard 5 science textbook which talks about nail cutting, hand hygiene, clean water, clean your hand after using washrooms, etc., which is very important, proven by this Bangladesh study. So you can see the vaccine efficacy kept on going up and up as you had more and more effective intervention. And the last study, Pakistan, because very important, Pakistan was suffering from that XDR typhoid outbreak. Now, unlike what's happening between the 2 countries, I'm so happy that the scientists don't discriminate because you have to save lives of human beings. So, Bharat Biotech donated vaccine to prevent typhoid XDR outbreak in Pakistan, in the Sindh province, during the outbreak time in 2016. So mass vaccination using the typhoid conjugate vaccine, 1 dose, was used for children 6 months to 12 years between February to December 2018 to interrupt the outbreak. And there were a huge number of children, more like 2 lakh children who received the vaccine. And now an active surveillance was done in the hospital and the GP clinic to see the efficacy of this type of field intervention or mass vaccination program. And they looked at the efficacy against clinical case, against blood culture proven case, and again those who were XDR. And you see the cohort of children were followed up for primary endpoint, which was vaccinated versus unvaccinated children. And overall, you can see 57% of cases were XDR. So half of cases were XDR and half of them were probably non-XDR. What is the data which showed? You can look here, overall efficacy in against clinical cases was 57%. Now remember, clinically very difficult to say which is typhoid, which is not typhoid. Again, culture proven cases, 95%. And again, XDR cases, again 96 to 98%. So no matter whether the typhoid is XDR or non-XDR, the vaccine works the same way. The efficacy is as high as 95 to 96%. So it also looked at the safety. So you can see a fever was around 0.1% of the population who received the vaccine. Less than 0.07 had some local reaction and some had diarrhea. So no red signal for adverse effect. And lastly, Zimbabwe. Mass vaccination done in Zimbabwe. There was a huge outbreak of typhoid cases in Zimbabwe, Harare region between 2007 to 2018. You can see there's a huge number of cases. So they again did a mass vaccination program and also introduced the WASH program under the Gavi funding. And you can see here, the typhoid single dose was given around 350,000 subjects between 6 months to 15 years. And 3 months after vaccination, there was a sharp decrease in the typhoid case in children, but not in adults. Again, saying that those who did not take vaccine did not have prevention of typhoid. You can see here, blood culture dropped from 23% to 0 in children, where it increased from 15 to 30% in adults. So you need vaccination for adults too. And that's why this vaccine is now licensed till 45 years of age. And in fact, now there is a study between 45 and 60 years of age, which I will not show you because of lack of time.
So 5 minutes more.
Yes. So this is the WHO recommendation. For people traveling in high-risk areas where the disease is endemic, you should take the vaccine. So all your friends coming from Singapore, UK, Europe, USA, they should take the vaccine before coming to India, especially if you are wanting to eat Pani Puri on the road, which was the title of my topic. People living in such areas, refugee camps, microbiologists, sewage workers, and children, look at children. So it's like almost recommended as a routine vaccination for children. That's the reason why the government is very serious in introducing this vaccine for national program. In typhoid endemic countries, SAGE recommends introduction of typhoid conjugate vaccine for infants. I showed you the incidence is as high 500 per 100,000 in 6 months to 9 months of age children. So anyone above 6 months of age should receive single dose. And it says that the need for the second is not ascertained. It doesn't mean that there is data to suggest the second dose is not required. As on today, from the data that they have, it looks single dose will work. NIP administration of typhoid conjugate vaccine might be most feasible at the same time as other vaccine. That's why at 9 months when you're giving the MR vaccine is the correct time to introduce this vaccine in the national program for the logistic purposes. This is what the ACIP recommends. Of course, now we have the 2020 purple book which is there in your hand. The recommendation are very similar, that you at least give 1 dose and maybe give it 6 months of age onwards or at 9 months with your first MMR vaccine. Now, why second dose, which I am a propagandist and we may debate and we may discuss, but this is my take on the second dose. Look at the efficacy. Human voluntary test, 87%. Zero efficacy, 85%. Nepal, 85% till 2 years. Malawi, 83% till 3 years. Bangladesh, 85% till 2 years, sorry, it's not 2 hours. And Pakistan is 95%. So except Pakistan, rest all looks around 85%. Now, as I told you, there is a 7-year long-term data by Bharat Biotech, and they had 2 groups. One which received 1 dose, and the second which received a booster at 1.5 years after the first dose. So these are the titers in boosted group versus non-boosted group. And you can see here, the boosted group, the titers were 32, 14, and 10-fold higher at 3, 5, and 7 years, whereas in non-boosted group, it was 21, 8, and 5. So you can see here the titers are almost double in boosted group as compared to non-boosted group up to 7 years follow-up. And look at the seroconversion, which is more than 4-fold above the baseline at 5 and 7 years, was 84 and 71% in boosted group versus 72 and 44. So it falls as low as 44% at 7 years. Would it mean there will be breakthrough typhoid at 7 years, 8 years, 10 years down after only 1 dose? No one knows. But if boosting is shown to improve the seroconversion, what happened? 1 minute. So if the boosting is shown to improve titers as well as seroconversion, why not give the benefit of second dose, at least individual practice where you don't want to give typhoid. And I'm sure Arun is sitting here and he has data, of course not published, but he has got, how many? 60 cases of typhoid, 25 cases of typhoid following 1 dose and 4 in those who have received 2 doses. Well, I leave it to you there for you to munch over what I've shown, and it's completely my own analysis. At least give 1 dose of typhoid conjugate vaccine is my message, so that you can be safe from a disease which is vaccine preventable. Thank you very much for your patient hearing.
Thank you so much, sir. So now we all can have pani puri, but also remember where are you having it from. So I would request our IB member, Dr. Tanushri, to kindly felicitate, sir. So we can have the questions now. So I'm sure everybody would be having for both the sessions. Yeah.
Question is for Dr. Kasi.
Kasi can come up to the stage. Yeah.
I don't know whether this is the appropriate time to ask this question, but for children who have received varicella vaccine 2 doses, and hopefully that has protected them from having ever chicken pox, is the Shingrix vaccine indicated? Because I would presume there is no virus in the dorsal ganglion.
No. One, there is sufficient evidence to show that varicella vaccine decreases the incidence of herpes zoster in the vaccinees, in immunocompetents, to the range of around 35 to 40%. In immunosuppressed, it's much higher, 60 to 70%. It does not protect all. The second issue is, can the vaccine virus attain latency in the dorsal root ganglion? See, initially it was believed that if you give the vaccine and the patient develops chickenpox, there's a double load of virus in the dorsal root ganglion. But studies have shown that there is no increase of herpes zoster following vaccination. So it does protect against herpes zoster. It's all right.
It's okay.
You must remember that once there is latency, whether vaccine virus or the natural virus, when there is suppression of immunity because of age, they are prone to develop herpes zoster. So there's a need to give the vaccine even in those who have been vaccinated. Anything you add?
No, perfect. I think there was a huge study done in onco patient where they developed zoster within no time following chemotherapy. And those children, so there were 2 groups of children, vaccinated and non-vaccinated. They were vaccinated while they were having malignancy. Remember, now that's something which you normally don't do because 40% of the children would develop rash. But it showed that the zoster was prevented to the tune of 80% in short term if they had taken vaccine vis-a-vis those who had not taken vaccine. So what Dr. Kasi is saying is perfectly right. But I would say that till the time we don't know the original code of varicella vaccine in USA doesn't become 50-year-old, we will not get that answer whether they would develop zoster without vaccine or no.
Dr. Kasi, could you?
That's right.
Can you just elaborate on your reactogenicity of both the vaccines, Zostavax and Shingrix? You said they're more reactive. What do you mean by the minor AEI or the major or the intermediate? What sort of reactogenicity? Number one. One of your slides shows that Zostavax first initially you were saying it is a more reactogenic, and now the better you got the Shingrix. But in the slide you have shown more reactogenic Shingrix as versus to Zostavax.
Right.
Could you
Answering
just
your
elaborate?
second question, it is more reactogenic, less reactogenic compared to Shingrix, but not compared to placebo, Zostavax. That is one thing. Yeah. And
About the reactogenicity, what do you mean by
Now
which
see,
reaction?
The pain of prevention. How severe is the pain of prevention?
Now the reactogenicity studies have shown that as far as the local adverse effects in the form of pain, swelling, and redness is almost about 80% more in vaccinees compared to placebo. If you take the serious adverse effects, autoimmune diseases, new onset medical conditions, they are similar in the vaccine and the placebo group. So it's only the local reactogenicity which is significantly more, and it's much more with the Shingrix compared to Zostavax.
Yeah, we have some online viewers also who are asking questions. Yeah, Vinay?
So before that is taken, when I coined the term of pain of prevention, was not only the pain of taking vaccine, but pain of the cost of the vaccine too.
Dr. Nitin Shah, I mean, you are now, I would really like to, because, you know, many experts in our IAP fold and this thing, they are of the strong opinion there should be only one dose,
Correct.
typhoid, and you and even I am on the protagonist of the 2 doses. Could you just little elaborate what is that, this thing? You know?
I think that I use 2 doses. Till time I'm convinced that the 1 dose is going to work for a long time.
Because I know,
I give the second dose 3 to 5 years after the first dose, and not immediately. As I showed you, giving it immediately is futile. So I give 2 doses now. I can't elaborate more than what I showed you, the 7-term long-term immunogenicity data, which showed that the 2 doses were at least had serologically better than 1 dose, which is expected, obviously.
No, but apart from the data, do you endorse that higher level of the antibody titers that really matter,
No,
or it doesn't?
actually not, because if you look at the, there is no real cutoff for the antibody titers, which is preventive in typhoid, but from Dr. Robbins' group and the Bharat Biotech group, they feel that around 3.5 to 7 is the cutoff, and these vaccines achieve more than 100 titer. So when you have to eat 2 chapatis to fill up your stomach, it doesn't matter whether you have 4 or 6 or 8, so far as you have 2. That's the question. Dr. Sane. So, can I take the other half? Yeah, other half, please. Other half, I have already shown IAP is saying because 1 dose is there, WHO says. Yes, please.
Yes.
So can we have the online question, sir?
Yeah, 1 minute after Kasi, the online question. Yes.
Yes, sir.
Okay. Now, to make a recommendation, you require solid evidence. We cannot make it on suppositions or individual opinions. That's why the ACVIP so far has stuck to a single dose. Now, if you look at the 7-year follow-up study, it has been done not in the entire population, but in the 6 to 23 months population. Yes. They have examined it by 3 methods: the Robbins, the zoo assay, they have done it by the Vaxzyme, and they have done by the NCBR, that US one. Correlate of protection is established only for the Robbins method. It has not been established for the Vaxzyme method. So when they looked at the 7-year follow-up by the Robbins method for the 6 to 23 years age group, statistically significant higher titers in the boosted group was present only at 1095 days, that is at 3 years. At 5 years and 7 years, there was no statistically difference between the titers, between the boosted and the non-boosted. Now coming to the actual numbers, even at the end of 7 years, by zoo method, the titers were about 12 to 15 at the end of 7 years. And the accepted concept is that a titer of 2 is protective. That is, that is the basis on which this vaccine has been licensed for use. So if you have a titer of 2 and you're getting a mean titer of around 12 to 15, as of now, based on the study, I'm qualifying all my answers, there is no need for a booster. Times will change. ACVIP is not rigid about it. If new data comes, definitely we will change that.
Absolutely, agreed. Yes.
So, good morning, sir. As much as all of us are enjoying this academic feast here, there are more than 100.
Little louder, please.
There are more than 100 people online.
Okay.
And there's one question for Dr. Kasi. Dr. Indu Khosla asks, are there any studies which shows incidence of zoster in children post varicella vaccination?
We answered that question.
Yeah, I answered that. It reduces the incidence of herpes zoster by around 40% in immunocompetent. This was a 14-year follow-up study done by Baxter's group in USA.
One more, Dr. Unmesh Upadhyay is asking zoster vaccination indication in a patient with 1 episode of zoster.
Yes, the recurrence of zoster is present in about 3 to 5%, becomes much more in the more advanced age groups, and generally the repeat episodes give rise to more postherpetic neuralgia compared to the first episode. So definitely there is a need to take the zoster vaccine even in those who have had 1 episode of herpes zoster.
Sane.
That all these follow-up studies of Shingrix, they say the duration, mean duration of follow-up between the 0 to 36 months and 0 to 41 months.
Yes.
That means 0 days follow-up is, that means no follow-up. So what does that mean to me?
See, that means now the study is conducted over a period of 1 year. So one patient may receive on day 0, another patient may receive on day 300, another one 365. Follow-up is uniform. They say we will follow up vaccinees for 3 years. So at the end of 3 years, all the patients are analyzed. So there is a difference in the duration of follow-up.
So zero in the... No, so zero means they were followed up immediately after the last dose. So normally all per protocol are 2 weeks after the last dose or 3 weeks after the last dose. So someone who is 3 weeks and 1 day, is just 1 day follow-up.
So wouldn't that increase the efficacy of the preventive efficacy, that you are not following them enough, basically?
That is why long-term follow-up is done, 10 years follow-up is there.
So
that gives the correct picture.
So they showed almost now 7 years long-term follow-up in the original cohort, and still the efficacy is persisting at around 70-75%. Alok.
I think we can have just one last question.
So we have Dr. Alok coming from Rajasthan all the way to attend our CME, and also we have Dr. Rajendra Vaidya from Aurangabad.
It's about typhoid vaccine only. The first dose given at 9 months. The typhoid occurred after the 1 dose. If the vaccine is given, in some cases we give it after 1 year.
Yes.
In those cases which we give at 1 year or later or at 2 years, the first dose, is the failure rate less or same?
That answer is not there in the trials, but if between 6 months to 2 years, if you have delayed your dose, you will have an incidence of typhoid in 500 out of 100,000 children. So I think it's not worth doing it to have little less efficacy at 6 months and 9 months, if at all, and trying to expose them, especially if they are on top feeds, they can get typhoid. So I would stick to 6 to 9 months as starting the first dose.
And about even in that TCV study, they subdivide the 6 to 23 months into 6 to 11 and 12 to 23 months, and they showed that in both the groups, immunogenicity is similar. There is no difference whether you give it at 6 months or you give it at 20 months.
So your question whether there will be more breakthrough if you are given at 6 months versus 2 years is not true. Not on immunological
If
basis.
we give the vaccine first dose after 2 years or in adults, will the second dose be recommended by you?
I would always give the second dose 3 to 5 years after the first dose. Is my personal take. As I said, I have very little evidence to show, but I am convinced till the time data is there that the first dose breakthroughs are not that great, I would continue to use 2 doses. This is my take. It's completely personal take. It's contrary to what the IAP is saying. What IAP is saying is perfectly all right. It's almost the same as what WHO is saying. Public health perspective, it makes sense to give 1 dose because you are saving so much money. Like just to give you an example of conjugate pneumococcal vaccine, UK today gives only 1 primary dose and a booster early at the end of 1 year. So, public health always will look at the effectiveness of the program rather than individual.
Is the first dose taken as a vaccine failure or a drop in seroprotection? In those who get the disease...
Anyone who is vaccinated and a month after that, if he gets typhoid, is a vaccine failure. Last comment.
So we can take the questions in the 45-minute session. We have it
please
for...
Please reserve this question for the, otherwise there will be no one left at the end of the day. Thank you very much.
We have 25 minutes of tea break as well. So please. We'll start. Thank you all. So our next topic is safe and thermostable, a dream or a reality. So for this, I would like to invite Dr. Rajesh Kasla. He is a consultant pediatrician who is working in Neon Hospital, Malad, and he is an EB member of IAP Mumbai. Thank you, sir.
Thank you, Dr. Tanushree. After listening to stalwarts in vaccinology.
So Rajesh, before you start, this is an introduction, a new form snippet, just 10 minutes, very focused topic. It's not like a vaccine, but a part of the vaccine. It's an experiment, I hope it's successful. There are 3 such snippets. One is the second will be on 1 versus 2 versus 3, and the third will be every 10 years, are you crazy? I won't tell you the which vaccines, but this is the first snippet.
After listening to stalwarts in vaccinology, here comes a 600 seconds snippet from a practicing pediatrician, and the topic is safe and thermostable stabilizer a dream or reality. Now, when as a practicing pediatrician, we vaccinate our patients, we are worried about two important things. One is the potency of the vaccine and whether the vaccine that we are giving will cause any adverse effect after the immunization. Now, we all know all our vaccines are currently available are to be stored safely between the 2 to 8 degrees centigrade with an average shelf life of around 2 years. The vaccine potency once lost cannot be restored. Even one small exposure to ambient temperature will cause some degradation, and multiple exposures will just lead to the cumulative effect and will cause damage to the vaccines. Vaccines are sensitive to heat at different degrees, but not to mention even the cold injury is going to cause similar damage. Live vaccines are more susceptible to the damage. Now, this is a chart which we all know, and it shows the sensitivity of different vaccines for the heat, and this is for the freezing. So now, to prevent this particular damage, the thermal damage to the vaccines, what can we do? So there is a role of stabilizers. What are stabilizers? Stabilizers are additives which are added to the vaccine formulations, which will improve the vaccine stability during the manufacture, storage, transport, as well as at the time of administration. What does stabilizer do? Stabilizers will inhibit the chemical reaction, will keep the vaccine homogeneous even throughout the storage. It will prevent the vaccine components from getting separated and sticking to the walls of the vials in which the vaccines are available. The commonly used stabilizers right now are gelatin, monosodium glutamate, trehalose, and formaldehyde. So I am going to talk more about gelatin and trehalose. So let's first talk about gelatin. Now, gelatin is a partially hydrolyzed collagen. It has a very typical gelling characteristic which prevents the inactivation of virus due to the thermal changes. Unfortunately, most of the serious adverse effects amounting to anaphylaxis are due to gelatin and their peptides. Almost 80% of the children who has developed anaphylaxis after vaccination were found to have anti-gelatin IgE antibodies. And gelatin is right now used in a lot of vaccines that we are using: DTaP, measles, MMR, varicella, JE, and rabies vaccines. In Japan, in the year 2000, when they found out that there was so much of vaccine-induced anaphylaxis due to gelatin, they have sort of discontinued adding gelatin to all the live virus vaccine, and from that time onward, the incidence of anaphylactic reactions have significantly reduced. The second stabilizer is trehalose. Now, trehalose is a disaccharide with a very strong glycosidic bond. This is a chemical structure which helps this stabilizer to have its effect. It withstands a lot of environmental stress, whether it is freezing, drying, or even excessive heat. It protects the cellular integrity of the live virus vaccine especially, and it prevents those three-dimensional structure of the antigenic proteins. It prevents denaturation, degradation, and aggregation during the storage and the transport. Now, we all know that most of our live virus vaccines undergo a process called as lyophilization. In lyophilization, exactly what happens is water is extracted from the vaccine, and this is done by giving a lot of pressure on the vaccine, and this is happening at a very temperature from 20 degrees to almost minus 60 degrees and back to 20 degrees. So when such a huge thermal stress is going on, there is a very good chance that the potency of the vaccine or the antigenicity will be at stake. Here, we add a stabilizer like trehalose. Now, what does trehalose do? Trehalose is one stabilizer which has a very high glass transition temperature, in the sense that it can withstand such high changes in the temperature and prevent the antigenicity of the vaccine. It is one of the preferred disaccharide. There are other disaccharides also like sucrose, maltose, etc., which is added to as a stabilizer. But trehalose is much preferred because of this high glass transition temperature. Now, what does I mean by this? This trehalose basically forms a glass scaffolding around the antigens. Now, so this is trehalose. which forms the glass scaffolding around the antigen, and it prevents the effect of all the thermal stress, whether it is cold stress or the heat stress. And something similar is shown with another stabilizers, where the bond is not so strong and there is a good chance that there can be a thermal damage to the vaccine or the antigens. As I told you, it forms a glass scaffolding. It is a non-toxic stabilizer. It is non-hygroscopic disaccharide. Now, these tree halos, as I told you, the proteins which are there, it doesn't get damaged even when the vaccine is freeze-dried. It doesn't get denatured, and there is no degradation during the transport as well as storage, so that the vaccine maintains its functionality. Tree halos has been proven to protect the antigens. The damage to the proteins has been prevented and retains the efficacy of the vaccine to almost to the tune of 90%. So much so that if the vaccine is exposed to the temperature of almost 70 to 80 degree, tree halo still maintains the secondary structure of the proteins. Mind you, this does not mean that we should expose the vaccines to these high temperatures. This is just in case of some accidental exposure, the stability of the vaccine will be still maintained because of this good stabilizer. As far as the vaccine storage is concerned, we just discussed that most of the vaccines, the shelf life is around 2 years. But the study has shown that by adding tray halos to the vaccines, the vaccine stability has, the shelf life has been increased to almost 3 years. And even at the end of 3 years, when the potency is checked, the potency is the same as it was at the time of manufacture, even at the last day of the shelf life. Now, we spoke about the vaccine when it is manufactured, vaccine it is transported, stored, and then what happens at the time of administration, which we all do. At the time of administration, we have to reconsider all our live attenuated vaccine which are available in the powdered form. So we add diluent to it. When we add diluent to it, so there is a very good chance that we may happen to damage the antigenicity of the vaccine, and the efficiency of the vaccine or the potency can be compromised. Now, exactly here also the tree halos works. I already discussed that it forms a glass-like scaffolding around the antigen during manufacture itself. When you dilute, when the water is added to this particular dry powder, it has got 2.5 times larger hydration volume. By that, what happens is the water which we inject as diluent gets absorbed in this glass scaffolding, and it forms a very viscous solution in which the antigenicity of the vaccine is well preserved as compared to other vaccine stabilizers where there can be still amount of gaps and the antigen can be destroyed at a time of reconstitution. At present, tray halos is currently used in 2 vaccines in our country. One is in rotavirus and another one is varicella virus. You can see that the tray halos is being used over here as well as here. And it is now even issued, the FDA has issued it as a generally recognized safe stabilizer to be used in the vaccine. So while there are many stabilizers available, tray halo stands out amongst the rest of the stabilizers because of its unique properties. It has got longer shelf life. It maintains the structural integrity of the antigens. Nearly 100% antigenicity is maintained. It maintains the vaccine's efficacy and stability even at varied temperatures, and anaphylaxis reactions are very negligible. So having a safe and thermostable stabilizer is now a reality with tray halos. Thank you. I saved 30 seconds.
Thank you so much. Thank you for that wonderful. It's always difficult when you have to stop in 10 minutes. So for our next talk, we have a dialogue. Sorry, sir. So I'll ask our EV member. Okay. Yeah, I'll ask our EV member, Dr. Shikha, to please give a memento to sir. Thank you, sir. Thank you. Dinesh. So our next talk is common vaccines. So our next topic is common vaccines, confusion and consensus. We have 5 vaccines here: PCV, BCG, varicella, IPV, and rotavirus. This session has been brought by unscientific grant from Novo Mediscience. And for that, we have our moderator, Dr. Rajesh Chokhani, sir, and three eminent panelists, Dr. Suhas Prabhu, Dr. Vijay Avle, and Dr. Praveen Mehta. Our moderator, Dr. Rajesh Chokhani, sir, he is a consultant pediatrician in Hinduja Hospital, and he is the current president IAP Mumbai of 2022 and 23. And he's co-author of a book that we have all learned, Lessons on the Grand Round. Welcome you, sir. Our next panelist is Dr. Suhas Prabhu. And sir is as a working consultant pediatrician in PD Hinduja Hospital, an ex-ACVIP member, and he has many scientific convener and the writer of the multiple modules, and he has many articles, international and national articles. Next panelist is Dr. Vijay Avle, sir. He's a consultant pediatrician and director of Dr. Avle Multispeciality Hospital, and he is also attached to Apollo Hospital. He is the head of the Apollo Hospital, Navi Mumbai, and he has been an ex-IAP president 2014 with multiple publication in his name. And last but not the least, Dr. Praveen Mehta, sir. So he's a very senior consultant, and he has a very special interest in vaccinology. He's working in Jack and Jill Hospital, Ghatkopar. He's also an ex-ACVIP member and faculty of the multiple vaccinology program. So welcome you all. Thank you.
Hello. Very good morning to one and all. When we talk of confusion, a fact is that my wife is always right and I am always wrong, at least in front of my wife. Now the confusion is when I tell her she is right, am I right or wrong? Audience, what do you think? I'm right or wrong? So one thing is clear, this thing will always remain confused and there will be no consensus. The second thing that is clear is that what is a consensus sometimes when everyone agrees to say collectively what no one believes individually. So this statement holds true. You know, we don't believe it individually, but in public we will say, yes, we believe in this. But on a more serious note, we are here to discuss vaccines today. And that is because medicine is the only profession that labors incessantly to destroy the reason for its own existence. And friends, you'll all agree that in our day-to-day routine practice, usually there are good days, bad days. Some days are very serious and drab. And then occasionally comes a comic relief like this, when a parent describes that, doctor, my child has unlimited free outgoing with different ringtones. So this is describing diarrhea. So let's discuss rotavirus vaccine. So there is a lot of confusion about the age limits when it can be administered. So Vijay, can you take up that?
Yeah, so we have 4 licensed rotavirus vaccines available for use in private practice. 2 of them are used in National Immunization Program as well. When it comes to following an individual practice, I would strictly recommend to follow the recommendations made by the ACVIP, that not to give the first dose beyond 14 weeks and 6 days, and not to delay the vaccine beyond 32 weeks. However, if you look at the Government of India recommendation, in the public health program, the upper limit has been relaxed up to the age of 12 months. So much so that if a child happens to take the first dose at 12 months, it is said that the remaining 2 doses can be given in the second year of life also, that 4 weeks from the 4 and 8 weeks after 12 months of age. Now, why is this relaxation made? If you look at the, first of all, why is that restriction? Because rotavirus carries the baggage of intussusception as the risk following vaccination, especially the first dose, within 2 to 3 weeks of the first dose. The two first licensed vaccine, that is Rotarix and Rotatec, it underwent huge trials, and it was studied for intussusception. Based on the background of a huge risk of intussusception following the rhesus reasserted rotavirus vaccine. So just to avoid the risk of intussusception, that restricted window was advocated. However, if you look at the burden of diarrheal disease and deaths, especially in developing countries, it is too huge. So what they observed over a period of time, that even if you relax the age window, the benefit of saving children of diarrheal deaths is far more. It outweighs the risk of intussusception by relaxing this age. And that's the reason why Government of India has gone a little lax, and we have recommended that vaccine can be used up to the age of 1 year. However, I repeat that in private practice, please follow the recommendations on the product insert and the recommendation made by the ACVIP. It is said that for about 150 diarrheal deaths saved because of extending the age window, you have only risk of about 1 intussusception. And in this today's era of diagnostics and therapeutics, that intussusception should not lead to any mortality.
I would just like to add one thing. This first dose restriction can be extended for Rotarix because we are giving only 2 doses. So you can give the first dose as late as 23 weeks and 6 days or 24 weeks. So you have this opportunity once you have a patient who come beyond 15 or 16 weeks and not receive the rotaviral vaccine. You have the option to give the Rotarix vaccine. You can complete 2 doses before 32 weeks.
And so, Suhas sir, now we have these usual problems. What if the child vomits or has gastroenteritis? Should we give the vaccine? And should we give it again if he vomits?
This happens pretty often. Of course, if the child already has gastroenteritis, it's not a good idea to give him the vaccine. But sometimes you don't know when he comes to your clinic, and the mother says later on he develops a little bit of diarrhea. Vomiting is fairly common, not that common because the vaccine is sweet. The question is, you want to know whether the vaccine needs to be repeated. Is that the question?
Yes, sir.
If you look at the manufacturer's recommendation, they will say repeat if you think the vaccine has come out. But I do believe that this is a live virus vaccine. Even if a small amount remains inside, the virus is going to multiply and it will probably protect your child. So it's not my practice to repeat the vaccine. But again, we are going to have a consensus, all three of us.
Yes,
right?
sir.
There is no confusion.
Thing is, sorry,
I said there is no confusion.
No, IAP, ACVIP clearly recommends that there is no need to repeat it. That is one. Only problem is the leaflet of RV1 rotavirus vaccine mentions that you should repeat it.
Correct. And there is another leaflet which mentions that you may repeat at the discretion of the practitioner.
Right.
So basically sitting on the fence.
Right.
So,
but IAP has made it very clear that it need not be repeated.
so IAP and this consensus team says don't repeat. Now 2 doses or 3 doses, Praveen Mehta sir?
For RV1, obviously 2 doses. All other vaccines have 3 doses, which are licensed in India.
First one RV1, second one RV5. 2 doses or 3 doses?
Then 3 doses.
Okay.
Because when you don't know what was the first, in fact, ideally we should not be changing the brand. But if you don't know that what was the first dose or you are not able to find it out, then in that case we have to give minimum 3 doses.
So you said you should ideally not change the brand, but suppose that brand is not available, then do you have to restrict your choice or anything is fine?
If you don't know, then anything is fine, but you give minimum 3 dosage.
Okay.
It again depends on the age the child comes to you. If he's taken the first dose and you don't know which brand it is and he comes to you at around 23 or 24 weeks, you will have to give him Rotarix because you need to finish 2 doses. You can't give him 3 doses if you start Rotatec or the other brand.
So each will follow the principle of not mixing by choice, but if you are pushed to the wall, for all vaccines for that matter.
Suhas Prabhu sir, what about the efficacy of rotavirus vaccines in general?
If we look at the data, and I must mention the data is not really comparable, because 2 of the brands don't have efficacy data from India. If you look at the original data of the Rotatech, the original vesicary study from Finland shows about an 88% efficacy. The efficacy in the Western countries, in the US, is near 90%. Latin American countries is 80%. So we do believe that there is a difference in the efficacy of the vaccine depending on the population and the environment that we see. So we don't really know what is the efficacy of those vaccines like Rotatech. In India, we don't have a data. On the other hand, we have efficacy data for the other two Indian brands, and they appear to be much lower. And so the question will come is, are those vaccines better than us? It's difficult to give you a definite answer, but I would rely on any brand, because one thing, as was mentioned, as Dr. Vijay just mentioned, is that in our country, with the high burden of disease, it is more important to give whatever is available, whatever may be more affordable, and to protect the larger number of people in the population. So I think, look at the efficacy data, keep it aside, use any brand that is available. I would be happy with any of them.
Because the number of diarrheal deaths prevented is so huge that we don't go into little bit of difference between the efficacies of the different brands. So use anyone which is available.
Sure. So at this point, any questions on rotavirus vaccine from the audience? Yanit.
So while there is no data on Rotarix and Rotatech from India, but there is data on Rotarix and Rotatech from developing countries of Africa and Asia. And if you look at the same Rotatech with 98% efficacy in USA, the efficacy in Mali was 18%, 1-8. So it is country specific rather than vaccine specific. So to my take is that all vaccines have the similar efficacy based on which country you are using it.
So literature says group of country specific or country specific. So well developed and less developed nations.
Just to give a simile that for 85% efficacy in Latin America, for 100 vaccinated, one child was prevented from getting severe rotavirus gastroenteritis. That in Malawi with 50% efficacy, 6 children were prevented from getting the disease. So it's not just the efficacy. It's
Yeah, so I think the other issue about efficacy, as Nitin sir is saying, is that you're talking of severe rotaviral gastroenteritis prevention, which is better than not getting a disease at all. Any other questions from?
Yeah, may
So, Rohit, 1 minute, online and then you. Yeah.
So there's one online question which is asking 6 weeks first rotavirus vaccine given, then no follow-up till 6 months. How many doses more?
2 more doses.
2 more doses of RV5. Yeah, Ruth.
Yeah, no, this is a comment to us. You said ki up to 26 also, the first dose is okay for Darix.
24.
24. The problem is that the whole philosophy of rotavirus vaccine is to prevent, of course, a death, but the natural infection also gives a protection for the second and the third severe. So if you wait for 24 weeks, already the baby has already...
No, Rohit sir.
I'm saying if the patient has missed and come to you in 24 weeks,
so,
your option is to give Rotarix.
Redundant, because by the 24 months, what you will prevent? There will be no severe diarrhea. Whatever the attack will be, it will be very minor and mild attack will be there. So the basic effectivity or whatever the importance of vaccine becomes redundant if you, if
Agreed, Rohit sir. So I think sir made a point that if someone comes beyond that 15-week window, instead of telling him that I can't give you the rotavirus vaccine anymore, you may choose to give Rotarix. That's the point. Yeah.
Sir,
okay, let's move on. Yeah.
Product insert of Rotacell says it can be used till up to the age of 1 year.
That's what we discussed. No? So ACVIP is 8 months, that is 32 weeks. One literature says 1 year, WHO says 2 year. All that is based on balancing intussusception versus severe rotaviral diarrhea deaths.
Government of India is a national program, but Rotacell is a product insert. Can be used.
Correct. Yeah. So I think the safest for individual practitioners would be to follow ACVIP guidelines.
Right, agreed.
Valid, yeah.
That if a patient has come late for the third dose, if he has taken either Rotatech, Rotavac or the third vaccine, Rotacell, then he cannot take the third dose. But if he has taken Rotacell or he can...
Give him the mic now, please.
What Alok is saying that by product insert and the DCGI approval, There is only one vaccine, which is Rotasil from Serum, which has approval to be used for the last dose till 52 weeks, not the first dose. So suppose someone has taken 2 Rotatec and now doesn't come for the third dose before 32 weeks, then technically you can't give the third dose, but here you can give him the Rotasil third dose and give the benefit.
Yeah, but again, by the product insert, but not by ACVIP.
No, ACVIP has no say if there is product insert which is DCGI approved. ACVIP will come if there is a confusion for the product insert.
Okay.
Like suppose for your HPV
ACVIP
vaccine,
wants to comment on this?
whether HPV-9 can be given to anyone, whether HPV-9 can be given to...
So if I am taken to a court of law, product insert will supersede ACVIP?
Yes.
ACVIP
Yes.
may not be able to protect also. It's
Okay.
just a recommendation. This is approval.
Okay, okay.
Nitin, my question to
So
you,
can
do
we
you
have
vaccinate a child who comes to you at 10 months of life with rotavirus vaccine? Yeah.
Okay, let's move on. This will be endless. We'll move on if we have time. Rotasil, first dose 12 weeks.
So Rajesh, I can conclude saying that the product instead of Rotasil is licensed for use up to 12 months of age. So medico-legally, you are safe in using this vaccine beyond the recommended age group of 32 weeks by the ACVIP. However, as Rohit said, as the age advances, the natural infection has occurred almost in all children, and the subsequent infections are mild. So it really doesn't make much immunological or protective sense in offering this vaccine at 9 months.
Sure.
So,
okay, now, yeah, we'll have it later.
So one last. So previously RV1 was recommended only up to 6 months. So has the recommendation changed? Because
Sir just said, no?
Because it was...
Suhas Prabhu, sir.
No, see, the question is, can you use Rotarix beyond 6 months for the last dose? Because their study shows that the last dose is always before 26 weeks. But the WHO and SCPI says, irrespective of brand, the last dose can be up to 32 weeks. So their SCPIP will help you.
But you said that is not valid. The package insert count supersedes ACVIP.
Right. Product insert of Rotarix doesn't say that first dose can be given beyond 14 days and 14 weeks and 6 days. If the last dose is before 26
Precisely.
weeks.
So why you use it then? You just because
I think we'll discuss all this in the next session.
But remember, wife is always right.
Now, is it too old to be even told to the patient to take? Or it's old, may not be gold, but can't yet be sold or discarded off? And we are talking of BCG vaccine. So now, does it give protection against TB? Conflicting reports. Suhas Prabhu, sir.
If you look worldwide, the data, it talks about BCG will protect against tuberculosis in only about 50%, 50-51% depending. But it does seem to have a higher efficacy of protection against more severe disease, like for example meningitis or disseminated tuberculosis. Yet, for want of a better vaccine, we have been continuing it. So, what more you want me to say on this? So,
no,
in
so
spite
we
of
can't
the fact that we don't have data of good protection, this is what we use, but there is a case for getting a newer type of BCG, which will probably give you better protection, and that's why there has been research going on. There are a couple of...
So, sir, what is recombinant BCG, and is it expected to be better with respect to tuberculosis?
Okay. Now, what happens in the BCG vaccine, we know it's a bovine Mycobacterium tuberculosis that is attenuated by 230 passages. Now, during these passages, there is, of course, a natural mutation, as well as because of the recurrent passages, there is a change in the DNA structure. So if you look at the DNA structure of the BCG virus compared to the original bovine strain, there are a lot of deletions in the genes. And there are various nomenclatures for that. The most important one is what is called the RD1, which in fact has got deletion of so many genes, including the ESAT gene and the CP10 gene, which is the one that we use in the quantiferon gold. So that brings the issue of whether the BCG vaccine is less efficient, because these genes have been deleted. So what the companies have done is they have done recombination by trying to add, in recombination they've done two things. One is they've tried to add these genes that have been deleted, and also they've tried to make the vaccine such that the genes are expressed to a larger amount so that it will improve the immune response. So this is what RBCG basically is.
Sir, is RBCG being explored for prevention of other illnesses?
No, see, basically this is developed in Germany, and now the Serum Institute has taken over it, and they are mainly trying to fill the gaps which are there in the BCG. For example, BCG is not protecting against the latent tuberculosis becoming active. So now there is a phase 3 trial going on in India, which is looking at two aspects. Number one, it is looking at the trial is going on for preventing the tuberculosis in the household contacts of open tuberculosis. And that is to find out whether this RBCG is useful for preventing the tuberculosis in the contact person. And the second trial, which is in the third stage, which is going on in India, is for fully treated and cured pulmonary tuberculosis cases. They are being given this vaccine to see whether any reactivation occurs or not. These are the two fallacies with the current BCG which we are using, that it is not able to prevent reactivation of a latent TB, and it is not able to prevent the transmission. So both these aspects are being looked after in this phase 3 trial, and also there is a third trial which is going on in South Africa, where they have introduced RBCG in their national immunization program. And once the data comes from all these 3 trials, we will be able to find out that whether the RBCG is superior in preventing the transmission as well as in prevention of the activation of the latent tuberculosis. And once that comes, of course, as far as the immunogenicity and safety is concerned, it has shown that the severe side effects are much lesser than BCG. Then also the immunogenicity up to the days 14, it is very good. But beyond 14 days, the immunogenicity of RBCG is lower than our conventional BCG. But as this new guidebook has already mentioned, that RBCG immunogenicity, although it is lower, it cannot be correlated with the actual real world effectiveness. And that will come when we get the results of all these 3 data. And we are hoping that if the phase 3 data is showing good results, probably it is going to be a good replacement to the conventional BCG.
Thank you, sir.
Dr. Chokani, I think the question really was about preventing other illnesses.
Yes, sir.
We know that BCG has immunomodulatory and immunostimulatory effects. There is a data originally from, I think it was Malawi. When they gave neonatal BCG, there was a decrease of 40%, not only in tuberculosis, but other infections, neonatal sepsis, and so many other things. So the question comes whether BCG can be extended to protection beyond tuberculosis. I think we all know, the jury is still out. I don't think we have enough data on this. But I think we all remember 2 or 3 years ago when people said that BCG might help to protect you against even COVID.
Yeah.
And that was the reason why some countries did not get. Yeah. But I think
so I think they're exploring it as a vector also for other illnesses. So, but all that is still experimental. Vijay, should BCG be offered to an older infant or child who has missed it in the newborn period?
See, as said before, BCG primarily is a good vaccine to prevent severe forms of tuberculosis, which are likely to occur until the age of 5 years also. That is the basis of recommending this vaccine up to the age of 5 years. So if a child has missed and is below 5 years, it is worth offering this vaccine.
Few commonly asked questions. There is no scar visible of the BCG vaccine. Should we repeat, Vijay?
It does not necessarily mean that the BCG has failed. However, that's the only visible or easy way of making out if the child has received BCG or not. And if the there is a recommendation to repeat it once, you wait for 12 weeks, and if there is no scar, you repeat it. And if it doesn't, induce scar by giving it second time, you don't repeat a third dose.
Do we do a tuberculin test before repeating?
No, there is no need to do it.
There is one interesting study which is published in Indian Pediatrics and which has been quoted in this new purple book about the scar. that one Dr. Rani et al. Has done the study in 655 BCG vaccinated children, out of which they found that only 10% did not have scar, and those 10% they have studied the response to PPD, and they have also studied the response to lymphocyte inhibition migration test, and found out that 90% of them had good cellular immunity and also good response to PPD. So out of 655, there were only 5 children where they failed to demonstrate the immunogenicity without the scar. So absence of scar, the message is very clear that the absence of scar does not mean there is no immunity.
Sure.
But since we don't know that which are the 5 children who will not get immunity, we can very well repeat, but not more than twice. If the second time also the scar doesn't occur, then we don't try anymore.
Sure. Vijay, a few rapid fire. If baby is LBW or preterm, when to give BCG?
Reasonably stable for discharge, that time you can give BCG.
So no weight criteria, no age,
28
gestational
weeks
age.
is good enough. 1800 grams they say.
1800
has been mentioned. But
Asymptomatic baby born to mother with bacteriologically confirmed TB. Should I give BCG?
Yes.
I will be also
before
giving
that-
prophylaxis.
But before that, you investigate that child is not active. Having
Agreed,
active
agreed.
tuberculosis.
But suppose the
If
child
it is
is-
normal, give isoniazid 10 milligram per kg and also give BCG vax.
Suhas Prabhu, sir.
Yeah, no, I just want to add that even if you are treating the child for tuberculosis, you can still give BCG.
So whether you are treating, whether you are giving prophylaxis, you will still
You will
give
still give
BCG.
BCG.
Okay. Infant born to HIV positive mother. Suhas Prabhu, sir.
Yes, of course we can give.
Okay.
See, there is, I would like to give comment on this, that there is, if you look at the IAP guidelines, it is very clear that asymptomatic you give and you don't give in symptomatic children. That is what the IAP guidelines. But we have heard Dr. Nitin Shah several times on this, and he has been quoting a study from Uganda, where asymptomatic children who were BCG, who were HIV exposed, were given BCG, who later on developed severe BCGosis. And therefore, I will not be surprised if in future ACVIP comes out with the guidelines that you wait for 15 days, do a PCR, if the patient can afford and if the facilities are available in a remote area from where the patient is coming from, and if PCR is negative, then give BCG.
Okay.
I would only add to it that with the PPTCT program, the risk of transmission is almost negligible. One. Secondly, in public health program, no such facilities available. So in the larger interest of the community, I mean, it is most of these babies born to HIV positive mothers are asymptomatic and they are immune preserved. So that is why the recommendation comes of giving it to asymptomatic newborn at birth.
I would think even if they are PCR positive, are they immunocompromised is the question. Which at
No,
birth-
then you look at the CD4 count. If it is more than 15 to 25, then give it.
No, they may not be immunocompromised, but what has been observed in Uganda, that over a period of time, the risk of developing BCGosis is higher in
Mic
infants
to
who were
Dr.
born-
Nitin Shah, please.
Yeah.
No, he raised his hand. Don't think I am overruling these experts.
No, what I am trying to say is what Praveen said is very right. That the study done in Uganda and African countries showed that children were exposed to HIV positive mother, not proven whether they were actually infected or no. At that time there was no PPTCT program, so you would expect 1 in 3 of such children to be actually positive. When they were given BCG at birth, when they were asymptomatic and completely immune preserved, if they later on subsequently were proven to be HIV infected, they develop late BCGosis because the BCG remains dormant in the body. So it's not a question of whether when you give CD4 count is normal or no. It will be always normal at birth, right? So that is the reason why they had an advisory saying that do not give BCG unless proven the status of the child. But as Vijay said that now today with the strong PPTCT program, the efficacy of PPTCT is 98% prevention. So for the remaining 2%, you can do a quick DNA PCR
Sure.
in your private practice. Within 15 days, you can do it and then prove either way and then go ahead with BCG.
Sure. So neonate given IVIG, yeah, we can still give the BCG vaccine. Now we move on to the next vaccine. So we generally say more the merrier. So with respect to the pneumococcal vaccine, we pediatricians are definitely happy that there are more players in the market and it's helping us. But there are other issues about being more the merrier. So are more serotypes covered, does it mean better, yes, no, etc.? So let's discuss that. So Suhas Prabhu sir, PCV10 versus PCV13 in the Indian context.
Okay, I'm glad you said Indian context, because you really need to see what your prevailing serotypes are to say whether a vaccine is good for your particular community or children. So if you look at, there's lot of data now on serotypes, and without going into the details of those studies, PCV13, the 3 additional serotypes, now again it depends on which PCV10 you're referring to. There is an additional maybe 7 to 10% coverage for the additional 3 serotypes that are not present in the PCV10 of the other 2 companies. So to that extent, 7%, 8, 9, 10%, it is better.
So the difference is narrower with the newer PCV10?
Yes, it is narrower with the newer PCV because it includes 6 and 19A.
Fine. So the difference is marginal with the newer PCV10 versus PCV13. Now we know that there are 2 schedules proposed for PCV10. One is in the public sector, one is in the private sector. So which schedule is better at an individual level?
At individual level, of course, it is 3+1, that is 6, 10 and 14 weeks, and a booster at around 15 months of age.
So sir, why is the schedule different in the public sector?
Because they are looking at the mass coverage. If you really have a coverage, for example, many Western countries are also following 3-dose schedule, particularly in UK, because they expect the coverage to go up more than 80-85%. Some countries are even trying only 2-dose schedule and getting good results, but it all depends on ultimately what coverage. For an individual patient who is sitting in front of you in your private practice, the best schedule is 3+1.
I think, if I may add, we know that PCV has a herd immunity effect. So as Praveen rightly pointed out, if you're using it at a country level as a universal immunization, probably less doses may work.
So more the coverage, more the efficacy of those less doses. If patient has taken PCV10 with the BMC, should we suggest one more dose?
Ideally, yes.
At what time?
It depends on when the 2 doses. You give minimum 4 weeks interval after the second dose.
So ideally, immediately after the second dose, 4 weeks later, you suggest a third dose. Now, many times or sometimes there is a mixture. So there is a PCV10, if it is followed by next dose 13 or vice versa, sometimes happens. What will be the impact? Vijay?
So in general, by choice, don't do this. If you push to the wall, yes, you can do it. Usually what is observed is a higher valency vaccine is given following initial dose of lower valency vaccine. The GMCs and the are better. So if you have a choice, it is better to use a higher valency vaccine on the child who has received lower valency vaccine. So PCV13 followed by PCV10. However, I mean, PCV10 followed by 13. This data comes from countries where there have been switches from 10 to 13 and other way. These countries also have used PCV7 in the past. So it is very difficult to draw conclusions on the effectiveness of such mixed schedule. But again, I repeat that in general, the higher valency vaccine in a child who has received lower valency vaccine is preferred over lower valency vaccine in a child who has received higher valency vaccine.
Mic to Dr. Sudhirya.
Yeah, I just wanted about this question which patient comes with doses taken at BMC. When is the appropriate time to give the vaccine? I think it should be after 15 to 18 months when primary series over with PCV10. That would make more sense because, these patients, when they are given at 1.5 months and then 3.5 months and 9 months, then they might have kind of no booster effect later on. Would that?
I agree with you.
No, Sudhir, the pneumococcal disease is concentrated in the younger age group. So you live with 2 primary doses. There is a risk that the child may not be adequately protected in that window between the second and the 9-month dose.
Now the question comes, if the child comes to you at 10 weeks, do you give him the middle dose? Because he's going to get the third dose at 40. Are you going to say wait till you're here?
No, if I give middle dose, then I switch to 15 months as the third. No, fourth dose I switch to 15. So important is to give 15 months dose rather than, that's what, because see, remember when PCV came first, the guidelines were to give it at 18 months of age booster. Then subsequently they reduced between 10 to 15 months because they saw resurgence or more cases of pneumococcal infections between, late in first year of life. And they thought that might as well give between 12 to 15 months.
So if a patient comes after finishing 3 doses in BMC, then ideally I agree with you that the 4th will come in the 2nd year of life.
No. So Sudhir's point is that even if he comes after 2 doses, I will tell him come at 18 months again. Suhas Prabhu sir, you wanted to say something? No. Kasi sir.
I think in every forum there's a lot of discussion about this NIP versus Indian schedule versus the recommended schedule, or what I say is the Western schedule. Now please remember, efficacy studies are there only for the 3-dose primary schedule. All the 2-dose schedules are based on immunological studies. The WHO has published a very good paper way back in 2017 about scheduling of PCVs. What they found that with 2 doses, the antibody titers against all the pathogens are almost similar whether you give 2 or 3 doses, except for 6B and 23F, where the difference is more than 10%. This difference disappears by the time it comes for the first booster, and following the first booster, there is no difference. The second thing we need to remember is we are talking about antibody titers. These antibody titers were done when we were using the polysaccharide vaccines, which elicited much inferior antibodies. With the conjugate vaccines, we are getting antibodies with much higher avidity and affinity. So this 0.35 was true for the polysaccharide. It may not be true for the conjugate vaccines. At much lower titers, they may be effective. Now, I personally feel if someone has taken a 6 and 14 schedule and comes at 9 months for the booster, I think nothing is going to be served by giving an additional intramuscular dose.
No, so the debate here is, we'll stop this debate here, but if I understand right, the debate here is whether the 2-dose primary schedule is slightly inferior to the 3-dose primary schedule, or what Sudhir is proposing. So will the 9-month dose be taken as part of the primary if you give the 18-month thing? So there the 9-month is a booster. So the 18-month becomes a kind of a second booster rather than 9-month being a primary. So that's the difference we are discussing. I think we'll move on. If only 1 or 2 doses have been taken, will it provide some protection? It is already answered indirectly. Suhas Prabhu sir, something about PCV 14, 15, 20, which we believe are coming.
Yeah, 14 is supposed to come to India, and I think, just 2 days ago, the PCV 20 has been licensed for children. It was licensed for adults a little earlier. So obviously, like we said, it will depend on what is the serotype prevalence in your particular country. We need to check whether PCV 20 will be really better for us than PCV 13, depending on the serotype coverage that we have. But like you said in the beginning, more is merrier. We don't know what the price difference is going to be, whether it will be worth giving a 20 valent if the price difference is very much. But if the price difference is not much, I think there is no reason why you should not go for the 20. In the US, they're talking about 20 replacing the 13 completely, just like the 13 replaced the 7.
Only 1 or 2 points that PCV 14, even though it is higher valent than existing serums PCV 10, if you look at the total coverage, because of the absence of 6A, which according to this latest purple book comprises the 17% of the strain in India, the coverage is much more with a 10-valent serum vaccine compared to the new biological Evans 14-valent vaccine. This is a classical example to make a statement that valency alone does not matter.
Sure.
Regarding PCV 10, the big advantage which is going to be there for PCV 20 is that it will almost replace the polysaccharide vaccine, because the polysaccharide vaccine, see, there are 19 serotypes which are common between the existing 23 polysaccharide vaccine and PCV 20. Only 4 additional serotypes are there in polysaccharide vaccine, and compared to that, in PCV 20, there is 6A, which is not present in polysaccharide vaccine. So overall coverage, even though it is 20 valent compared to 23 valents in a polysaccharide vaccine, the overall coverage of PCV 20 is going to be much higher than PPV which is existing 23-valent vaccine. So I am sure that once the PCV20 gets licensed in India, it will be replacing completely polysaccharide vaccines, because there are a lot of advantages of conjugated vaccine, and also it will be overtaking the PCV 14, 15, 10 and everything. Only thing that we look at the price of that.
Yeah, it depends on the price.
So for high-risk cases, we all know that PCV vaccine has to be followed up by a polysaccharide vaccine.
But
now,
as Dr. Praveen said, not if it's 20.
Yeah, not if it's 20. Now we've got only 6 minutes left,
One more comment, that PCV20 was initially licensed only for adults in USA, but just 3 days back, they have got it licensed to be used in children also from 6 weeks onwards.
So request to experts, we've got about 6 minutes left. So we'll do a quick rapid fire to what is useful to pediatricians. And if the rationale behind it is very detailed, we can discuss it over the tea. So moving from the IM injection that occasionally triggered polio to the IM injection that consistently prevents polio. Now, if it is taken in BMC, we know it's given as fractional doses at 6 and 14 weeks. So should we supplement it with a full dose, and when, Vijay?
Yes, 8 weeks after the second fractional dose at 14 weeks.
But now with the third dose being given in the BMC setup, we don't require to add any dose in the primary series. Of course, the booster at 18 months and 4 years continues.
Sure. If taken 3 primary and 1 booster at 18, is IPV at 4 to 6 years important?
Yes.
Yes, it is extremely important because the immunity wanes.
Taken IPV but missed pulse polio, is it okay?
It's okay.
It's not okay because pulse polio prevents the transmission.
Right.
So is it okay for that patient?
Yeah, for that particular patient, yes, but not part
because
of the
parents are guilty of having missed it. Yeah. Vijay, place of standalone IPV in this era of combinations?
There are many children who take the IPV in the, IPV in the public sector at 6 and 14 weeks. You can use this full dose IM 8 weeks after the second fractional dose. The children who have not taken the 4th or 5th year booster, they can be given. Immunocompromised children who cannot be given the live vaccine and who are unable to afford the combination vaccine can be given the standalone IPV.
Sure.
Particularly at 4 years, 4.5 years, it is going to be very useful.
Vijay, can it be given to adults? There are reports of adults with polio abroad, and sometimes parents ask, we are going abroad.
Though not recommended at this point of view, I always remember Nitin's the famous quote that if there is a vaccine available, you please give 1 dose to all the adults in the family.
It will depend upon that adult's history in the past, that whether he has taken previously polio vaccine or not. If not taken, the product insert of PolioVac clearly mentions that you give 3 doses, 1 month, 2 months and 6 months. If the partially vaccinated adult is there, then give only 2 doses. And if fully vaccinated and going to an endemic area, give only 1 dose.
No, but I think this is a hypothetical question. There are only a couple of countries where now there is polio,
right.
so
Right.
let's not discuss this.
Sure.
Unless you're going to Afghanistan.
So we'll spend the last 3 minutes on chickenpox vaccine. This is known as the student's law of tension. Pressure is inversely proportional to the number of days left for the exams, where I will study tomorrow remains constant. So at my time, the exam going students' bizarre thoughts were, I don't mind getting these marks to escape that battle of scoring marks. But we now know as doctors that that's not true. So one most important question, when should we advise the second dose of the vaccine, sooner or later?
Sooner. Earlier is better than later.
Okay. Can it be given post-exposure?
Yes, of course, within 3 days.
Sooner meaning not earlier than 3 months.
Post-exposure?
Within 3 days, but you can give up to 7 days.
Can the vaccine lead to herpes zoster later? I think it was discussed. Nephrotic on steroids has not taken this vaccine earlier. When can we give it?
At least 2 weeks after he has completed his steroid course.
Means
sorry. Yeah.
For
4 weeks,
1
4
month.
weeks.
It depends on what is the dose which is going on. Below 10
If he
years.
is on the full dose, then yes, it is a long.
But when he is on alternate day, you can give it, or you have to wait for remission?
What
you
happens
can give
is
it.
when he goes off steroids, he's always on a lower dose. Nobody stops abruptly.
You can give it that time.
parents are not sure of their own vaccination status, should we measure their antibody levels or advise vaccine?
It's not cost effective to measure the antibody level. I will prefer to give it straight away.
Okay, plus that poke also.
Adults need 2 doses.
So friends, we have 2 types of experts. One, those who speak on a simple thing in such a convoluted way that at the end we are all confused and we feel it is our fault only that we are confused. But we had a wonderful set of experts who tried to straighten out some confusions, so much so that at the end of this session, all of us have started feeling we are experts. Thank you very much.
Thank you.
We added few confusions also.
Thank you so much. Thank you. I'd ask Dr. Shikhar to please give the memento to Dr. Chokhani, sir. So please give Dr. Subhash Prabhu, sir. Dr. Vijay Evle, sir. And Dr. Praveen Mehta, sir. Thank you. Thank you for the wonderful panel. There are a lot of questions in the tea break, I'm sure. Thank you. The tea break is only for 20 minutes. And please collect your...
I would request the delegates that they can collect their delegate kit, the exciting delegate kit, throughout the day from now on, from 203 IAP stall. So there are 2 stalls there. From one you get the delegate kit, and from the other one the purple book.
Yeah, there is no rush to take it, so you will get the bags throughout the day. Thank you. अच्छा सर बाकी के ये किट किधर है
डालेंगे. Sir, is this a passport protected? It's passport protected. Sir, का doc. अच्छा ठीक. So welcome back, delegates, after a good cup of coffee and tea. We will start the next session now. So we have the next session with our own Dr. Nitin Shah, sir. He'll speak on At Last We Can Prevent Cancers. And this has an unrestricted scientific grant by Serum Institute of India. Over to you, sir.
So friends, welcome after the tea break. Can we have silence, please? So I am filling up the gap because Dr. Hit Sharma, who was supposed to come and speak on behalf of Serum, because of some reason he is not able to come. So last minute I am given this talk. So again, my disclosures. Why HPV vaccine? I think that's the first question that you should ask. Now if you look at the age standardized incidence rates of cervical cancer in the world, these are very recent 2020 data, just accessed last week. You can see here, the ones which are red are the ones with high burden. And you can see here, India is all quite orange to red. So we have a very high disease burden in the country, next to what is seen in the Africa. And the necessary cause of HPV cervical cancer is HPV infection. 100% of cervical cancer are caused by one or other oncogenic HPV virus. But it's not only the cervical cancer, it's beyond. Vaginal, vulval cancers in women, penile cancer in men, and anal, oropharyngeal, and genital warts in both the sexes are also caused by either oncogenic or the warts by the benign, but very important, difficult to treat HPV infection. So you can see here, nearly 100% of warts are because of 6 and 11, almost 70% of vaginal, 50% of vulval cancer, 50% of penile and 80% of anal cancers are caused by one or other oncogenic HPV virus. And this is again a very recent data. You can see here I've accessed just last week. Age standardized rates of HPV related cervical cancer in women per 100,000 population. And you can see here, when you take the world, it's around 13.3 and India is 18. So we are having even more disproportionately higher incidence than the entire world is concerned. So that would translate into almost 600,000 cases of cervical cancer in the world, of which 1/4 are in India, that is around 100,000 plus. And out of deaths, no matter what you do, 50% is the mortality. So around 3,000 plus women die of cervical cancer, of which around 75,000 are from India alone. Next to breast cancer, cervical cancer is the commonest cancer in women at all ages in India. And you can see here with the age, the incidence or the prevalence of the cervical cancer rises very high in our community. And it's not only the cervical cancer, as I said, but you look at the anal cancer in women, vulvar cancer, vaginal cancer, and oropharyngeal cancer in women. They are anywhere from 0.5 to 2.4 per 100,000. May not be as dramatic as 18, yet not as less as we think. And look at the men, penile, anal, and oropharyngeal, around 3 to 5%, 3 to 5 per 100,000, which is again significant as compared to cervical cancer. So you have a vaccine which not only prevents cervical cancer, but it also prevents a lot of other cancers. And what are the types which lead to cervical cancer? You look at, this is the cumulative increase in the coverage as you keep on adding the oncogenic virus. The common is being 16, and then the 18 two together is 83.2% in India, unlike 72% in the world. And you add the remaining 5 serotypes which are there in the nanovalent vaccine, that is 33, 35, 45, 58, and 52 and 58, there's a spelling mistake. It almost takes you to 98.5%. We have vaccines which prevent 80 to 95% of cervical cancer, and you still don't give it, I think is a crime. We owe it to women of our country that we do 2 things for them. We do a mammography, and if possible a sonomammography, so that we detect breast cancer early, and we do HPV screening and HPV vaccination so that we can prevent a dreaded disease like cancer, cervical cancer. We have had 3 vaccines. The bivalent of GSK, which was only for the cervical cancer, the quadrivalent of MSD, which also had 6 and 11 for benign warts, and now we also have 9-valent vaccine from MSD, which also has the remaining 5 oncogenic type, which makes it 98%. Which bivalent is now no more available in India and is going to be phased out entire world because these other vaccines are higher valent. And now we have a new entry, and that is serum's vaccine, which is quadrivalent, same as the quadrivalent of MSD, which is 16-18 for the cervical cancer and 6 and 11 for the benign warts. So why another HPV vaccine? This is WHO's global strategy to eliminate cervical cancer. 90% of girls fully vaccinated with HPV vaccine by age of 15 years is the goal. 70% of women should be screened with a high performance test by 35 years of age and again at 45 years of age, which is a dream come true, because where are the people to collect and to read those swabs? And 90% of women identified with cervical cancer to receive timely treatment in the early stage. Again, where is the screening for cervical cancer and where is there to pick up them early? So what cannot be treated should be prevented. And this is the starking reality of the world. On the left is the disease incidence of cervical cancer, age stratified rates in women for cervical cancer. And on right hand side is the vaccination for HPV. And you can see the marked difference. Entire Europe, USA and Australia has hardly any cervical cancer disease, and yet they are the ones which are using the vaccine. And the countries which are in red in Africa, Asia, like India, don't have a HPV vaccine in the national program. So reasons for this inequity is one, lack of awareness, which is true for screening. I don't want to embarrass the women here, but ask question to your own and answer to your own as to how many of you have undergone at least once a pap smear in your life, if not every 3 years. How many of you have at least gone once a mammosonography, if not every 2 to 3 years? An answer will be dismal. So if as a doctor, as a pediatrician, if you have lack of awareness, what to talk about people staying in slums? Hesitancy. People don't want to take vaccine, don't want to do preventive healthcare because they think preventive healthcare is just a gimmick. But most important is lack of cost-effective vaccine, and that's why lack of national program. So these are the two most important reasons why you don't have a good HPV prevention program in the world. And that's why you need a cost-effective vaccine, because today we have excellent vaccine from international market, but they are so expensive that it's almost impossible for the third world country to introduce those vaccines at the given cost in the national program. So comes the savior, Serum Institute of India, with this quadrivalent HPV vaccine. And mind you, though it's serum vaccine, it is not the serum which has made the vaccine. There are 13 agencies involved, including the Bills and Melinda Gates Foundation and so many other, including Government of India, BIREC, ICMR, which have come together as a partnership to make this reality to have this vaccine. So this vaccine, as I said, has 6-11 for the benign warts and 16-18 for the cervical and the other anal cancer prevention. And the antigen content is same as the MSD's vaccine, which is 20-40-40-20 per dose. It also has some excipients like aluminum hydroxide as an adjuvant. It is licensed for use in our country for women and men both. For 9 to 14 years, it is licensed as 2 doses 6 months apart. And for 15 to 26 years, is licensed as 3 doses 0, 2 and 6 months apart. So unlike the HPV 9, which is licensed for boys from 9 to 16 years and for girls from 9 to 26 years, this vaccine is licensed for both boys and girls from 9 to 26 years of age. So what study it has is one thing to have a vaccine which is indigenous, but other thing it should be also as good. So this was the phase 2-3 combined study where there were 2 cohorts, 9 to 14 years age and 15 to 26 years age. 9 to 14 years received 2 doses 6 months apart, and 15 to 26 years received 3 doses as 0, 2 and 6 months. And in each one of them, you have males and females, and a comparator vaccine which is Gardasil, which is in females. And you have also for the 15 to 26 years, male and female receiving serum vaccine and Gardasil as the comparator vaccine. Now one thing peculiar, if someone who have sharp eyes, actually the comparator vaccine is Gardasil female here, Gardasil female here. Why there is no Gardasil male here? Because Gardasil is not licensed for use for males in our country. So ethical permission was not given to use Gardasil male as comparator. So the comparison was always with Gardasil in female and serum vaccine in male and female. So it's just two doses for below 14 years and 3 doses for above 14 years. And you can see here, almost 366 people all on each arm, so all the 6 arms together had almost like 1,500 subjects which were enrolled. So primary endpoints were to demonstrate immunologically non-inferiority, and there were two cutoffs. 0.67, which is the cutoff taken by many HPV vaccine trials in the past, and a 0.5 cutoff, which is what WHO says as an acceptable limit. So what is this cutoff of non-inferiority margin? You take the current vaccine, I mean the new vaccine, and you take the current comparator vaccine, and the titer ratios you divide, and you develop 95% confidence intervals. And the lower bound confidence intervals of these ratios should not be below 0.67 or below 0.5. That is the way you look at non-inferiority. So you have girls between 9 to 14 years, 2 doses, compared with women of 15 to 26 years in the comparator vaccine, 3 doses. Boys 9 to 14, 2 doses versus women in 3 doses in comparator vaccine. And for older, women 3 doses versus women 3 doses here, and men 3 doses versus women 3 doses here. So first of all, the side effects. So you can see here, this is the cohort 1 of girls, and this is the cohort 2 of women. So this is talking about girls or women. So you can see a Cervarix versus Gardasil in girls. Local swelling was lesser with Cervarix, and fever was lesser with Cervarix, though statistically not significant. Comparing the older women, you can see here nausea was less, and again fever was less. So somehow little less side effect in the form of local and fever. What about boys and men? So you have boys here, and you have Gardasil girls, and you have men here, and you have Gardasil in the women. And again you can see here that local swelling was again lesser with Cervarix compared to Gardasil in boys. Fever, pain, dizziness, headache, all were lesser in boys as compared to girls. And on the other side, for men versus women, lot of side effects. In fact, most of them statistically significantly less in men compared to women. Now, is it because men can tolerate pain much better? मर्द को दर्द नहीं होता है? Don't know, but this is a fact. So women get pain, but they show more than what they get. And men get pain, but they don't show it. All right, jokes apart. Now this is the most important. Next 4 set of slides are important to understand the non-inferiority. So this is seroconversion rate. So you can see here girls Serum Institute, boys Serum Institute are in violet and yellow color, and girls MSD are in green color. So you can see 100% seroconversion for all the 4 serotypes, irrespective of which vaccine you have used. Same way here, older women, older men, and women on the comparative vaccine side, and again 100%. So as far as seroconversion is concerned, both the vaccine, irrespective of the age group, irrespective of the sex, had 100% seroconversion. Now we say the titers ratio is a non-inferiority criteria. So this is girls Cervarix versus women Gardasil. So remember, girls Cervarix were only 2 doses, and Gardasil women were 3 doses. Now why compare with women of older age with younger age girls here? Because you have efficacy data for Gardasil in women between 14 to 26 years of age. So when you have the efficacy for a group and you show non-inferiority, you have a bridging. That's known as epidemiologically studies by sero-bridging. So you expect if you have non-inferiority with the new vaccine, it will have at least the same efficacy as which is shown with the comparator vaccine, and we know Gardasil has an efficacy of almost 98% when used in the age group of 15 to 26 years of women. So you look at the titer ratio. So first, girls, you can see here the ratio is 1.9, 1.6, 1.8, and 2.1, and lower bound confidence are 1.6, 1.3, 1.6, and 1.7. They are all above 0.67 as well as 0.5. So if at all, young girls had a much superior immune response than the women of 15 to 26 years receiving Gardasil. Same way, young boys with 2 doses compared with Gardasil women 15 to 26 years, look at the ratios are above 1, and lower bound confidence intervals also are above 1, so statistically significant. One more thing, you look at the fold rise in Cervarix as compared to the baseline. Like just to give an example, baseline was 0.06, post-vaccination 304, so it's like 1,000-fold higher. For all 4 serotypes, it was 1,000-fold higher in the girls. It was also 1,000-fold higher for the boys. Now comes the women 16 to 26 years 3 doses with Cervarix versus women 15 to 26 years of Gardasil, And you can see here again the ratios are, now look at the lower bound confidence intervals, except for one point type 11 which is just touching 0.5, all rest 3 are above 0.5. So by WHO criteria, they were all statistically non-inferior. And remember, the two oncogenic, which are more important because they prevent cancer, 16 and 18, definitely proved to be above 0.5. And again, if you look at the baseline versus post-vaccination for Servavac, there was more than 1,000-fold rise in the titers. Now, why am I insisting on the 1,000-fold? Because I'm going to show you what the antibody titers means. And the last is men Servavac 3-dose versus women Gardasil 3-dose. And again, you look at the ratio. Again, type 11 is below 0.5, but rest all the three, including the two oncogenic, are above 0.5, so they meet WHO criteria. And again, for all 4 serotypes, the titer rise is more than 1,000-fold. Now the questions, what does titer mean? Titers are one important way by which you license a new vaccine. But do you need so much titers actually to prevent disease? Like we talked about pneumococcal from 3+1 to 2+1 to now UK using 1+1 and still having the same efficacy. So whether you need, can you use lesser dose and get away with any problem of efficacy? So this is a study on Gardasil which was done originally, and they looked at the antibody titers against all the 4 serotypes, 6, 11, 16 and 18 over 5 years. And they gave a booster at 5 years to see boostability. Now just concentrate on a type 18, and you can see the titers have sharply fallen. They are almost reaching the same as what was seen in placebo group. Of course, when you gave them the booster, there was a massive boosting, which means it was boostable, but the titers had actually fallen drastically. Now more than titer, the seroconversion. So these are the titers which went up from 8 to 461 and fell to 52 and 33 by 4 years. Look at the seroconversion. At the end of the third dose, 99.5. By 4 years, it had dropped to 60%. So at 4 years, you have a 60% women still seropositive, and titers being 33.8. Would it jeopardize the efficacy of the vaccine? And this is the efficacy against type 18, which was persistently at 98.4%. So that shows you that probably you don't need so much titer or seroconversion, because we don't know how these vaccines work. Is it cell-mediated immunity? Is it some local immunity in the cervical secretion, or is it the serum antibody which are important? So this shows you that there is no much correlation between antibody titers and actual efficacy. Now this is the most important slide, and I'm sure in the next snippet, Dr. Shirodkar will show you this data in much great detail. This was study done in India, which was originally efficacy trial of 2 versus 3 doses in 9 to 20-year-old girls, and lo and behold, after some time the trial was stopped because of some mishap in another trial, and by default you had 1-dose recipient, 2-dose recipient and 3-dose recipient. So now they converted that into a cohort analysis and followed them up for 10 years. And look at the efficacy with 1 dose versus 2 versus 3 dose. And they found that 1 dose efficacy was 100% as compared to 2 or 3 doses. But look at the titers. The titers with 3 doses are in the green for all the 4 serotypes. They are massive, right? Look at the titer with 1 dose in blue. They are almost touching the baseline over the some time. And yet the efficacy was 100%. So there was hardly 2 to 4 fold higher titer with 1 dose, and yet it was sufficient to lead to 100% efficacy as compared to several fold higher titer with 3 dose and having very similar efficacy of 100%. So with these new vaccines showing 1,000-fold rise in titer with all the 4 serotypes, we presume that this is what will happen with this vaccine over the time. So this is the editorial in the Lancet in 2022 Oncology, which talks about a silver bullet for cervical cancer prevention. The entire article is on the Servavac from serum, and it shows that in phase 2-3 trials, they've shown that it works very well compared to the MSD's vaccine, and it is believed to be costing only 200 to 400 rupees. Of course, that's for the public health, and in fact, Mr. Ade Punewala was on record to say that he will probably give this vaccine for $3 to $4 a dose, but we know in commercial market, it never comes at that cheap rate. So, you know, this vaccine is available as a 2-dose vial today, each vial costing 4,000, so 2,000 rupees per dose. Now, why you will wonder as to why there is a 2-dose vial and not single-dose vial, is because when this vaccine was made, it was made for public health, and in fact, they were not given license for commercial use. The entire dose had to be given for public health. But somehow they then allowed some vials to be sold in private market, and because the doses were made for public health as 2 doses, you only have 2 doses. In next 6 months, I'm sure you will have a single dose vial also available. So it says that developing countries of Asia and Africa, and it names a lot of them which are having high disease burden, probably will be able to afford this vaccine in their public health because it is so cost effective. So just to summarize, this new vaccine is a gender neutral vaccine that provides equal opportunity to men and women up to the age of 26 years as on today. I'm sure they will have studied beyond 26 years, and like the other vaccine, it may become vaccine up to 45 years of age. Is immunologically non-inferior to the existing vaccine on WHO criteria, especially for the oncogenic serotype. Is licensed for use up to 26 years for both men and women, and is an extremely cost-effective vaccine, at least especially in the public health. So I'm sure we are all looking forward to single dose, and till then, when you have 2 doses, either you have 2 children from the same family, or give mother, child, brother, sister, or have a HPV day where you can call 2 patients so that you don't waste the vial and waste your money. Thank you very much.
Thank you, sir, for a wonderful session. And when a teacher teaches well, we want to continually learn from him as well. So for the next session also, I invite Dr. Nitin Shah, sir. The topic is on Hashino. Where and what is it?
So it's Hoshino, not Hasina. A lot of men ask me that, what are you discussing in the vaccine? I said, please read, it is Hoshino and not Hasina. All right? They thought it's a Hasina from Japan, that's why it's named as Hoshino. So that's not correct. Okay. So as I said in my inaugural address to you, that we have monologues only on either new vaccine or vaccines, old vaccines with new data. So I presented on type by BC, which is an old vaccine, lot of new data. I spoke on Sabha, which is new vaccine. And I don't know how many of you know about the data on Zydus's MMR vaccine. Have you ever heard any time? How many of you have heard? So very few. So I thought that's why it might be worth to know what this new vaccine means, especially when it is a new mumps strain. So let's not forget measles. And we have seen lots of them. And I hope you are reporting it. And now many parts of the city, the local ward officers have made WhatsApp group, and you are supposed to put your cases there so that you don't have to fill up all those forms, etc. I am in one of such for the F North, and every day there is someone who is reporting a case of measles, even today. All right. So these are the Koplik spots. How many of you have seen this Koplik spot? This slide was given by, I don't remember which doctor, but he sent me this slide that this is typical Koplik spots. All right, so RO measles is one of the highest in the infectious disease, 12 to 18, which means is a rule that the child who is in contact with the index case, if he is not immunized or is not naturally immune, will develop measles. And that's why you see families after families, children getting measles. Case fatality is 3.8% even today. So it's not a disease which you can take lightly. Besides the typical rash leads to otitis, pneumonia, diarrhea, vomiting, dehydration, encephalitis, keratomalacia, bronchitis, croup, and name it. When we were residents in the ward, there used to be a row full of measles and post-measles. So on one side was active measles, the right side was all post-measles, tuberculosis, TBM, and massive malnutrition. So it was a dreaded disease. Risk is more in children who are malnourished, immune compromised, above 30 years of age, pregnant ladies, and those with vitamin A deficiency. So there are lots of meta-analysis on vitamin A and measles, and it shows very clearly there is someone who is vitamin A replete or is given vitamin A during an active measles, their mortality can be brought down by as much as 60%. And I think that's the reason why please ask your ward officer to give you a bottle of vitamin A. They will give it to you because they are not able to reach the family fast. So when you see a child, give him vitamin A, 2 lakh if it's above 1 year, 1 lakh if it's below 1 year, and 50,000 if below 6 months, and repeat a dose on the second day, and that itself will do a lot instead of giving them all fancy antibiotics. So if anyone wants, please let me know. I will put you to the right perspective, and you will get this vitamin A bottle in your clinic. Mind you, it's a very concentrated syrup, so it should not fall into the wrong hand. Otherwise, if someone consumes one bottle, it's a sure shot poison. Okay, measles vaccine was launched in 1963. That is when I was 3 years old. So probably I missed that vaccine. Before 63, there used to be outbreak every 3 years, and 2.6 million deaths annually used to happen every year. From there, we have now come in 2000 to 2018, 75% drop in cases, which means we have prevented 23.2 million deaths because of a single vaccine. That's a huge benefit of such a vaccine. 2001, MR was introduced because rubella was equally important. So by 19, around 80 countries have eliminated measles and another 80 have controlled rubella. I think that's a great achievement by a vaccine like MR. In India, it was launched in NIP in 81, and MR campaign was launched, as you know, in 18-19, and now it has become part of the national program at 9 months and 14 months or 15 months or 16 months, depending upon when the child comes. WHO has set 3 goals. One dose coverage of more than 90% national level and 80% district level. Some of you who would have heard Dr. Jacobson speaking on measles recently, he stressed that our entire focus of measles elimination is from a national program to district program, because every district has to have their own strategy. Reduce and maintain measles incidence to less than 5 per million, which is a dream come true in our country as on today, and reduce and maintain measles mortality as compared to 2000 by more than 50% by 2005. We have missed that bus. More than 95 by 2010, which we have missed the bus. So I think we need to catch up. And no WHO region has achieved this target so far, and that is the starking realities. Like polio, we are postponing. But unless you aim for something, you will never be able to succeed, no matter how many years it takes. This is the 2021 measles case map you can see here. And so the lighter the color, less the cases, the darker the color, more the case. You can see one country stands out, and that is Nigeria and Niger and Somalia, which are all in Africa. And of course, India is also a little darker than many of the part of the world. So India had 5,700 cases in 2021, but in 23, it has superseded. Now there must be more than a lakh of cases of measles in the country. So out of 550 million under 5 children, 40 million are at risk of measles as they miss first dose or the second dose of MR vaccine. And I think that is again not fair to children, that you have a vaccine which is so cost effective, part of national program, and still parents don't give it, we don't give it, is not correct. Of the 19 million children who have missed their MR vaccine, 6 million are in India, Pakistan and Nigeria. So same story. Polio, India, Pakistan, Nigeria, Afghanistan. Measles, India, Pakistan, Nigeria. I mean, this is not correct, though we are all aiming. I was in one of the meetings with an international experts, and a lot of Indian delegates were there like me, and they were all saying, India is no more developing, it is developed. One person got up and said, excuse me, sir, no developed country has wild polio in their country. And I think that shut the entire delegation of India to say, keep mum, we still have wild polio. This was almost 10 years back. 2021 saw 9 million cases and 128,000 deaths. This is not acceptable for a vaccine preventable disease. More than 95% of these cases are in developing country. 22 countries which were otherwise polio free have experienced large outbreak, and a lot of them are having resurgence. All this speaks that we need to invest more manpower, money, political will, and individual efforts to increase the MR reach so that we don't have this outbreak. And as I told you, I'm sure Dr. Amol is here and some more office bearers of Maharashtra here. In the Maharashtra task force meeting of measles, it was on record to say that in 9 months, we had only achieved 60% target for the MR. So another 3 months, you have to become at the most 70. We need 90% plus coverage, remember. Not with 1 but 2 doses. And that's the reason why we are having the measles outbreak. So I thought, besides talking about the vaccine, which is new, let's refresh our understanding of measles. Mumps, of course, everyone knows mumps is a benign disorder, but it can lead to complications like meningitis, acute encephalitis, which can kill the child, transverse myelitis, cerebellar ataxia, pancreatitis, orchitis or oophorytis, which is a common cause of sterility in couples, deafness, and even remotely related to diabetes. Rubella is a devastating disease if it happens in pregnancy, though it's known as 3 days fever with some rash and lymph node, but it can lead to congenital rubella syndrome. And according to WHO, there are more than 100,000 cases of CRS every year in the world. So to prevent that, you have to target the mothers to get the vaccine. And that's why R is added to measles and made into a MR vaccine. In India, it is supposed to be more than 30,000 children born every year of the CRS, and we need to prevent that. Risk is 90% if the mother is pregnant below 10 weeks of gestation and she develops a rubella during the pregnancy. you know all the side effects of the congenital rubella syndrome. I will not go into the details. So you need vaccine, and we also want to prevent mumps besides measles and rubella in our practice, because as I said, it's so common to give a combination vaccine. It's as costly as MR vaccine, and in private market we believe that we have to prevent mumps, so we use MMR, whereas government uses MR vaccine. So we are so far serums vaccine and we are GSK's vaccine. There were essential difference in the measles strain, Edmondson-Zagreb versus Schwartz, mumps strain, Leningrad versus RIT, and rubella, which is the same. Now we have one more vaccine from Zydus, which has the Edmondson-Zagreb strain, same as serum strain, and that's where your Hasina comes. Hoshino strain of mumps, all right, and the same rubella. So rubella is same between the three. Mumps is completely different. Leningrad-Zagreb in serum, RIT or Gerilin strain with GSK, and Hoshino with Zydus. So what is this new vaccine? It's a live attenuated freeze-dried vaccine which has the required content, whatever is the CCID 50 of the three strains, and it is this Hoshino strain is essentially used in Japan, Korea, and Iran for last 25 years. Korea and has recently switched from this to Gerilin strain, and Japan has stopped using MMR combination and uses MR as a routine vaccination and mumps given as an optional vaccine, because they are very finicky about mumps encephalitis, which will happen with every vaccine, including Zydus vaccine, serum vaccine, and I'll show you even with Gerilin strain it is less, but it's not absent. Okay, so monovalent Hoshino strain mumps is used still in Japan. So phase 2 and phase 3 study, two studies done by Zydus. The phase 2 study is essentially for side effect profile, and the phase 3 is for a comparison with the existing vaccine. So phase 2 was an open label study done way back in 2014 in 5 centers of the country, where 15 to 18-month-old children who are eligible, who receive this vaccine, single dose as 0.5 ml subcutaneously. So safety was followed up to 6 weeks. Immune response was seen at baseline and 6 weeks after the dose. And these were the cutoffs used for seroconversion. For measles, 200 MIU per ml, mumps 8 EU per ml, and rubella 8 IU per ml. So those who are seropositive are above cutoff post-vaccination, irrespective of initial antibody positive status. And seroconversion means initially seronegative but now have above cutoff level. So there are two ways of looking at the end of the vaccination as to what happens. So this was the seropositivity and seroconversion. This was the these children received measles at 9 months. You can see at 15 months, many of them had antibody, and it became 100% after the Zydus vaccine was given. For mumps, because there was no mumps given before, from 11% natural antibody jumped to near 100%. And again, rubella, because there was no rubella vaccine given before, from 18% it jumped to nearly 98%. So on this phase 2 trial, there was a very high seroconversion obtained by the vaccine. Now look at the titers, and you need cutoff of 200 for measles, and the titers achieved were almost in the tune of 3,000. That for mumps cutoff is 8, and what achieved were almost in hundreds. And that for rubella again a cutoff is 8, and again they were almost from 100 to 150. So in open label it showed the vaccine was safe, highly immunogenic from seroconversion point of view, and a very high titer as compared to the cutoffs that were used. So that led to licensing to start for phase 3 study by the DCGI. So this was a single blind randomized active control trial whereby Zydus vaccine was compared to the serums vaccine. So 2:1:1. Two children who received either a unit dose Zydus vaccine or multi-dose Zydus vaccine to see whether multi-dose will have any different from unit dose, and the competitor vaccine which was serums vaccine. So you can see 100 to 100 to 100. So 300 subjects who are 15 to 18 months old had received one dose of either of these vaccine, and they were followed up for 6 weeks for safety and immunogenicity. Again, you look at these children had received measles vaccine before, so many of them had antibody against measles already, but post-vaccination, whether it is Zydus unit dose, Zydus multi-dose, which are the first 2 bar, Zydus total, which is irrespective of the multi-dose unit dose, and the one which is light green is comparator vaccine. So you can see all 4 bars, 100% for measles, nearly 97% for mumps, and 98% for rubella. So if you just take away the Zydus unit dose and multi-dose and just compare Zydus versus serum, then that's where it makes life simple for you. Post-vaccination, For measles, 100%. For mumps, 94 to 95%. And for rubella, 95 to 91%. As far as titers are concerned, again, you need a cutoff of 200. With both the vaccines, the titers achieved were 1500 and 2000. But there was more titer with Zydus vaccine compared to serum vaccine, which was statistically significant. As compared to mumps, serum had little better titer, but again, statistically not significant. And for rubella, again, Zydus had little better titer, but again, statistically not significant. So you can see here that except for measles antibody, which were better with Zydus, the other two were comparable. So non-inferiority of the new vaccine compared to serum vaccine was established by this immunologically response study at 6 weeks. What about safety? Fever was definitely less with Zydus vaccine compared to serum. Rash also was less with Zydus vaccine compared to serum. But again, you can see most of them were statistically not significant. So you may find that both vaccines are equally safe with little less chance of developing fever or rash following vaccine. And overall tolerability, which the patient were asked how you feel about the vaccine tolerability, you can see both the vaccine had excellent tolerability. Almost 90 to 95% of patients said, relatives, the parents said that the vaccine was not excessively side effect wise or fever or pain point of view. And again, all this fair, good, etc., none of them were statistically significant. Now the question of aseptic meningitis, to why did we stop using excellent vaccine from Sanofi, which had Urabe strain of mumps from the world? And why Hoshino as an MMR is not used, but Hoshino as only mumps is used in Japan? And that's because of this finicky nature of the Western countries, where side effects are more important than the effect of a vaccine. In Japan, you know how the AP vaccines came in market. In 1970s, 3 deaths happened following wholesale DTP vaccine, and they were all ascribed to the pertussis component, which is wholesale component. There was such a hue and cry in Japan. They stopped vaccination. The government stopped vaccination under the pressure of the common man, and several children developed wild pertussis and died of pertussis encephalopathy. The government realized that you need to prevent pertussis. They asked the manufacturer, you please bring another safer vaccine, even if it's a little less efficacious, because then only we will be able to use a pertussis vaccine. And then there was a rat race between the manufacturer to make an AP vaccine. And that's how the AP vaccine came in the market. They were not invented by the company de novo. They were asked to manufacture a safer vaccine. Same way for mumps component, aseptic meningitis was a big thing in the Western country. So you can see here there was one extra case of aseptic meningitis for every 10,000 vaccinees who received Sanofi's Urabe containing vaccine. And that was enough reason for them to suspend that vaccine and withdraw the license. Now if you take that one case, what is that case? Child had on 2 to 3 weeks after mumps vaccine, some fever and headache. They did a spinal test, they found thousands of cells. They said this is aseptic meningitis. Never proven that the virus strain was actually grown from the culture in most of them, and all of them recovered with ibuprofen in 2 days and sent home. How many of you have diagnosed a mumps associated aseptic meningitis in your practice? Not a single. We don't bother. Children get fever, headache, so chup so ja crocin leke. So we don't bother, but the Western world bothered. So I thought I'll cover up the aseptic meningitis, clear the doubt. So first of all, it is a known complication of mumps. It is much milder than wild mumps, never leads to any death, and becomes asymptomatic within few days after you treat them with symptomatic treatment. So what is the status of aseptic meningitis besides Urabe with the 3 vaccines? So you have Gerillin strain, Zydus strain, and serum strain. The serum is Leningrad Zagreb. So Brazil had a huge outbreak of measles. So they started mass campaign, like how we do polio campaign, using serums vaccine. So 3 different studies have been published from Brazil on serums vaccine mass campaign to look at the aseptic meningitis and the efficacy of such examples in preventing wild mumps. Both were looked into. So first looking at the side effect, you can see here these are the 2 different. So first of all, how many? 4.4 lakh children in one area of Brazil received serums vaccine, and 4 lakh children in other part of the Brazil. So total cumulative 8 lakh children receiving MMR vaccine in a campaign mode. So see, 32 weeks is when they, 32 weeks of the epidemiological week study, they received the vaccine, and 35 to 36 weeks, you can see suddenly there is increase in the aseptic meningitis. Same way here, they start at 38 weeks, and in 42, 43 weeks, they have increase in the aseptic meningitis. So you can see chronologically it's fitting that 2 to 3 weeks after mumps vaccine, there is an increase in the aseptic meningitis. But again, as I said, they are all mild and they are all recoverable. But look at the impact. When they use this vaccine, what happened to the wild mumps? 92%, 93%, 93%, 93% reduction in the disease. So there was nearly 95% reduction in the wild mumps, which is more important. So for that mild aseptic meningitis, are you ready to try to decrease wild mumps? The answer is yes. But yes, there was a case of. So how many cases of aseptic meningitis happened? So you can see here almost 1 case for 8,000 doses, and here again 1 case for 13 to 19,000. So same as Urabe, little less than Urabe. Yet Urabe was withdrawn, but we are still very happy using this vaccine. This is the same vaccine we are using in our day-to-day practice, and we haven't really worried about this aseptic meningitis. Okay, there's a massive study done in Egypt using serums vaccine, where more than 3 lakh children received this vaccine, and they found in the side effect profile no case of aseptic meningitis, though there was some case of parotitis. So remember, there can be mumps vaccine-induced parotitis as much as aseptic meningitis. In some cases, again, mild, and most of them recover. And some of them can develop lymphadenopathy that you see with natural rubella, also with the rubella vaccine. All right, what about Hoshino strain? So you can see here, these Hoshino-containing strain and Urabe strain were used in South Korea, and there was also another one, Rubini strain, which was used, and Gerilin strain was used. So comparing the incidence of aseptic meningitis, you can see here in below 18 years, relative risk was 11 compared to Gerilin strain. So there were definitely some cases of aseptic meningitis, but that was not the case for anyone who is above 18 months. So it is the problem of first 2 years of life and not beyond as far as aseptic meningitis is concerned. But yes, with Hoshino also there can be some aseptic meningitis. What about Gerilin strain? 2 studies done. One in UK, they found no case of Gerilin strain leading to any aseptic meningitis, whereas this is the largest data link from vaccine safety in USA, and it found that the relative risk was 3 as compared to no vaccination 14 days after the MMR vaccine. So it's not that the Gerilin strain does not lead to any aseptic meningitis. It also leads to, though to a larger extent, much lesser than the other 2 strains which are there in the market. And parotitis, as I said, can happen with any vaccine. So you can see serums vaccine, MSD's vaccine, Sanofi's vaccine, all of them had their own share of either lymphadenopathy or some parotid swelling because of the side effect following the mumps and the rubella strain. Parotitis with Hoshino strain, rare, but it can happen. So it's around 0.8 to 1% depending upon which study you look into. And lastly, we speak so much about Gerilin strain, the best strain, no aseptic meningitis, extremely good, comes at 4 times more cost than the vaccine which we have from serum or from Zydus. So this is the shocking reality of the MMR vaccine in USA today. This is access just last year, and you can see here, there used to be 150,000 cases of mumps in USA in 1968. They introduced MMR in 1967, and now it is 2 doses, as you know, at 15 months and at 5 years. The case dropped by more than 99% by 2003. But since 2006, it has nothing to do with me becoming president in 2006, but they started having mumps outbreak. And you can see from 2006 onward, there are huge outbreaks in fully vaccinated adults, which means there is waning of efficacy after 2 doses of MMR by the time you reach 15, 18, 20, 25 years. So in areas where there are outbreaks, and there are several areas in USA where there are outbreaks, they now recommend a 3rd dose of MMR in adults. So no vaccine has 100% efficacy and a long-term efficacy except hepatitis A. Remember, most of the other vaccines need natural or vaccine boosting as the age advances. So this is the starking reality. That's why I'm very happy that as far as the IAP ACVIP is concerned, and I'm sure Dr. Kasi will feel very happy that I'm agreeing with him, that we are giving 3 doses of MMR. And the 3rd dose is at 5 years, which will probably see them for 20, 25 years, because this problem is of the young adults. So just to conclude, we have a new vaccine from Zydus, MMR, which has Hoshino strain of mumps. This is a strain which is used in Iran for 25 years as a monovalent vaccine in Japan. And in fact, in Japan, using monovalent vaccine, 700,000 doses, not a single case of aseptic meningitis has happened. So, it is a combination which is probably more problematic. Phase 3 data compared with serum vaccine found it to be non-inferior and as safe. And there are rare side effects like aseptic meningitis following all the vaccine to some or other extent, including parotitis and lymphadenitis. But that is something which we should not bother. So I think we should use a vaccine which is available and which is cost effective. Thank you.
Thank you, sir, for a wholesome coverage of all these vaccines. And now we can have a discussion, and we can start from a Hasina first. From a handsome guy.
Are there also any questions from the chat box? Just see someone. Yes.
The first question is about that HPV vaccine.
Yes,
HPV
sir.
vaccine, that now we have a 9-valent vaccine.
Correct.
And the 5 serotypes which have been added, they are mostly for preventing cervical cancer only.
No, there is also for anal, genital and other cancers.
And does it help in boys also?
Yes. It's a gender-neutral vaccine for prevention of anal and penile cancers.
So it is licensed as a gender-neutral, but
yes.
Does it really help in...
Yes, so it prevents warts in both the sexes, and for men it is mainly for oropharyngeal, penile and anal cancers.
Right.
And for anal cancers and oropharyngeal there is statistically significant decrease. For penile cancer, as the numbers are very small, there is no statistically significant decrease, but the point estimates show that it prevents penile cancer to the tune of 85 to 90%.
But I am talking about only added serotypes.
For the 5 extra serotype, yes.
Extra 5?
Yes, yes.
Does it help in
yes,
boys as well?
Yes, it helps in boys. There are efficacy trials done. Yes.
Dr. Nitin Shah, adding up these 5 serotypes, 31, 33,
yes.
45, how much percentage of cervical cancer is
10%.
I mean, is it now only...
From 87% with 16 and 18 together in India, it becomes 98%.
But there is a phylogenetic trees there, and 16 has got the affiliation of...
So you are talking about cross protection.
They provide the cross protection.
All right. So I think good you raise. I have a slide on cross protection. So is it cross protection or cross protection? That is my title of the slide. So the cross protection was seen by 16, again 33 and 35. But only for 2 to 4 years after the last dose is given. After that it becomes statistically non-significant. Suppose you have a 10-year-old child who is given the HPV vaccine today. By 14 years there is no cross protection, and that person gets married only at the age of 20, 22 or 23 and gets exposed to HPV through either way. There is no cross protection at that time. Absolutely, studies are there. There are 6 years and 8 year long-term immunological follow-up study on what happens to the titers against the non-vaccine serotype as far as the titers are concerned, and after 2 to 3 years the titers become non-significant. Yes. So there is no efficacy data as a part of cross protection as far as HPV vaccine is concerned, but there is data on direct protection, and as IAP always says, direct protection is always better than cross protection. Kasi wants to add something.
Sir,
yes.
There is some minimal cross protection persisting till 8 years only for serotype 45.
So
others it has
by 48 months, that is 4 years, the titers drop to almost zero.
A request, anyone who is speaking, please speak in the mic and speak loudly, otherwise the online people cannot hear.
Sorry, I am very, very loud.
can HPV vaccine...
Madam, thoda nazdik, haan.
Yeah, can HPV vaccine be given at around 28, 29 weeks for a male?
So first of all, let me clarify this for once and for all. You have 3 vaccines now, Gardasil, Gardasil 9 and Cervavac. Gardasil is not licensed for boys or men at all. So it will be an off-label use. Gardasil 9 is labeled for both men and women. But Gardasil 9 is only for 9 to 26 years for females and 9 to 16 years for boys or men, whatever you call it. Cervavac is licensed for 9 to 26 years, both for men and women. And Gardasil world over is licensed for both men and women till 45 years of age. So anything which is not in the product insert is off-label. Off-label is not illegal. Off-label has to be shown as with consent of the parents, and I would probably also say a written consent which is documented on the paper, so that you don't have any confusion. I know I have helped through the companies and through the papers, one pediatrician was sued for giving Gardasil to a boy, and the father said that where it is licensed for use in boys in our country. So we have to defend by saying that you agree to take it, which means there was a verbal consent. And for all vaccination, even the government of India doesn't insist on a written consent, and there is recommendation to use in boys in WHO and many Western countries. So with that case went rafa dafa, but be careful when you use anything which is violating the product insert.
So sir,
yes.
Online questions, sir.
So you should ask question only during your session. No, I'm just joking.
Should I ask, sir?
Yes.
Sir, this is regarding Hasina only.
Yes.
So
Hoshino.
Yeah. So most of the studies what are done on this, what you showed, are not virgin population. They are received one dose of MMR at 9 months of age.
No, they have received measles, not
not
MMR. They have received only measles vaccine.
measles vaccine.
Yes.
So that will have some effect on
Measles, yes, but not
Right.
for mumps and rubella.
So are there under studies on a virgin population?
So the problem is MMR.
Because we give MMR at 9 months.
Correct. So that's a very good question, and I asked the same question to Zydus and Serum both. So what they said is, once there is a recommendation of using MR vaccine at 9 months, there will be no ethical permission to be given to use MMR at 9 months, because you cannot contradict the national programs. You will have to have a comparator with MR only. That's why they are giving. MMR was licensed. See, the studies were done 5 years back, 6 years back. That time MMR was licensed only above 1 year of age. Is the ACVIP is saying MMR at 9 months. If you see the product insert and the licensing, even Western countries don't use MMR before 1 year of age. That's the reason why this twist is there, that the MMR studies are all at 15 months of age. Madam, thoda nazdik rakho. हाँ.
Sir, I had a question about BCG vaccine.
BCG, okay, I'll answer, no problem.
Is there a... okay. So should I go?
चलो पूछ लो जल्दी से.
Sir, so is there any data regarding difference in efficacy giving BCG before isoniazid prevention and after isoniazid prevention in an infant
So
born to...
BCG, which is there in our country, is not INH resistant. So don't worry about INH having any problem.
Oh, no, I mean to say is whether the efficacy of the vaccine will decrease if we are giving INH prophylaxis along.
No, absolutely not.
So there are some online questions.
Yes, please.
One of which you answered actually. Maximum age, the mother can be given HPV vaccine.
Yes.
The other is from Dr. Sanila Nagvekar, 2 versus 3 doses for MMR.
2 versus 3. So 2 is minimum, 3 is ideal. And IAP, SCVIP says 3 doses. So if you give MMR before 1 year, remember, the mumps part may not work as well as compared to giving MMR after 1 year. Now, why do we say MMR at 9 months? Because either you have choice of only MR or MMR. Measles has gone. So you are giving MR, instead you can give MMR at 9 months, thinking that the mumps part will not work. So you give 2 more MMR after 1 year, which is at 15 months and 5 years. That's the reason why I would prefer to give 3 MMR, 9 months, 15 months and 5 years.
Another one, Dr. Bharti wants to understand post-measles vaccination. So child already has measles, how many doses and what will be the schedule?
So unless you have done the IgM for measles, you can never know that fever with rash was measles and not measles-like illness. So benefit of doubt should be given and the child should receive MMR vaccine.
Full doses, all 3?
Full dose, yes. Whatever age appropriate, yes.
Yes, okay. Thank you, sir.
Yes.
I have a question. The data on single dose HPV vaccine is very promising.
Sir, 1 plus 2 plus 3 snippet is there. Don't spoil her.
My question is, and as on today, cost is an important driver.
Yes.
So 1 nonavalent or 2 quadrivalent.
She will answer that. That's exactly the snippet is. Arun.
So I wanted to ask on everybody's behalf, this vaccine was
this
vaccine was tested for 15 to 18 months only. So can we give at 9 months and 5 years?
I mean, that is true for most of the MMR vaccine. They are studied at. So I don't know. I mean, either I don't know anyone from Zydus here marketing. They can answer, is the product insert saying from 9 months or is saying from 15 months? Yeah. So 9 months, what about serum vaccine? Is it in the product insert at 9 months? No, I'm not aware. So I will have to look into that at 9 months whether both vaccines are on paper. I'm sure Gerilyn, that is GSK's vaccine, is not licensed at 9 months. No. So when the product insert is saying nothing, and if you use, then you should have a backup of either WHO, some international agency or SCVIP. If the product insert says, then there is no problem at all. Use.
So it's regarding
Hello.
HPV vaccine. It is a comment that it is the age of initiation of first dose,
yes,
which is important.
Correct.
If you initiate it at less than 14 years, one dose, then the second dose can be given afterward. The total dose will remain 2 dose schedule.
Correct. Correct. So that's what she's going to discuss. Can you give only 1 dose, 2 dose, at what age? Please don't spoil her presentation.
So one query.
And I believe you, she's going to make it very crystal clear. I mean, her PowerPoint you will like better than mine.
So girls who have received Cervarix, because it was
Cervarix,
available. Cervarix,
yes.
the bivalent. And now it is not available, and either ways we have a better covering options now.
Correct.
So is it prudent to offer
So
either
that
9
lady or
valent,
girl received 1 dose or both the doses of cervical?
both doses of Cervarix?
So finish the course of cervical.
Yes, sir.
So anyone who received either bivalent or a quadrivalent vaccine in the past and can afford, I will give at least 2 doses of 9-valent vaccine 6 months apart, because that will give additional protection for the remaining 5 serotypes.
Right.
Yes.
Suppose
and the first dose of 9-valent will be at least 1 year after the last dose of the bivalent or quadrivalent. Is that clear? Yes.
See, suppose the mumps vaccine was available separately,
Yes.
like what is available in Japan.
Yes.
Would you still give MMR at 4.5 years?
I think
because
we
it
are-
is mainly for mumps that we are giving at
I
4.5.
understand. So I think we are not worried about the side effect of aseptic meningitis. I would give them MMR. I don't think so a single mumps vaccine will ever sustain in our country, because it's not part of national program. No pediatrician going to give another MR1 separately. How will you give measles and rubella? So, you'll have to give 2 different vaccines 3 times. It will be too much. I think let's forget about I brought up aseptic meningitis only because people should understand the concept behind the mumps strain. Otherwise, to me, all MMR vaccines which are licensed look very similar as far as efficacy and safety is concerned.
So we'll have one last question.
Last question.
So, Gardasil 9 is now recommended for boys.
Yes.
So is it not strange that Gardasil 4 has not got that recommendation?
Because they did not do a study of Gardasil 4 in men. And DCGI, very rightly, now insists on a local study for any new vaccine. So even say for COVID vaccine, mRNA, they refuse to do study here, they refuse to give them the license. Because Gardasil did not do a study in boys here, they did not get a license for boys or men.
So can we expect, because 9 is...
Now where is the question, Gardasil? You have Cervarix for boys and you have Gardasil 9 for anyone who wants to use it. So Gardasil 4 to now get male indication is next to impossible. If 1 unit dose of this vaccine comes and if they are almost equal, Gardasil 4 will be almost replaced by Cervarix as what happened with pneumocills. That's how the vaccination, whole market and cost. We are very cost conscious, remember. The most rich person wants the most cheapest vaccine.
Thank you
Thank
so
you.
much, sir. Thank you so much, audience, also for the interaction. And now we have the awaited session. Is 1 better or 2 or 3? And for that, we have our most dynamic treasurer of Mumbai IAP, Dr. Amruta Shirodkar. She's a consultant pediatrician at Nanavati Max and Guru Nanak Hospital.
है नहीं है So very good afternoon to all the delegates. My topic is 1 better or 2 or 3, and I'm being given 10 minutes. I hope to do justice, and especially under the stress of speaking after Dr. Nitin Shah, sir. Thank you, sir. Okay, so the topic of discussion here is the human papilloma virus vaccine. This has been adequately covered right now only by Nitin Shah, sir. So, introduction, we all know only 3 strategies can eliminate cervical cancer. A combined strategy of high coverage of HPV vaccination of girls between 9 to 14 years, twice lifetime screening of women at 35 and 45 years, and effective treatment of those with cervical neoplasia. Here, of course, our concentration is on point number 1. But to concentrate on point number 1, there are a number of stumbling blocks. The vaccine, inequality of vaccine availability has already been stressed upon by sir. So almost 2/3 of the low income and the middle income countries cannot introduce HPV into their national immunization program. These countries at the same time have a disproportionately high burden of cervical cancer, but they don't have enough resources to afford the HPV vaccine, which is currently recommended to be administered at least 2 doses. WHO in 2019 has estimated that the global coverage of HPV vaccine is only 15%. The health systems of these countries are not prepared to face the formidable challenge of delivering these 2 doses to adolescent girls. And of course, with passing years, these countries are going to be affected by a huge gap in supply and demand, because the global vaccine requirement is going to go up to 120 million doses by the year 2030. So considering these stumbling blocks, I am going to present very briefly 2 major studies on HPV vaccine which were undertaken. One was an Indian study and another study was done in Kenya. So there was some evidence before these studies. There was a trial, a combined post-hoc analysis of the Costa Rica and the Patricia trial in a smaller number of single-dose recipients. Around 292 adolescent girls were studied, and it showed that there is a high efficacy of a single dose of HPV vaccine. So to consolidate on this evidence, an Indian HPV vaccine study was published on in October 2021. The study has been already covered by Sir. I'll just rush through it. It was initially started as a randomized trial to compare 3 and 2 doses of the quadrivalent HPV. However, there was a mishap in another study of HPV vaccine. There were some vaccine-unrelated deaths, and hence the Government of India suspended HPV vaccination in the trials. Now, this randomized controlled study was converted into a cohort study, and then the aim was to compare the efficacy of a single dose to that of 3 and 2 doses against persistent HPV 16 and 18 infection at 10 years post-vaccination. So these cohort study model, after the randomized trial was suspended, now these participants got distributed into 4 cohorts. There were 3-dose recipients who received vaccine on 160 and 180 days, 2-dose recipients who received vaccine on 1 and 180, 2-dose default cohort, which received vaccines on 1 and 60, and a single-dose cohort, a single-dose default cohort, who received only 1 dose of the vaccine. So here the methods were like the participants were followed up yearly. They collected cervical specimens from the participants 18 months after marriage or 6 months after the first childbirth, whichever was earlier, to assess incident and persistent HPV infections. So incident was a single HPV type detected anytime, whereas persistent was at least 2 times the HPV type was detected at the same time, 10 months apart. So married participants were also screened for cervical cancer when they reached 25 years of age. And to serve as a control, they used unvaccinated women who were age matched to the married vaccinated participants. So outcomes here were studied, as I said, persistent infection was the primary outcome from HPV 16-18. And the secondary outcome here was incident HPV 16 infections and HPV 16-18 related CIN 2+ lesions. There were other exploratory outcomes like persistence and incidence of any 1 or more of HPV 6 and 11, or any 1 or more of HPV 31, 33 and 45, or any HPV type. So after statistical analysis, when they found out the results, the vaccine efficacy against persistent HPV 16-18 among the participants was 95.4% in the single dose cohort, 93.1% in the 2-dose cohort, and 93.3% in the 3-dose cohort. So to conclude the study, in the longitudinal cohort, the efficacy of a single dose of the quadrivalent HPV against HPV 16-18 persistent as well as incident infections was similar to 2 doses or 3 doses in 10 to 18-year-old girls on a 9-year follow-up since vaccination. So this was an Indian study. After this, there was also a Kenyan study which was published in April 22. Here what they did was a randomized multi-center double-blind control trial. Here they studied single dose of the nonavalent vaccine or the bivalent vaccine and compared it with the meningococcal vaccination. Here they studied slightly older adolescents and young women, 15 to 20 years of age. So they recruited around 2,000 women between 2018 to 21, and 1/3 received the nonavalent HPV, 1/3 received the bivalent HPV, and the remaining 1/3 received the meningococcal vaccine. So here also they enrolled the patients and collected 6 monthly cervical swabs, and at month 3, the vaginal swab was tested for HPV DNA. Enrollment sera was tested for HPV antibodies. Now they made a cohort which they called as the modified intent to treat cohort. This cohort basically included participants who had a HPV antibody negative result at enrollment and a HPV DNA negative result at enrollment and also at month 3. The primary outcome here was studied as the incident persistent vaccine type HPV infection by month 18. So when they extrapolated the results, they studied that there were 38 cases of incident persistent HPV vaccine, HPV 16-18 in the population, out of which 1 occurred in the nonavalent group, 1 occurred in the bivalent group, and 36 in the meningococcal vaccine group. So when they compared the vaccine efficacy of the nonavalent versus the meningococcal, which was used as a control, it was 97.5%. Similarly, the bivalent versus the meningococcal was also 97.5%. So over the first 18 months, this study is still ongoing. Of this ongoing trial, the efficacy of the single-dose bivalent or the nonavalent HPV vaccine was very high among the Kenyan adolescent girls and young women. So this demonstrates that there are high levels of protection against vaccine-specific oncogenic HPV infection. So as already discussed, the protection was 97.5% for both the vaccines. So after both these studies, WHO came up with a position paper in 2022 on the HPV vaccine. The previous position paper was in 2017. Here, certain recommendations were changed. So now the WHO recommends, the first study, Indian study, was for 9 to 14, whereas the Kenyan study was for 15 to 20 years of age. So here now the WHO has come with a recommendation of a 2-dose schedule for girls and women aged 9 to 20 years. The minimum interval between the first and the second dose should be 6 months. For women older than 21 years, ideally recommended is a 3-dose schedule at 0, 1 to 2 and 6 months. But WHO has now given the recommendation in this position paper that 2 doses with a 6-month interval for women above 21 years would be as effective as a 2-dose schedule. And alternatively, the last line here is very important, a single-dose schedule has been now recommended as an off-label option, which can be used in girls and boys aged 9 to 20 years. So this is a very important recommendation of the WHO position paper on HPV in 2022. So to summarize both these studies and the WHO position paper, it says that the current evidence, a single dose has comparable efficacy and duration of protection as a 2-dose schedule, and it offers many advantages. Firstly, the vaccine now becomes more efficient, it becomes more affordable. It of course contributes to an improved coverage, and when we're using this vaccine in the public health perspective, the use of a single-dose schedule can offer substantial benefits that outweigh the potential risk of a lower level of protection if efficacy wanes over time. Now, there is no current evidence of this. This has been stressed upon by Sir already. So, these were the references for the snippet which I presented. Thank you.
Thank you so much, Dr. Amruta, for the brief snippet. I would request Dr. Tanushree to kindly felicitate Dr. Amruta. So we move on to the next session, which is a panel discussion. Zara hatke, zara bachke, ye hai vaccine meri jaan. So there are 4 vaccines which would be discussed in this session. So we have, for this, moderating the session, Dr. Nehal Shah. Ma'am is a consultant pediatrician at Saifi Hospital in Ruxmani Lying in Hospital and the Secretary, Mumbai IAP. I call upon the panelists, Dr. S.G. Kasi sir, whom we have already heard so many times now. Dr. Sudhir Sane sir, the head Department of Pediatrics, Jupiter Hospital. Dr. Chetan Trivedi sir, practicing pediatrician and neonatologist from Gujarat. Sir has been past president Academy of Pediatrics, Ahmedabad. Over to you, ma'am.
Good afternoon, everybody. So today's talk is Jara Hatke, Jara Bachke, ye hai vaccine meri jaan. So why Jara Hatke and Jara Bachke? Because the vaccines that we are going to cover are not in our routine immunization schedules. They are thoda hatke. So bachke becomes important because there is a lot of ambiguity regarding when to give, whom to give, kitna boosters, which dose, what formulations. The session is also going to be a little hatke and bachke because here we are going to be a little more objective. Try to be one word, one sentence, yes or no, and few brief notes like absolute study class. And bachke because if you are going to miss it, then you're going to miss the golden words coming from this expert faculty here today. So let's begin. So our first vaccine that we are going to cover is the rabies vaccine. So quick revision of the categories. So category 1 is touching or feeding of animals, licks on intact skin, contact of intact skin with secretions and excretions of rabid animal and human case. Category 2, of course, nibbling of uncovered skin, minor scratches or abrasions without any bleeding. And category 3, single or multiple transdermal bites or scratches, licks on broken skin, contamination of the mucous membranes, and with saliva. So my first question, Dr. Chetan Trivedi, sir, how early is early after the dog bite?
As early as possible, I must say, because whenever we have a history of dog bite, first and foremost thing is we should not run for the vaccination, but I think first is the wound care is very important. And for that matter, we have to understand that we have to just keep the wound under running tap water, that you have to keep it for 15 minutes. That will remove almost 50% of your viruses from the site, from where this virus is going to enter into the body and going to now tissue. Second thing is, after doing that, you can use any of the 3 antiseptic solutions. So I would like to take the name of the stand, like Betadine, Sevlon, or Dettol. So that's okay, fine. You can use it. And then after doing that, you have to think about the vaccination as early as possible. Depending upon the categorization, you will decide whether the vaccine to be given RIG or monoclonal antibody, and then we'll go ahead for that.
So going the other way, how late? So suppose this patient has not come in the first 24 hours. Till what latest can we give it?
See, usually what happens, this rabies is having a long incubation period. So we have seen on record 6 to 7 years after the bite, the 1 or 2 anecdotal cases been there. But most of the time it is 1 year or so till the bite you get a chance of this rabies. So even if it is late, after say 1 month, 2 months, you have to consider it's been happened just today only, and you have to categorize and give the vaccination or RIG as per the schedule.
So audience, if you have a history that somebody had a history of dog bite 1 to 2 months back, and the parent suddenly realizes that the animal died of rabies, he can still come and take the vaccine if he was not taken it earlier. So, Kasi sir, the latest recommendation of post-exposure prophylaxis in regards to 5 versus 4 doses, the controversy.
Opening a Pandora's box. Okay. Now, the standard recommendation by the NCDC, National Communicable Disease Control Program of the Government of India, still remains 5 doses of PEP and 3 doses of PREP. Okay. Now in 2018, the WHO came out with shortened recommendations, that is 4 doses for PEP and 2 doses for PREP. Now this entire new recommendation was based on certain observations, the main feature of which was that protective antibody titers are reached in almost 100% within day 14 of the first dose of the vaccine. There is no significant rise in antibody titers between post 4 and post 5. There is very little increase. So giving the 5th dose is probably of not any benefit versus giving only 4 doses. This was the main reason why this recommendation came. This recommendation was accepted by the WHO, also by the ACIP, American Academy of Pediatrics. But NCDC has not accepted it because they feel that in a country like India, where the burden is very high, reducing the number of doses will require a lot more data than what has been generated for the WHO recommendations. And they will insist on local data. So now for us, practicing pediatrician, which should we follow? And I think, as Dr. Nitin Shah has mentioned many times, for a disease like rabies, more number of doses will probably be better than less number of doses from the purely medico-legal point of view. And as has also been mentioned just a short time ago in the same, when there's a legal dispute, I think national recommendations will take precedence over any local professional body recommendations. So from that point of view, from a legal point of view, 5 doses. But if you look at the scientific data, 4 doses is sufficient. I think I have confused you all enough. I don't think I have given any
No, sir, absolutely
data, but
clear.
this is, you cannot go anything beyond this.
So the message we take is we are still going to stick to the 5-dose post-exposure prophylaxis. Sane sir, what if one misses a dose of the vaccine as per the schedule? We are talking about the 5 dose.
You can give as soon as the patient, healthcare contact immediately.
So if he took a 0 dose and the 3rd day he missed, he comes on the 5th day. So do I consider the 3rd on the 5th day?
Yes. You
and then how do I consider the 7th day?
From there.
From
so
the
4
first
days
day?
after 5th.
So I count the 3rd dose from the 1st dose or the 2nd dose?
3rd dose from the 2nd dose.
From the 2nd
Second dose. 4 days from the 2nd dose.
I think there are no standard recommendations for this question. There's only one printed recommendation, that is by the Immunization Action Coalition, which is a sister organization of the US CDC, where they have mentioned, like for example, if the patient misses the 3rd day dose and comes on the 5th day, you maintain the gap between subsequent doses. But from the immunological standpoint of view, you should complete the schedule as early as possible. So, I mean, it really doesn't make any matter whether you alter the subsequent schedule or don't alternate. Basically, finish the schedule with the given number of days.
Sure. So what if my patient has taken accidentally in the gluteal region and come, 1st dose? We don't
invalid
count it.
dose, absolutely invalid dose, restart the schedule.
Suppose he's taken the 1st dose at a government center and come to you for the 2nd dose. Intradermal ke baad intramuscular.
For logistic purposes, interchangeability of route and brand is permitted, but there is no scientific data to support these recommendations.
So that answers the second question as well, that are rabies vaccine types interchangeable? You could, with so many brands available.
Try to avoid interchangeability, but if there is no alternative, interchangeability is permitted.
Sure. So this question is also partly answered by sir, that pre-exposure prophylaxis, 2 doses versus 3 doses. So for all medical legal aspects, we stick to the pre-exposure as 3 doses.
That's my personal opinion.
Sir, to a practicing pediatrician, would you be able to enumerate 1 or 2 conditions where you will tell them to take a pre-exposure prophylaxis? Indications, you have a pet dog or whatever, sir.
It's for me?
Yes, sir.
Yeah. Okay. Now, basically, there is no classification, but the US CDC has classified 3 grades of risk. The highest risk is those who are in contact with live rabies virus, lab workers, people working in rabies production facilities, etc. So for them, I think actively pre-exposure prophylaxis. The second group is those who are on moderate risk, and that is where many of us healthcare workers dealing with rabies patients. And the lowest risk is children in contact, postmen, delivery persons, etc., who are in risk. So these are the 3 main groups, category 1, 2, and 3. Highest risk, moderate risk, lowest risk for rabies. So basically, all these categories should receive pre-exposure prophylaxis.
Thank you, sir. So any absolute, yes, sir.
And category, sorry.
No,
yes,
please, no. The only thing is, I think, personally, and even the ACVIP in 2014 had made this recommendation, children with dogs at home actively promote pre-exposure prophylaxis to all the family members.
So for high-risk patient, as Professor Cassie said, we need to do, you are not professor, okay, so Dr. Cassie said, so you talk like a professor. So you should give also booster every 5 yearly or at least do antibody titer. Okay. Yeah.
So any absolute contraindications to pre-exposure?
No absolute contraindication for rabies.
So this was the next question, sir. Sane sir, you can take this. Are any boosters required for this group?
So
and at what interval?
Yeah, if there is a persistent risk of infection, say for example those lab workers working in rabies lab, then not only they need antibody titers to be done, but every 5 yearly booster.
5 yearly booster.
5 yearly booster.
Sure, sir.
For those at very high risk, the category 1, do it every 6 months and give boosters if it falls below 0.5. Otherwise, they say either give a booster every 5 years or do antibody titers every year once.
Every yearly, sir. Okay, sir. Sir, and so we got that, indications of anti-rabies. Chetan Trivedi, sir, can you take this re-exposure prophylaxis? So suppose post-exposure somebody is taken, pre-exposure somebody is taken, and there is a re-exposure. So within how much time is he protected? When should he take it again?
Correct. So there is 2 things, pre-exposure and post-exposure. If the person has finished pre-exposure as well as post-exposure prophylaxis, after that within 3 months, if they get exposed to rabies or any bite, then you should not do anything other than wound cleaning. If it is more than 3 months, then you have to give 2 doses at 0 and 3 days. Only 2 doses are required. No need for rabies immunoglobulin or monoclonal antibodies. Because if person has already received vaccine any time in the life, except for in immunocompromised condition where we will give RIG or monoclonal antibody, rest we have to give 0 and 3 dose to IM, that's all.
Thank you, sir. So, Sane sir, special conditions, pregnant woman, we can give it
because
safe.
rabies is 100% fatal, there is no contraindication, there is no special precautions, it's not a live vaccine, so you should give to all these conditions.
Pregnant woman, lactating woman, early infancy, you have a 2-month-old also, you can give it safely.
Absolutely.
There is a history
Newborn
of
also.
atopy. So this is in
Absolutely.
regards to immunoglobulin. Any problems or we can give it?
You can give it.
You can
So
give it.
only thing is if you have risk of rather atopy or something, you give it in a setup where you can tackle the atopy or anaphylaxis if anything happens.
Right.
That is very clear. And lastly, immunocompromised host. I think you have to change the category. If it is in category 2, you have to treat as a category 3. And you need to see for the antibody titer, seroconversion is there or not. Because otherwise you have to complete the dose.
Yes, sir, Kasi sir.
About maybe 8 to 10 years back, I had an occasion where I gave rabies immunoglobulin human and I gave the first dose of Rabipur in my clinic and the child developed an anaphylaxis. Resuscitated adrenaline, that is a different issue. Subsequently, we hospitalized the child and started giving decreasing dilutions of the vaccine, starting with from 1 in 100 coming down to full dose, all done in a space of about 1 hour to 1.5 hours. And we managed to completely immunize the child. And surprisingly, for the subsequent doses, there was no reactions at all. They tolerated all the subsequent doses. That's the only time I have experienced anaphylaxis with rabies vaccine. It's enough to cut short your life by 10 years, let me tell you.
So next question, Kasi sir. Although it seemed a little impractical when I was putting it down, but this was actually what I faced. So one of the patients who was out for a safari and was doing giraffe feeding got bit on the hand and there was a proper wound. So there was no immediate IG available because he falls in category 3 of wild bite with this thing. So in this case, does the dose of our rabies vaccine change, the dosing change as fast as quickly, or does it really change, sir?
Okay. First, any bite in the wild should be taken as a category 3 exposure. There is no category 1, 2 for wild bites. All mammals can transmit rabies, so any sort of mammalian bite is an indication for rabies prophylaxis. In this case, some data suggests employing what is known as the Zagreb schedule, where you give 2 doses on day 1, followed by 7 and 21. So it's a 4-dose schedule. On the other side, there is no data to show that giving 2 doses on the same day will give you superior antibody titers. But this is the only thing you can do. But I still feel the earliest available opportunity, this guy should go and take rabies immunoglobulin locally.
Sure, sir.
Even if he has taken 2 doses on day 1.
Right, sir. So for the audience, which animal bites do not require a rabies vaccine? Domestic rodents. So human to human. Dr. Jitendra said human. So can human to human transmission happen? Yes. So theoretically only corneal or organ transplants. Which other rodent then? Rabbit and squirrel. So I think leaving rodent, rabbit and squirrel, rest all. And what is the longest?
Case of squirrel,
See, all these are for domestic. If a rabbit bites you in the wild, you have to take the vaccine.
Squirrel?
Sorry, sir. Elephant bite. So that is why I said giraffe. I didn't say lion or anything else. So what is the longest incubation period of rabies after a bite reported in literature? 21 nahi sir, wo ball. 7 years. So 7 years is what I got in literature.
Madam, one last comment.
Sure, sir.
We say squirrel bites don't give post-exposure prophylaxis. There is data from Kerala where rabies has been reported for all squirrel bites, and when they've examined the sera of squirrels, they have found rabies virus in circulation. So I think we should be a little hesitant to say that you don't need PEP for squirrel bites.
Even Sri Lanka, there was.
So give even when there is a squirrel bite to be safe, sir. Yeah, yes. Give.
Absolutely, because
For
vaccines
rabies,
have
give. Just
yeah,
give.
Vaccines have become so safe that there is no point in.
So moving on to the lifesaver, the rabies immunoglobulin. Kasi sir, can we take this with you? So
Okay.
indications, dose, sites, sir, you can talk about it.
All class 3 bites, all class 2 bites in the immunocompromised requires
Rabies
passive
immunoglobulin.
protection, rabies immunoglobulins or monoclonal antibodies. The dose for equine 40 international units per kg, for the human 20 international units per kg, rabies shield 3.33 international units per kg. For twin rab, it is 40 international units per kg. Mode of administration, intralesional only. IM immunoglobulins is useless. Studies have shown where when after giving intramuscular rabies immunoglobulin, they have tested the antibody titers. In the vast majority is less than 0.03 international units per ml, when the protective titer is 5, almost 10-15 times higher. So IM is of no use except in very special situations where the site of exposure unknown, like in aerosol exposure, either in the lab or bats, which is not an issue in our country. Okay, so mode of administration is only into the lesions, every lesion that is present. So it is important the younger child, strip the child and examine the full body for any hidden bites which are not very obvious, because they are the causes for vaccine failure. Now, if the wound site is very small,
how do we?
See, generally, you cannot, for now, if you get a wound, small, say, 2 millimeters in the fingertip, it is anatomically impossible to give the full dose. So, generally infiltrate properly till the RIG starts oozing out of the wound. And in fact, this was a very seminal study done by Umesh Bharati from Himachal, and that was the basis why WHO made the recommendation that you don't have to give only the smallest volume that you can give in that particular site. So certain sites you cannot give the full volume. On the other hand, if you have multiple bites, you can dilute the serum. How much can you dilute? As much as is necessary. Theoretically, even dilutions up to 500 times is sufficient to give you adequate levels to give local protection. So depending upon the volume that you need, you dilute it. There is no upper limit to it.
So how many shots of HRIG? The same, it remains that one. And how
single, then throughout the lifetime, there is no need for a second dose.
Absolutely.
So even ERIG, in case you develop antibodies, it's really not going to matter, because you're never going to give a second dose, unless if you're immunocompromised.
Sir, for immunocompromised?
Yeah.
That's it. In immunocompromised, you will have to give a second dose. How
soon after administration would the passive protection start?
It is immediate, because you are directly giving pre-formed antibodies.
Right,
and that's the reason why we see when you give a vaccine, in about 65 to 70, you have protective antibody titers by day 7. By day 14, everyone has it. And depending upon the site of the wound, if it is very close to a nerve terminal, it can get attached to the nerve roots very quick. So earlier you give it, much better. So utilize that window period where there is lack of protection with vaccines to give passive protection.
And safety, efficacy, of course, beyond doubt.
Safe, not safe, you have to give it. That's it.
Chetan Trivedi, sir. So types of monoclonal antibodies, mono versus twin. Dose, sir has already said. Any advantage over rabies immunoglobulin?
See, these are the monoclonal antibody is now been coming up as an option to rabies immunoglobulin. Because we know that immunoglobulins are coming from animal sources, and there is, restriction because there is a cost is high. It has not been available in enough quantity. So this monoclonal antibodies have been produced in such a way that there can be reproducibility. So bulk of it can be produced without any change in their consistency. So we have monoclonal antibody two types. One is a single monoclonal antibody, and another is a cocktail of two monoclonal antibodies. So monoclonal antibody single, which is from Serum Institute, that is Rabies Shield, which has been tested for almost 25 different wild as well as street rabies viruses. It has been effective very well, and the dose is 3.3 international units per kg, and that you have to infiltrate into the wound as we are doing it for rabies immunoglobulin. While this one, the twin monoclonal antibody, it is coming up from the another company, Zydus, and that is TwinRab, and here they have two monoclonal antibodies, right, DOCA and Miro. And what they want to say is Peruvian bites. There are certain this thing which has been covered by this two monoclonal antibodies. WHO has recommended more or mirror, rather two monoclonal antibodies should be there in a cocktail should be there. That's been recommended. And the dose of this twin rab is 40 international units per kg to be infiltrated in the wound.
Sure, sir.
Anything, because this screen display.
Yes, sir. No, that's it. So, yes, sir.
I defer to with you that mono and twin. My mono and twin. Mono and twin, I beg to differ because there is no difference whether you give mono or you give twin. Both almost. You said give more the better, more. No.
It's WHO has recommended that more than 2 monoclonal antibodies is preferred. WHO recommendation is there.
No,
in practice, there is no difference whatsoever.
No difference.
We can use it because Peruvian bite is the only thing which has not been common.
One important question, very often it is asked that a child comes to you for the 4th dose of anti-rabies vaccine and is not been administered the passive prophylaxis. How do you tackle this child? You can't give, I think.
More than 7 days, we don't give.
14 days maybe, sir.
I think we need to revise our thinking on this issue. Now, why do we not give RIG? Because we feel it is going to interfere with the vaccine take. I just told you that studies have shown that with intramuscular, absorption is very poor. The titers are less than 0.03 in the vast majority. And they have not reported any titers more than 0.3. Highly unlikely that there will be interference. So I personally feel even if he comes at the 4th dose, give. After that, what to do? There are 2 issues over which there is a debate. I think this is going outside the standard recommendations. You have 2 choices. Either you believe in your scientific data and say it is not going to interfere and complete the schedule, or if you are not sure, still feeling shaky, restart the schedule. I think the importance of RIG is supreme in preventing rabies in that particular child. Believe me, you are giving the vaccine more for sustained protection. And for immediate protection, if you say choose between vaccine and choose between RIG, RIG is more important.
Sir, can I have a differing voice here?
Can we have that late? We won't be able to cover the
Okay.
So at the end, we are going to have 45 minutes. So interesting facts, of course, Goa is a rabies-free state. And of course, this was the lady who was 15 years old when she became the world's first known survivor of rabies without receiving any vaccination. And of course, her miraculous survival challenged a time-honored scientific fact. She was put on medical coma for 2 to 2.5 months thereafter. So coming to the next vaccine, Japanese encephalitis. Kasi sir, which Indian states or places in MMR region have JE on their routine immunization schedule?
What is MMR?
Some Maharashtra, Mumbai. Sir, हमारे काम का है ना sir.
Maharashtra, you answer, please.
I mean, I don't
if you
know.
tell me Karnataka, I can give you that.
I'm not sure where, which MMR region.
Sir? Okay. So except Mumbai.
Except Mumbai, all have been declared endemic. Wow, great.
So except Mumbai city, every else. Huh? So audience, who is the natural reservoir for JE virus? Natural reservoir. Pigs and wading birds. Is human-to-human transmission possible?
No.
Because it's a neurotropic virus. Sane
It's
sir,
not only neurotropic. You see, for JE to transmit, a certain level of viremia has to be achieved in the host. And except for dogs and ardid birds, no other animals can produce that level of viremia for transmission.
Pigs or pig.
Except for pigs and ardid birds, no other animals can produce that amount of virus.
So human beings cannot transmit
to the other. So, Sane sir, which types of JE vaccines are available for routine use? For
we have 2 types of vaccine, live 1442 Chinese-made vaccine, and the recent kind of entrant, Genevac, which is again derived from that 1442, but it's a Varosep-killed vaccine, and it's an indigenously made vaccine.
There are 2 inactivated vaccine, Virocell derived. One is JEEV and Genvac, right? So one Genvac is like it is Kola strain which are using. Jeev is using this one, SA1442. So one is a live which has been there in the government schedule, and it is to be given, say, earlier, maybe 8 months onwards. So 9 months they are giving first dose, and second dose they are giving between 12 to 18 months. So that is about a live attenuated vaccine which has been available, the Chinese brand, which has been given in the government setup. Rest two, they have been available for private sector, and that is to be given after 1 year. And there is a different dosage. Do I need to?
Yes, we'll come. So inactivated for us for use for private practice. So are they interchangeable? The question always comes.
Again, that will be said. It should be unavoidable. But government, because for the programmatic reason, they have been allowed to interchange whatever they have been given.
Kasi sir, what is the safety profile of live attenuated JEV, and what is the available Indian data on IC51 by GEV? Any clinical data available regarding long term? You can take everything.
Safety profile in whatever post-marketing surveillance have been done in our country, the vaccine has shown a remarkable safety profile, very little of local reactogenicity as well, and there is absolutely no neurovirulence of this particular vaccine. It's a very stable attenuation, and reversion like OPV has never been demonstrated with this particular vaccine. Now, regarding IC51 data, GEV, only a immunological non-inferiority study has been done in the country, not a efficacy study, where they have compared GEV with the old mouse brain vaccine. Okay, and that vaccine has shown definitely a superior immunological, statistically superior response compared to the mouse brain vaccine. I think this is as far as the Indian data is concerned. Of course, there are other studies where they have just done an immunological profile where they have found that following one dose, the seroconversion is about 52%, and following 2 doses, it reaches 98%. So that is the Indian data regarding GEV.
Sure. Sani sir, what are the IAP recommendations for Japanese encephalitis? So partly we covered, but what is does it change in the outbreak areas?
Outbreak areas, you start early at 9 months of age and give 2 vaccines, 9 months and one after 1 year of age.
Okay. 2 doses, sir.
So if you give, so Genevac, the product insert says 1 dose after 1 year of age. And I think in a low endemic area, it's an individual choice. But I take that choice that 1 dose after 1 year in low endemic area. But it's an individual pediatrician choice.
I think that the very clear, even ACVIP, even Government of India has been giving 2 doses of whatsoever vaccine available. So, of course, live attenuated vaccine, they are going to go give 2 doses. But even GEV or Genvac, if government is going to procure and give it to in the national immunization schedule, they will be giving 2 doses. Except for campaign mode, they can give single dose. Otherwise, it's all for all reasons. It is 2 doses. And why it is required? Because, yes. So, Kashi sir, you can.
Now, the ACVIP again in 2014 had said 2 doses. Why? The DCGI made a recommendation of 1 dose because in the phase 3 studies they found that this, as far as Genvac is concerned, that even those who had missed on the schedule and taken only 1 dose, they had close to 85% seroprotection rates. Subsequently, they did a phase 4 study where they compared 1 dose against SA1442. High seroprotection rates of over 95% were detected over a period of 1 year follow-up. 365, I think 720, 2 years of follow-up. Now, if you look at the antibody titers following 1 dose versus 2 doses, with 1 dose, it is somewhere around 125 units. I'm not very clear about, but it is somewhere around that range. With 2 doses, it is 416 units. Now, you must remember for all killed vaccines, protein-based vaccine, the titer always goes up, a rapid fall over 4 weeks and a more sustained fall. That is the antibody kinetics. So the higher the titer, the longer will be the duration of protection. It is basically, then the second thing is we do not know to what extent natural boosting is occurring in an individual place. So taking these 2 factors, the ACVIP has said that it is preferable to use even Genvac in a 2-dose schedule till a decision about booster doses of inactivated JE vaccines are taken. This is the present situation.
So that is the next. Considering the fact that the immunity wanes over time. Yes. So booster doses are indicated when, how many?
And incidentally, there was one study done in Thailand with a vaccine similar to GEV, the original Ixaro, where they gave single dose and a booster dose after 1 year. They followed them for 36 months. Seroprotection rates, antibody titers were higher with the 2 doses, but the seroprotection rates were similar in both the groups.
And based on that, they did a modeling study and found that based on the antibody decay kinetics, protection is expected for about 109 months. That is close to 9 years.
9 years.
So,
Right,
but
sir.
a child who has been vaccinated in your clinic is going to rural part of Bihar, say, and going, okay, then you can give booster again.
So that's what. So what is the time period of vaccination before travel to endemic area, sir? Kasi, sir? And in
All
that case,
inactivated vaccines 2 weeks, all live vaccine 4 weeks.
and how many doses? And in case there is a continued risk, then a booster, as you said.
Yes.
Right, sir? So, of course, can it be given to pregnant, lactating, and immunocompromised?
Inactivated vaccines can
No
be given.
No live vaccine.
No live vaccine.
Sure, sir. Can it be co-administered with MMR at 9 months? Sudhir Sane, sir, yes, no?
Yes, obviously.
Yes, sir. And of course, JE vaccines first became available in 1930s. Initially, it was an inactivated mouse brain, as sir said. Now discontinued due to its uncertain protection, multiple doses, and unacceptable neurological adverse effects. So moving to the next vaccine, meningococcal, considering the underestimate burden versus the cost factor in routine use for us in our immunization practice. Can you enumerate the high-risk groups that justify MCV? Sane, sir.
So I think certain congenital complement deficiencies, certain patients who would be on some, immune modulating substances which can inhibit complements. These are the two main groups, and sickle cell patients. These were patients who are high-risk category, and the second category is patients who are staying in high-risk areas. So, if there is an outbreak, these are the two high-risk groups that would justify MCV routinely.
So
One more group are lab workers and all that who can get exposed
Lab
to
workers splenectomized, as a splenic.
In our setup, most common is splenectomy.
Sickle.
And sickle is, there is autosplenectomy in that.
Right, sir. Sane, sir, what are the different types of meningococcal vaccines available for use? So polysaccharide, so which ones? So which form?
Mainly conjugate vaccines
Right.
now that are available, and we all know the difference between polysaccharide and conjugate vaccines. We have two conjugate vaccines available. One which is conjugated with diphtheria DT protein, and other is CRM protein. Both of them, are almost equivalent, except there is slight difference, and which we'll talk when. Should I talk now, or?
There is,
Okay.
it's going to come. Kasi, sir, what are the IAP recommendations for meningococcal, and what is the IAP recommended schedule of conjugated meningococcal vaccines?
First, IAP recommends this very clearly only as a vaccine for use in special situations and not for routine use.
So, point.
Have no doubt about it. Okay. Now the recommended schedule is earliest age it can be given in our country is 9 months. For your information, MenVio is recommended from 2 months of age in US, but in our country it is only about 2 years. So 9 months onwards, MenVio, 2 doses at least 3 months apart. Menactra, single dose after the age of 2 years. MenVio, single
MenVio,
dose
sir.
above the age of 2 years.
Other way.
Okay. Now, do you need to give a repeat dose? You need to give repeat doses when there's continued risk of exposure or immunocompromised. In that case, if the first dose of the meningococcal conjugate vaccine has been given below the age of 7 years, you give one booster after 3 years and subsequent boosters after 5 years. If the first dose has been given after 7 years, you give repeat boosters after 5 years. And generally in the immunocompromised, you will require 2 doses for priming. Unlike single dose for those above 2 years.
Above 2 years.
Now complement deficiency, even if it is about 2 years, you will give 2 doses as the priming.
Clear, sir.
I think HIV also is an indication, 2 doses.
HIV. So is the immunogenicity of both comparable? So,
So I think, yes, the immunogenicity is comparable for 3 strains, but as far as group A is concerned, MenVio has not shown non-inferior immunogenicity for type A only in the 2 to 5 years group. But if you take 2 to 10 years as a single group, then there is non-inferiority. So except for type A, some little doubt is there regarding the non-inferiority. Again, we really do not know how important it is to achieve that particular type of a protection against the disease. But anyway, on paper, I think both vaccines are the same. There is no difference.
Trivedi sir, what are the efficacy studies of meningococcal, any available in India that it's?
I think meningococcal vaccine, diphtheria toxin, that is Menectra is having studies and they are showing around 80 to 85% efficacy. Only thing is this Menvio, as sir said, it has been compared, like for non-inferiority trial was done.
Efficacy studies,
One
because
study has shown that with Menectra, within 2 years of introduction, the efficacy was around 82%, which came to around 72 to 73% at the end of 5 years. Only one efficacy study is there. See, when you have a vaccine with a known correlate of protection, you don't have to do efficacy studies.
So Kasi sir has answered this already. Are booster vaccinations required? So in this particular age groups, these particular patients, high-risk groups, when he already said less than 7 years if they've received, and more than 7 years every 3 years, and then later on after 7 years every 5 years.
So one more thing is that if you have actually vaccinated patient at 2 years of age and the person is going abroad, say.
So that's good.
Yeah, okay.
One-liners. For the audience, so which neurological illness is meningococcal vaccine associated with? Sir, aap mat bolo na, sir. Anybody? Guillain-Barré syndrome. So there is always
primary dose schedule. So, it's an extremely unlikely situation that the patient is taking PCV from government and he comes for Menectra to you. Don't give along with the PCV. When more commonly for us pediatrician is patients going abroad and they have not given DTAP and Menectra, you give either simultaneously or Menectra before DTAP. There has to be a gap of 6 months at least between DTAP and if we are following that with Menectra. This is a CDC recommendation.
So just a clarification, PCV 13 not to be given with meningococcal vaccine. Menvio and PCV 13 can be given, but PCV 13 and Menectra cannot be given. So in the government setup, suppose in Gujarat they are giving Pneumocil, so there is no problem. There are no studies. But this PCV 13 and Menectra, they cannot be.
So actual very practical problem when students are going abroad, because many times they come to you within.
So if you got to give both the vaccines interference, so keep a 6 months gap. Generally, now two things. One, meningococcal vaccine, we earliest recommended age is 9 months. And you usually finish your DPT by about 3.5 months. So usually interference will not be observed at all. So I don't think that situation is applicable in our country at all.
TDAP, sir, 10 years, if they come to you for, that's the thing that so many times we give together.
No,
and
there is no mention about non-compatibility of Tdap and meningococcal vaccine.
Okay.
In fact, simultaneous administration studies have been done with Tdap and Menectra and have shown that there is no interference.
Concurrently, yes, sir, but
Yes.
subsequently?
No, I don't understand.
First TDAP and then if you give Menectra, that there has to be a gap of 6 months,
No, not what Tdap.
So what I was saying was that this PCV actually is only PCV 13, and all this giving together, not together, is only for asplenic patients. All our patients who are going abroad are not asplenic.
Right.
I think that you're very right. You pointed out.
Right, sir. So we discussed students going for studies abroad. We said it's mandatory, less than 21 years, they need one shot of PCV 13 given at least 5 years before the date of travel, and which one to give, which one not to give, sir has already said. So Hajj pilgrims?
Hajj pilgrims, the requirement is that they need to take one vaccine at least 10 days before start of journey. If you are giving a polysaccharide vaccine, it is valid for 3 years. If you are giving a conjugate vaccine, it's valid for 5 years.
And they prefer ACWY because they
insist on quadrivalent.
Quadrivalent, yeah.
Not bivalent.
Y and W135 is common there. Yes. So they insist for ACWY.
So and all these travelers to African meningitis belt, they can take it from the government. So what?
Yeah, so that is important. If you are going to this meningitis belt, you got to have the yellow card of the WHO filled up. So the vaccine is to be taken only at authorized centers.
That
if
is
you do
a
it in your
practical
clinic and give a vaccine, they will not accept it in the international travel.
So most of these special situations, sir has already said. The first outbreak in Africa was recorded in 1840, but it wasn't until 1887 that the Australian bacteriologist identified the meningococcal bacteria as a causative organism. And of course, Heinrich Quincke sir helped us in lumbar puncture to diagnose. So moving on to our last Hatke, 3 minutes, sir, 3 minutes, huh? So moving on to our last Hatke and Bachke session, hepatitis A vaccine, always the big question, live attenuated versus inactivated. Kasi, sir.
As far as prevention of hepatitis A is concerned, there's nothing to choose between the two vaccines. Both have shown excellent track records. follow-up is much better with the inactivated vaccine. Now there's a little discrepancy when it comes to post-exposure prophylaxis. See, in post-exposure prophylaxis, you want early rise in antibody titers. Studies have shown that with even a single dose of the inactivated, I'll mention the brand because the studies have been done with Havrix only, 100% seroconversion is achieved within 18 days of vaccination, whereas the same thing takes 3 to 4 weeks for the live attenuated vaccine. That is the only situation where you may prefer. Second, of course, immunocompromised, you cannot use the live vaccine, you can use only the inactivated vaccine.
So both are equal except the situation sir said. Sane sir, one word, what is the minimum age of vaccination for both types?
1 year and above.
Sure. How long does the vaccine protection last in terms of years in an immunocompetent host? One word, sir.
So 10 years is what is data on minimum 10 years. They are predicted it to be 50
Kasi,
years
sir?
and more.
No, I think...
see, basically, hepatitis A is a long incubation period illness.
For live attenuated, 17 years data on record showing that there is a seroconverted, there have been almost 62% of population been having antibodies. So that is a very long-term study. So I think it's lifelong protection.
Yeah, modeling studies have shown more than 50 years for inactivated
40,
and
50 years
around
as well.
33 years for the live attenuated. But I think the protection is lifelong.
So are boosters after primary vaccinations required for both live attenuated and inactivated and normal immunocompetent? Obviously, they answered no. The seroconversion in the immunocompromised may be inadequate. So any dose changes or boosters required in these cases and any role of doing serological tests in this
think
group?
live cannot be given in immunocompromised. So only inactivated to be
So
given.
inactivated.
So that's all. Then we have to give the 2 doses. That's nothing more than that.
No, you will probably estimate antibody titers and give additional doses if the level goes below 10 MIU per ml, which is the seroprotective titer for hepatitis
So
A.
again, the same everywhere. Are they interchangeable? Yes, they are.
So
For
now the question will arise because
which is the Chinese new vaccine
Sinovac.
plus Havrix, they are interchangeable. There are studies regarding that. There is no
Audience-
recommendation that you interchange, but there are studies.
What is the infective period of a case of hepatitis A? Infective period, because the next question is, sir is going to answer based on that. What is the infective period of a case of acute hepatitis A infection? 2 weeks before and 1 week after. So Kasi sir, as you said, that there is a role of prophylaxis after exposure. Within how much period? What dose?
Hepatitis A vaccine, this is data regarding the inactivated. The recommendation, of course, even live attenuated holds true, except the limitation what I told you. If you give the hepatitis A vaccine as post-exposure prophylaxis within 2 weeks of onset of, within 2 weeks of exposure, protective efficacy is close to 87%, and it is equal to the protection offered by immunoglobulins. So the recommendation is 1 to 40 years. This is CDC recommendation. 1 to 40 years, give the vaccine. Less than 1 year, give only immunoglobulin. More than 40 years, give immunoglobulin and vaccine.
And the vaccine.
Yes.
within 14 days of exposure.
What is the mode of transmission to the close contact?
Pardon?
What is the mode of transmission to the close
So
contact?
of course, hygiene sir is important.
Same
but
source. Same source.
Common source.
So maximum, Sane sir, maximum upper limit of the interval in months between the first and the second dose of inactivated vaccine?
No upper limit.
No upper limit.
Whenever the patient comes second time.
So
you
in
give
that
it
case,
second.
revaccination or only the second dose?
Only the second dose.
So anytime the patient comes as late as after the first dose, you just give the second dose. So what is the recommendation for vaccination of an individual who has previously suffered with a clinical hepatitis but serologically not proven as HIV? Would anti-HIV antibody titer help, or should you go ahead and give it if the patient comes to you?
If it's a young child, the possibility is very high that it is hepatitis A. If it's an adolescent, older adolescent or a young adult, a good possibility it could be hepatitis E. So there's a need for the vaccine. So younger age group, should I do the titers? 2 things. It's not cost effective to do the titers, and second, a dose of vaccine given to one who is already immune will not harm in any way. So I would prefer to give the vaccine unless there is documentation of presence of infection with hepatitis A.
So one question, if we have got the hepatitis A positive, do that patient can get the hepatitis A infection again?
No.
This
Either disease or vaccine gives almost lifelong protection.
Anybody has seen those kind of, I have seen that one patient where 2 times it was positive.
See, there is something called relapsing hepatitis A. where the gap between two may be as long as 4 to 6 months.
Yeah, 6 months.
So this may be a relapsing hepatitis A of the same initial infection and not a reinfection.
So regarding live attenuated, most of the things sir has already answered, at what age, how many doses, seroconversion, we've discussed everything. So any absolute indications of inactivated over the live attenuated, immunocompromised host, which we've already said.
And
Sir, any Indian studies available on long-term seroprotection from India?
Very robust studies regarding the long term with live attenuated vaccine. I think that 10 years everyone is aware. Now I think the 14 years data is also available. Seroprotective titers of over 100 units are present. GMTs of over 100. And seroprotection has been in the range of 82 to 87%. So extremely robust, good efficacy studies from our own country, good immunological studies from our own country, which gives that it gives very good protection and is sustained for at least 14 years.
Sure,
Ma'am, can we
Trivedi
wind
sir,
off?
we are on the last question. Give me 2 minutes. Sir, Trivedi sir, could you briefly discuss the results of the studies regarding the mega trial in China, the large cohort of Chinese children who were...
So I think that is more than 11,000 kids were vaccinated, and it shows that it's a very good immunogenicity and even efficacy is very good. And what that immunogenicity is almost in the tunes of, they initially had say 98% and it came down to say around 80%. So that has been, there are many studies, but this is a study, and after that there is one more study, which is 17 years long-term study, where they have given a vaccine, single dose, hepatitis A live vaccine to the kids 17 years back. They took out those, out of that 47 were selected, and then they saw whether they have been seroconverted at 17 years or not, what is the situation of immune memory cells, B cells, T cells, and they found what is the boostability if we give hepatitis A vaccine exposure. And that what they found is 62% were still seroconverted, and those who were not seroconverted at that particular round, they got a very good boostability. So memory cells were very nicely been working. Even B cell and T cells, both have been documented that they are working even irrespective of their seroconversion status. So that is a wonderful study that reassures that single dose of live attenuated vaccine, it works and works for the lifelong.
Sure, sir.
So only thing is that live attenuated vaccine has slightly higher primary vaccine failure rate rather than killed attenuated vaccine. So
Sure,
that
sir.
I think one
So
point we
we-
should take that.
So we finish with our last slide. The first description of hepatitis epidemic, jaundice as they called it, is attributed as late as Hippocrates, and outbreaks have probably been seen all the time, 17th, 18th centuries, in association with a lot of military campaigns. Thank you.
One question to Dr. Kasi. A Bihar native who stays in Mumbai has taken 2 doses of JE vaccine. He goes to Bihar every vacation and spends 2 months every year in Bihar. How often should you give him booster? Does he need a booster?
No.
Before
No
sir answers,
in-
I request the delegates to kindly be seated. Yes, sir, please.
Yes,
Sorry.
thank you. Nowhere in any of the endemic countries is there a recommendation for a booster dose. Because your presence in endemic country itself means natural boosting. The problem occurs when you decide on your own that you need to give Japanese encephalitis vaccines to your patients, and there is no natural boosting because you're in a non-endemic area, then your protection is going to wane. Because US FDA, they have studied with GIV, Ixaro, their parent, and they have found that there is a rapid fall in antibody titers after 1 year, and they have recommended a booster after 1 year of age. So I think you've got to be very careful when you give JE vaccine in a non-endemic area, and that patient goes after 4 or 5 years to an endemic area, you do not know what her level of protection is.
Dr. Kasi,
How often you give this booster? How often you give booster? Every time they are going into vacation.
What's sir?
No, I don't think. This is a very hypothetical question. There is no answer. Endemic areas, no boosters as of now.
Thank you so much.
Thank you so much, everyone. I request the delegates to please be seated. Delegates, please be seated for next 2 minutes. I would request our IAP member, Dr. Tanushri, to kindly felicitate our moderator and the panelist, Dr. Nehal, ma'am. Dr. Sudhir, sir. And Dr. Chetan, sir. So after this sumptuous academic feast, we have a lavish lunch waiting, but still please wait for few announcements to be made by our president, sir.
Friends, IAP Mumbai had specifically invited a few dignitaries to grace this CME. So I will quickly just mention their names and acknowledge their presence. Dr. Amol Pawar, Secretary, Maharashtra IAP. Dr. Ram Gopal Chejara, ex-EB member of MAHA-IAP MMR region. 3 past presidents of Mumbai IAP as well as National IAP of Navi Mumbai IAP. And last but not the least, Dr. Bipin Shah, our very own past president, without whom you cannot get the lunch which is awaiting you. Finally, all of you know that we have a 7th May special GBM of IAP, Central IAP in Navi Mumbai. It is an earnest request to give your names at the IAP stall or talk to any one of us, but we want as many of you as possible to attend that meeting. We will facilitate transport, etc. Please come for that meeting. It is very important. Thank you very much. And just now, I mean, you all can divide. Some can go for lunch and some for your kids. Jitendra is faculty.
पीछे खुला है ना, हाँ, I think it's okay.
इसको बंद कर देते हैं।
नहीं, इसको रहने दो आप, ये
इसे
दिखाना।
मैम ना ऑल टैप करना, ठीक है?
So that we won't get delayed, you know, it's a Sunday evening, at least you will be with the family. Thank you. What? Nahi. एक second. नहीं, this one, this ऊपर वाला. So with our next talk, the topic of our talk is, do you know of the vaccine against shock? And for that, I would invite our speaker, Dr. Arun Wadhwa sir. And sir is a practicing pediatrician in Delhi, and he was an ACVIP member as well, and editor of many books and book chapters regarding vaccinology. So welcome you, sir. Yeah, thank you. हाँ सर. Shika, एक second. No, it went to some other thing.
एक folder है. They made a separate folder.
No, sir, we had added your CV in the same only.
अच्छा,
actually,
same
the
only?
previously, so that there is no.
अच्छा, sir, stock is after.
अरे यार.
बस ये रहने दो. So good afternoon, back to the CME. Now I've got two things to do. First is to tell you about the vaccine which prevents shock, and also to keep you awake after the sumptuous lunch. So as you must have guessed, this vaccine for prevention of shock, which one is it? Very good. Now I'll talk about all dengue vaccines. So first, before we start about this, I wanted to make it clear, you know, people some way say dengue, some says dengue. What is it all about? Which is the right thing? You know, so this is a Swahili phrase which is derived from this Eastern African language, which says that what it means is cramp-like seizure. And it's a very widespread virus. It's one of the most common. It is in 4 different types, which we'll talk to just now. And it's an RNA virus. So why do we need to give a vaccine? Is because of these 2 complications, which are the hemorrhagic fever and the shock syndrome. And that is why it was labeled as vaccine for shock. So how do we call it? Dengue, and dengue. Dengue is the real English pronunciation. Dengue is more like an American English. And dengue is purely in Hindi. You know, so when you say in Hindi it's dengue, like we should when we are talking in Hindi, but otherwise it should be dengue. No, it's like dengue, and dengue. So dengue would be something in between combination. English. So if we see, it's a very common disease. Half of the world's population lives in countries where dengue is endemic. And 75% of the global population can, usually living in the Asia-Pacific region, can get dengue sometime in their lifetime. This is a geographical distribution. As you can see, it's mostly in Southern America, but Asian countries, India is also one of them. It's a little better off than the developed world, but a little less than the South American countries. This is to tell you that, you know, the geographical distribution can vary, although DEN 1 and DEN 2 are the commonest, DEN 2 be the commonest across the world. This is actually in South America, but usually across the world, and it can keep changing. And DEN 3, 4 are less common, but over the years it can change also. So just now we should be concerned more about dengue 2, DEN 2 and DEN 1. And why do we need the vaccine? As we saw, it is half the world's population lives there. 75% of the population can be exposed to it in Asia-Pacific region. And outbreaks, as we have seen every year, they overwhelm the system. There is no therapeutic treatment for it. Prevention is only vector control. And obviously that means there is great pressure. So before we talk about the vaccine, we should also understand the natural infections. As I said, there are 4 dengue serotypes, and they are similar to each other to the tune of 60 to 75%. They give you lifelong homotypic immunity. This is important. There is no cross protection. There is some short-term heterotypic immunity. So in one season, probably you will get only one, but next season you can get the other one. So this is basically one must understand, and that is why when you have second infection next year, which I'll come to soon, you can have severe disease because of ADE. I'll tell you about this. So since you can get all the 4 diseases in your lifetime, 4 different strains are there, and there is no heterotypic immunity, you need to have a vaccine which is a tetravalent vaccine. So this vaccine should be efficacious, should be safe, should cover 4 different serotypes, can also be useful in children as well as adults. And if you have an outbreak, it should be given as an outbreak response also. And as I told you, one can have 4 separate dengue infections throughout your lifetime. And interestingly, they've seen that the 3rd and 4th one are usually very clinically silent and subdued. So it's only the 1st and the 2nd one which is the worst. So this is what happened in the waves also. They say the 2nd wave of a new virus is always most dangerous. So here also the 2nd infection is the most dangerous. And if we have separate vaccines for one of the each strains, Den 1, Den 2, Den 3, Den 4, compliance may be a problem. People may not come back for the other 4 doses. So all the vaccines which are under development are actually taking into consideration that it should be a tetravalent vaccine or should be covered. This vaccine, if it's not tetravalent, will also be, has to be like differ by region to region. As we saw in different regions, there are different vaccines. Some places where the dengue has been there for a long time, most of the adults are already immune. So children have to be the population target. And if it has been a new area where it has come just now, the disease, so adults also have to be taken into consideration. And obviously, all countries will want children also covered because they are our hearts. So there are certain challenges also why it's not being made so soon, why other vaccines came so fast. There is a lack of animal model. There's a potential fear of AD. Immune correlates still haven't been able to find. And also, we are trying to find out how long will the immunity last against all the 4 strains. So if you have a vaccine where tetravalent vaccine, but the immunity lasting only for 2-3 years for one strain, or 2-3 years, 5-6 years for another, that also is not right. But most importantly, there's no immune correlate of protection and there's no animal model here. So these are the strategies being worked, like we've been seeing corona also, prime boost, subunit, viral-like particles, VLPs, inactivated virus. But the 2 vaccines which are now licensed are the live attenuated viruses, which I'll come to just now. This is the landscape. So many vaccines are under trial. The first 2 have been licensed, rest are not. The 2 which have been launched are the Denvaxia and the Q-Denga. These 2 I'll tell you today. There are phase 3 trials going around in the NIH vaccine. One of them is in India, and that is being done by India Panacea Biotech. Panacea is doing it. And there are phase 2 trials, which again, 2 of them are in India. The last 2, as you see, Serum Institute and Indian Biologicals are also doing this. These are the vaccine, NIH vaccines. I'll tell you about these 3 vaccines today. First 2 are the licensed one, and the 3rd one, which is in the phase 3 trial in Brazil and India. So for taking the first vaccine, which is the TDV vaccine or chimeric yellow fever derived vaccine, it was first licensed in 2016, and it is licensed for 9 to 45 years of age. Can only be used in individuals who are seropositive and living in dengue endemic areas. Efficacy was around to the tune of 66%, and adverse effects were high, like headache 51%, 49% injection site pain. So half the people had some form of side effects also. And the second vaccine, which was licensed in 2022, can be given to children above 4 years of age, is efficacious against confirmed dengue and people who are naive against dengue. And pre-vaccination testing, that means is not required. That means you don't need to prove that you have antibodies. Interestingly, it's when you have the antibodies, then you give the vaccine. When you don't have the antibodies, you don't give the vaccine. And the side effects are more or less similar, 50% headache, 35% myalgia. So side effects point of view, it's not better than that. This diagram chart will explain to you. Yellow is the yellow fever vaccine, in which there are four subunits of each Den 1, Den 2, Den 3, Den 4 units which are there. So it makes a 4-valent vaccine. It's a live attenuated vaccine given in 3-dose schedule, which is also a minus point because 1 year, 0, 6, and 12 months is a long schedule to follow. It was first licensed, as I told you, in 2015-16, commercially available still now in Malaysia, Philippines and Indonesia. Registered in more than 20 countries. There are more than 26 trials involving 41,000 volunteers. So, and out of these 2.9 million doses which have been used, 2.3 have been used in only Brazil and Philippines. So these 2 are what kind of patronizing the vaccine now. Package insert allows only 9 to 45 years of age, and WHO ACIP also says that give it to only people who are lab confirmed dengue positive. This forest chart, both sides, participants of 9 to 16 years and 2 to 8 years of age. When the person was seropositive, seronegative, if you see, the vaccine was better when it is seropositive, and then the control was better when it is seronegative. Same as what we were saying, and both the age groups is the same. In the above chart, when the person is positive, the vaccine works better, and when the person is negative, the vaccine does not work better, the control works better. This is to show you how it happens. First, you have the dengue infection first time. The homotypic antibodies rise. The heterotypic also rise, but they wane off fast. When you have a secondary infection, then again the same homotypic rise, but the other heterotypic also rise. So after the second infection, all the four have usually got a good response. That's why the third and fourth illnesses are usually not so bad. So it's only the first and the second which is the worst, and third, fourth becomes silent. So I wanted to tell you more about the seronegative individuals who have the vaccine-induced severe disease. What happens when the vaccines are partially effective? They give you a primary dengue infection. So why I mean partially effective? Because the dose is 0, 6, and 12 months. So between 0, 6, and 6 and 12, suppose the patient gets a dengue viral infection, he has suboptimal antibodies, and data suggests that risk of ED is more when you have subsequential infections. First time you have DEN 1, then next time DEN 2, DEN 3. If the infection period between the two is longer, that means the antibodies had waned off, the IDE is more, and that is why we need to have faster immunity so that ADE does not happen. Because as we discussed, ADE happens when the antibody levels are in between. And this is the best chart to show you that if the antibodies are less than 1.21, AD does not happen. The highest possibility of DHF and DSS in patients happens when the antibody levels are 1.21 to 1.8. So below that and above that, they're fine. So this in-between antibody, you can't titrate for everybody. So you need to have a faster protection so that within a period of couple of months with 1 dose or 2 doses, the antibodies levels rise to a level and the patient cannot develop ADE if in between the 2 doses he comes across dengue viral infection. So this is an Indonesian study to show that in Indonesia they saw that 9-year-olds, most of them were already positive to dengue. So they were seropositive by 9 years of age. And in endemic countries this happens, like in Latin America also they saw this. The efficacy, immunogenicity and safety of the recombinant CDC TDV vaccine 2 to 17 years showed, and this was a very big study, so it's not something small. 9 studies were there, 34,000 participants were there. The efficacy was to the tune of 60%. And especially for DEN 2, it was only 34%. And as we saw, DEN 2 is one of the commonest across the world, followed by DEN 1 and DEN 3, DEN 4. So when you have 34% for DEN 2, which is the commonest, 51% for DEN 1, and DEN 3, DEN 4, 75, 77%, which was not so common, prevalent strain. So it's not really very heart-warming issue here. And the most common adverse events we discussed in the previous slide. So there were serious cases in the study, 211 cases were there. After the vaccine, 87 had DF, 14 cases were fatal out of these 87 cases. And also, it was seen that, after the doses, third, second, 1 dose, there were maximum after the first dose, then the second dose and the third dose. There has also been observed there is an interaction between flaviviruses and dengue virus. It was seen that people who have had flavivirus infection before, they also had some form of AD. They used to have more severe dengue infection. And on the other hand, people who've had dengue infection before, these pregnant mothers had less congenital Zika syndrome by the cross reaction with the dengue antibodies. So to say that limitations were there, in the earlier age group of 2 to 5 years, the efficacy was only 33%, 6 to 11 years was 57%, although after 12 years, it becomes much better, 74%. The main point was that it was not very effective in the seronegative individuals. As we saw, the control was doing better than the vaccine. Less immunogenic for DEN 2. Safety issues are there because the increased risk of DF. And the long doses schedule also, we discussed that over 12 months, compliance can be an issue. So just 2-3 slides about ADE, because the ADE people keep discussing what exactly it is. It is also called immune enhancement or disease enhancement. It is because of a phenomena in which what happens is the binding of the virus to suboptimal antibodies. So when the antibodies are suboptimal, or they bind to an area FC receptor which is not very protective, it gets absorbed, but the antibody does not kill the virus. So when it does not kill the virus, it is taken up by the phagocyte, it is not killed, it multiplies there. So it's something like it is using it like a Trojan horse, deceives the process of phagocytosis, multiplies inside the phagocyte, and then comes out. There are although two mechanisms, but the FCR receptor mechanism is better understood than the complement pathway, and it can be manifested by IgG, IgM, mainly by IgG, but also IgM, IgA can also be involved. So it's basically a deceptive mechanism used by suboptimal antibodies, and this suboptimal antibodies could be because of incomplete vaccination, like after 3 doses if you've taken 1 or 2 doses, can also happen after a primary or secondary viral infection. It has been seen with other RNA viruses also, like flavivirus, yellow fever, Zika, alpha, but dengue is the most one studied. CDC also, that's why says that vaccinate only children who have had previous dengue infection, not the ones. So first you do a test and then vaccinate. So there's also an Indian study with this vaccine, and this was done this was published in Human Vaccines and Therapeutics. In this study, which was conducted in Pune, Ludhiana, Delhi, Bangalore, Kolkata, this was in 2012 and 13, 189 participants only were there, 18 to 45 years old. And GMTs here in dengue positive and dengue negative groups were higher as compared to, they also seen the same thing, that if the person was seropositive, the antibody levels were much higher as compared to seronegative group. So it has to be similar as compared to the other group. But they also found that there was satisfactory in both dengue positive and negative, the immunogenicity and safety was same. But this study was not progressed further, and after that, since it never came to our country, it was shelved. Then the second vaccine, which is licensed now, we'll call it as TAG 003 or also the Takeda vaccine. This is also a live attenuated vaccine. It simulates all the immune system parts, which means the neutralizing antibodies are there, cell-mediated immunity is there, and also interestingly, it also produces antibodies to the NS1 antigen. And this is given only in 2 doses, which are 3 months apart. So rather than 0, 6, 12, it's given in 2 doses, 3 months apart. This is also the chart to show you easily how it is made. The green one is the DEN2. So basic backbone is DEN2. DEN1, 3, and 4 are the different colored ones, which small portions. So because DEN2 is the commonest virus we see, and this is made by DEN2, so it's one of the vaccine which would give you a good immunity against DEN2 also. This is the TIDES trial. TIDES actually would stand for tetravalent immunity against dengue efficacy study, tetravalent immunization study against dengue. And this is a 12-month report which says that efficacy was 80.2% and hospitalization risk was 95%. So gave good results. After 3 years also it has shown good results. In individuals previously naive to dengue, it was slightly less, but as compared to the previous vaccine, it did give good results in people who were naive also. Vaccine efficacy was 62% against virologically confirmed dengue, 65% in seropositive, and 54% again in negative. So there was still difference, 65 and 54%, but there was some response in seronegative also. And 83% against hospitalized, which is the main aim that you need to prevent hospitalization. And in this, if we cut through, 77% was in seronegative and 86% went seropositive. Very important point was that was a very rapid onset of action, because as we saw in the previous vaccine, 1 dose did not give, and because of low antibodies, there was ADE. Here, even after 1 dose, the protection against type 3 was 97%, 73% against DEN1, and 63% against DEN2. There's also a recently published study of a 54-month period and long-term follow-up of 4.5 years. The hospitalization prevention was 84%, symptomatic dengue was 61%. There was no evidence of disease enhancement or increased risk of hospitalization. And overall, more than 20,000 participants have received 39 doses of this vaccine, and there are 19 completed and ongoing trials. Until now, they have been not identified any safety risks to this. So this is a vaccine which is useful in children, can be given after 4 years of age. It's safe, effective, irrespective of the serostatus. Again, an important point, seronegative, positive, both can be given. Tetravalent, short dosing schedule, 0 and 3 months, fast onset of action. There is no evidence of disease enhancement, was generally well tolerated. Results reinforce the potential to help protect those who are living and traveling also. So immunogenicity-wise, safety-wise, it is better than the previous vaccine. The trials are still continuing, and they are seeking to have, wherever they are applying for application is there for indication is that it should be more than 4 years, and regardless of previous virus exposure to all adults and children, it can be given. And till now, it's been licensed in Indonesia, European Union, Norway, Iceland, UK, Brazil, and they've also applied for WHO and US FDA, and recently, just now, Dr. Puneet is here. He told me that yesterday only it was licensed for Argentina also. So, and all these places, it's mostly about 4 years of age. Indonesia, it's 6 years of age. Then coming to the last third vaccine, this is the NIH vaccine, which is also codenamed as TV003005. Actually, they had 5 of them. Out of these 3, these 2 were shortlisted. It is also a live attenuated vaccine, and it is again a chimeric virus evaluated in various trials in US also. And single dose, it is being studied, and single dose induces tetravalent responses to the tune of 74 to 92% and 90%. So TV003 also and TV005 had similar responses in flavivirus naive subjects. As we discussed earlier, whoever is flavivirus positive usually shows a better response. It has also been seen, evaluated in a challenge study, has been licensed to Bhutan. Bhutanan is the Brazilian company, also Vietnam, Panacea Biotech, Serum Institute of India for further study and manufacture. In US also it has been given to Merck. So here this vaccine, as we see, DEN1 is the green one, the blue is the DEN4 and DEN3. So they have taken 3 full genomes of 1, 3 and 4, and the DEN2 has been a part of the DEN4. And this is the dose of each component in TV00304. We don't need to go into details. What we need to understand is here, DEN4 and DEN2 are similar. DEN2 has a component in DEN4. And in a single dose response, they have found that tetravalent response was seen 74%, 86, 87, 92, 90%. So it's more or less giving a very good response. And these studies were in flavivirus naive adults, unscreened adults, experienced adults. So all these have been studied. And tetravalent response was good in single dose of the vaccine. So in the Bhutanian trial, Bhutanan is the company in Brazil which was the first one to take up this vaccine. A single dose proved to be safe, immunogenic. Tetravalent antibody response was present in almost 90% of the vaccines. Second dose provided very limited benefit. So that means that we might continue with using only 1 dose. And the vaccine ongoing trial is still ongoing. This is the Panacea Biotech, which has done phase 1 and phase 2 study in India. 100 only adults were taken, 18 to 60 years of age. Immunogenicity was studied till 90 days, and the most common side effects were similarly headache and fever. Out of the 92 subjects who completed the study, 81% achieved seroconversion to DEN1, 77% to DEN2, and 81% to DEN3, and 79% to DEN4. So if we see only DEN1, DEN2, 81%, and 78% did achieve seroconversion after 1 dose of the NIH vaccine in India.
So 5 minutes more.
Yeah, and so there are other vaccines also which are there in the pipeline, but most of them are, first phase 1, phase 2, GSK vaccine, then subunit vaccine by Merck, which they probably stopped, and now they will take up the NIH vaccine only. To conclude, dengue is the most common and the rapidly spreading arboviral disease with geographical expansion, growing impact on travelers. Tetravalent, recombinant, live attenuated viruses are in late stages of development. The TDV and TAG003 have demonstrated protection against severe disease. Differences still exist area-wise, age-wise, and with results are promising, and soon we should have a vaccine which would protect us and our children from dengue disease. Thank you. I also wanted to thank Dr. Puneet, who's there, for proofreading the slides for me. Thank you.
Thank you so much. Thank you for the wonderful presentation. I'll ask Dr. Shikha to please give a small memento to sir. Thank you. Thank you, sir. So our next talk, I'll invite Dr. Vijay Ole sir, and our topic is North to South and back every year.
You want to say something?
No, sir. No, sir.
Very good afternoon. At the outset, let me thank Dr. Rajesh and the Mumbai IAP for giving me this opportunity. And I'm going to talk on north to south and back every year. Obviously, I'm referring to the influenza vaccines, which keep coming every year. They are marketed every year, twice a year. One for the northern hemispheric country and the other for the southern hemispheric country. Based on the data which is collected with the Global Influenza Surveillance Network and the virus which is likely to circulate in the coming year, that seed virus is handed over to the manufacturer by the WHO committee, and based on that virus, a fresh vaccine is prepared every year. This happens because the influenza virus keeps mutating and there is drifting that occurs, which renders an individual who is acquired immunity either by natural infection or via vaccine, he no longer remains foolproof protected against influenza. That's the basis of having fresh vaccine every year, and it comes twice a year. So that is the reason why this talk has been named from north to south and back every year. So what I propose to do is talk about the disease burden, what has happened recently, especially in the post-COVID era, and why is it important to prevent influenza. And Nitin said we must either talk of some new vaccine or some new data. I'm going to touch upon a different aspect, talk about how important it is to vaccinate adults, especially the healthcare workers that we care for our children, and talk about choice of influenza vaccine and guidelines and recommendations. Okay, if you look at the influenza, recently post-COVID era, there has been a rise in all respiratory viral infections, but more so with influenza. And the typical seasonality that we have been observing over the last several years has somehow been disrupted. Now, this is the usual trend that has been seen for last several years with influenza. By the way, in India, there is year-round activity of influenza with peak occurring in monsoon months. In year when the COVID dominated the environment, influenza almost disappeared. But there was a fear expressed in the US citizens and US scientists that they could face a twindemic of both COVID and influenza. Fortunately, that did not happen. However, by the end of 21 or so November, cases of influenza started appearing. It peaked at around early 22, and then very peculiarly, there were two peaks. So this is what happened. From February onwards, again the influenza started rising. And this is a little unusual than what was seen in the past. When it comes to southern hemispheric country, again, the influenza was seen out of the standard, those southern hemispheric peak activity months. So like in India also, we are seeing a lot of influenza activity. We saw a lot of influenza activity before monsoon in the month of February, March. So this slide again explains the two peaks, wider persistence of peak in northern hemispheric country and out of season circulation in southern hemispheric country. And this is what I was talking about. In India also we saw a lot of influenza activity in the month of June, January, February, March of 2023, the first quarter, which is little unusual. As I said, India usually sees influenza in monsoon months. Another peculiar thing that we saw this year was a lot of activity with H3 influenza, H3N2. And the type B
initially, I mean, there was a thought that type B, perhaps, especially the Yamagata, is almost on its way out. But then it has started appearing again. So again, the ICMR surveillance also, talks about the same seasonality disruption and increase in influenza activity. Not only has influenza started occurring, but the incidence has gone up. There have been 17-fold increase in number of cases and 34-fold increase in number of deaths. Again, don't misunderstand. I'm not trying to scare you, though the numbers are small. But in terms of number of cases as compared to what was seen pre-COVID era, there is definitely a quantum jump. Now, why is it important to prevent influenza? Influenza is just not a simple respiratory illness. We know that there are certain at-risk population which is at risk of contracting complicated influenza, getting hospitalized, and even die because of influenza. Indian Academy of Pediatrics has recommended to use influenza vaccine to prevent influenza in children from 6 months to 5 years of age routinely. And that is the age where there is a risk of contracting complicated influenza. And apart from that, we know that obesity is an independent risk factor for severe influenza, elderly adults, healthcare workers, and all those with chronic disease of various organ system, immunocompromised individuals, so on and so forth. And what is important to realize that not only are children sufferers, but they also play an important role in giving it to others, because children come in contact with every member of the society, maybe at the school, on the playground, in the community. So it's extremely important to prevent influenza in children. Now there are a lot of data from influenza burden from all over the globe. There is one study which talks about the Indian estimates. As per this study by Purkasta, there is about 16 million cases of influenza every year, 11 million associated outpatient visits, and 28,000 deaths, which is a substantial number. And most importantly, this is something which is preventable. So influenza vaccination can reduce the overall impact of influenza, lower the risk of influenza-related deaths, and promote the cost-effective prevention of influenza in children. We know that the non-pharmacologic interventions like avoiding crowded places and wearing masks did bring down all respiratory illness, and so also the influenza came down. However, as soon as we did away with these measures, influenza started reappearing. So influenza vaccination is one potentially life-saving tool that can definitely significantly reduce influenza in children. It can reduce hospitalization and emergency visits, and also life-threatening influenza in those populations which are at risk of getting severe influenza. Now coming to healthcare workers, as compared to general adult population, healthcare workers are at an increased risk of contracting influenza. And it is also important to realize that not only we are susceptible and vulnerable to get influenza from our patients, but we can also pass it on to our patients who come to otherwise healthy patients. And I'm sure all of us are pretty well aware of what it can do in adults. The risk of myocardial infarction following influenza in adults is 6 times higher, and flu vaccine, this single tool can prevent myocardial infarction in these individuals with ischemic heart disease. Diabetes, and we know that with every passing year, the diabetic burden is increasing exponentially, and influenza can increase the risk of hospitalization amongst diabetics. The risk of getting hospitalized in an ICU is 4 times higher as compared to other non-diabetic population, and they are at an increased risk of dying of influenza. And we are also pretty certain and know about the role that influenza plays in exacerbating COPD and landing up them in hospital. Now, having talked about this, we also are pretty certain that we do not really pay much attention to our own health. If I ask this audience how many of us have taken influenza vaccine, not all hands will go up. I'm certain that there will be. How many of us have taken annual influenza vaccine every year? Yeah. So I'm very happy that at least 30% of the hands are going up. And then again, how many of us inquire and ensure that our staff is flu vaccinated? Very few of us do that. almost none of us do that. And then how many of us treating newborn ask if the mother has taken flu vaccine before or during pregnancy?
because this is one tool which can prevent influenza in the age ineligible, very young infant below 6 months of age. And how many of us really ensure that household contacts are vaccinated? Nitin would agree with me that there are many leukemic and malignancy children where unfortunately the household contacts are not immunized against influenza, and influenza can create really havoc in these immunocompromised children. When it comes to vaccine, it is pediatrician's domain, and we have done pretty well in pediatric vaccination. But even in the US, the adult vaccination has lagged behind. And in year 2014, an appeal was made to pediatricians to come to rescue and improve adult immunization. I think time has come to do that in India as well. So there comes the concept of family vaccination. So there's a lot of things that a pediatrician can do. We can display the adult vaccination schedule in our clinic. We can print adult influenza vaccination schedule. Not only influenza, there are so many other vaccines which an adult needs to take. Say Tdap vaccine, for example. Guide them on the time of immunization and guide them to the appropriate adult clinics where they can have influenza vaccine. And believe me, even today, it is only thanks to the COVID era that uptake of vaccine and understanding and awareness has gone up amongst adult population, both the physicians and the population in general. We must make it a point to ask the vaccine status of the accompanying caregiver, encourage especially the pregnant women to ensure that they take influenza vaccine, and lessen the need of adult provider. Because unless we inculcate that habit, it will not be done routinely. Then comes the question, can a pediatrician vaccinate an adult? Yes, of course, certainly. Any licensed and registered medical practitioner in this country can vaccinate. And in fact, in public health setup, we know that it is the ANMs who vaccinate the population. Provided that we have taken all the precautions, we have resuscitation kit, anaphylaxis kit to take care of the adverse reaction, maintain the vaccine and the cold chain, know the schedule, and different vaccines are available and the different adverse events available in different age group that we should be aware of. And not to forget that documentation is equally important. Now coming to choice of influenza vaccine, as I said, you have northern and southern hemispheric vaccine, and southern hemispheric vaccine comes in the month of March or April, which becomes the latest vaccine for the ensuing season of influenza seen in southern hemispheric country, and so also in India, that is monsoon months. So there are three virtues that one should take into account. Immunogenicity evidence in Indian population. It's a prerequisite for licensure of any vaccine to have Indian data, and we have this quadrivalent vaccine which comes from the sponsors who have given this unrestricted, not unscientific, but unrestricted scientific grant for this session. And there is a data on immunogenicity in different age groups, and the protection of eightfold rise has been documented across all the age groups that it has been studied in, and even the GMCs are there is eightfold rise in post-vaccination heme agglutination inhibition titers, which are taken as surrogate of protection in influenza. There is enough proof of it. The second virtue that it must look at, it should offer protection against all the four strains, two subtypes of influenza A and the lineages of type B influenza. So there are different studies available over a period of time which have definitely documented evidence of significant antibody titers against the type B influenza. And finally, WHO, quality is an important aspect, and flu quadri of Sanofi is WHO pre-qualified vaccine. Now finally, guidelines and recommendations. We know that the Indian Academy of Pediatrics Technical Committee, that is ACVIP, recommends influenza vaccination as a routine vaccine in all children from 6 months onwards, routinely up to the age of 5 years, and in all children who have chronic disease of lung, liver, kidney, immunodeficient children, and children with diabetes and other disorders. Quadrivalent vaccine is definitely preferred over trivalent vaccine, because very often it has been seen that in the past, when trivalent vaccine was available, the strain which was contained in the virus and the circulating lineage of type B very often differed. That led to suboptimal performance of the vaccine, with the risk of people losing confidence in the influenza vaccine. Influenza vaccine effectiveness is a game of prediction. If you have a good match, the efficacy and effectiveness is excellent. If you look at the Ministry of Health and Family Welfare recommendations. They again go on to recommend in children with chronic diseases, but their age of recommendation is slightly broader. They say up to 8 years of age. And then WHO has taken a definite position saying that influenza is a key tool in preventing influenza, and they say vaccinate children to reduce the influenza or ILI cases, and also helps in reducing community transmission. And influenza vaccine is one tool which has had greatest impact, especially in school-age children. Various bodies in India like Indian Medical Association, Association of Physicians of India, Indian Association of Occupational Health, and Geriatric Society all have now fortunately taken the cognizance of the fact that influenza can be dangerous, and it can lead to hospitalization and death. So they have also strongly recommended influenza vaccination of adults in different age groups. So this again reiterates the Ministry of Health recommendations in diabetic, blood disorders, immunocompromised patients, cancer patients, bronchial asthma patients, liver kidney diseases, chronic obstructive pulmonary disease, and the heart disease patients. Now, which is the right time to vaccinate? If you look at the influenza prevalence in our country, I said year-round we have influenza activity, but it is increase in monsoon months in most part of the country except the northernmost and the southernmost tip, where you see influenza in winter months like the countries in the northern hemisphere. So for all practical purposes, it is the southern hemispheric vaccine, which comes in the month of March, April, is the latest vaccine that one should use. Cities with temperate seasonality can use the northern hemisphere vaccine, that is the southernmost and northernmost tip of the country. So the best time to vaccinate is before the onset of peak influenza activity, that is April, May. In India, limited influenza activity is usually seen throughout the year with a clear peak during the rainy season. An optimum time to vaccinate is pre-monsoon, that is May, June. However, there are studies which say that even you can start vaccinating these children for the rainy flu season as early as the month of April. Now, remember the influenza vaccine, the antibodies, the protective effect wanes over a period of time, and it does not protect you beyond a year. So even if the strain doesn't change, there is a need to annually vaccinate all these children who receive influenza vaccine. So this is the southern hemispheric strain which is now available for us to use. There is a change in the H1N1 type as compared to what was available in the northern hemispheric 22-23 strain, and this vaccine is very much available. So to conclude, post-pandemic there is a resurgence observed in influenza activity, and an unusual and unpredictable landscape of influenza circulation is seen. Individuals with chronic lung disease, COPD, diabetes, healthcare workers, elderly and pediatric populations are vulnerable population as they experience severity of influenza in terms of vulnerability, need for hospitalization, and even mortality. Influenza vaccination is safe and effective in all these susceptible individuals, including children and healthcare workers. Split vaccine target surface as well as internal antigen and is found to be efficacious across all age groups. Pre-monsoon period is considered as the best time to vaccinate with the latest available strain, which is southern hemispheric strain, and various national and international bodies recommend influenza vaccination in COPD, diabetic, healthcare worker, elderly children. And with this, I would like to once again thank the organizer for giving me this opportunity.
Thank you so much, sir. Thank you. We'll take the questions at the last 45-minute session. Now, for our next talk, I would invite Dr. Arun Vadva, sir. And this is our today's last snippet, very rapid fire. And sir's topic is, every 10 years, are you crazy? So, welcome you, sir. हो गया नहीं हो गया सबको पहले दिया
So which is the vaccine which is given every 10 years? Is Tdap given every 10 years or TD or TT? So whether we should give Tdap or TT every year, every 10 years? Which vaccine? No, which vaccine? I was asking people what do they think about this. So that you guessed, it is TDAP or TD, but everybody's saying differently. Somebody's saying TDAP every 10 years, somebody's saying TT or TD. So TT is out. I think we'll not discuss about TT at all. We'll talk about TD and TDAP, whether we should give TDAP every 10 years or TD every 10 years. So before we talk about that, we should know about the natural immunity. You know, interestingly, in the 1918s and 19s, it was 1900th century, it was thought that pertussis gives you lifelong immunity. And probably this lifelong immunity thought was because there was so much of prevalence in the society that natural immunity gave boosters and they thought it lasts lifelong. But after that, this was a study which was published in 2002, 2005, which actually did all the study, and they found that infection immunity was never lifelong. It wanes after 7 to 20 years. And this could be because of result in differences in the level of circulating B pertussis, surveillance systems, case definitions, lots of things, but it was never lifelong. For WP vaccines, an UK study estimated that by 4 years, the immunity drops to 52%. This is WP vaccines. And the clinically protective level against immunity goes down. Australian data study provides evidence that immunity acquired by WP vaccine wanes after 6-9 years, which is still similar. And for AP vaccines, 8 studies were taken up by this meta-analysis, and they analyzed and said that the protection lasts from 4 to 12 years. So there was a big variation. But definitely, AP and WP, the immunity was different. Clear differences between the two existed. And it was, by the data prevalent, it was clear that WP did give a little longer protection. And they concluded that, you know, acellular vaccines now used in the US do not protect as long as the prior WP vaccines. Studying demonstrated the previous component gave who had taken all the 5 doses of AP. 98% protection was there within the first 1 year, about 71% by 5 years, and studies which demonstrated the efficacy pertussis component, TDAP, now this is TDAP, 73% in the first 1 year and 34% by 4 years. So by 4 years, only 34% was left. And the studies which demonstrated the efficacy of pertussis component when women got the TDAP during pregnancy, 78% in infants less than 2 months old, and 90% hospitalization for infants less than 2 months old were protected from hospitalization due to pertussis. There are 2 vaccines available in the market. Both of them are not exactly the same. One is a 4-component, one is a 3-component vaccine, and the doses, the component amounts are also slightly different, including diphtheria, slightly different, and the indications are also slightly different. The Adacel vaccine is not licensed above 64 years of age, whereas the Boostrix is licensed lifelong. So to reduce the mortality in adolescents, ACIP recommends that all children between adolescents, that means 11 to 18 years, should give a single dose of the vaccine. Who have received TD should get a TDAP, and after that it should be given, TD should be given every 10 years. Children who have not had any dose, they should be given in 3 doses, 0, 1 and 6. All of them, at least one of them should be TDAP and the other should be TD. The first one, TDAP, is always the better one. So coming to additional doses for the general population, when we talk about our patients, whether the patients need TDAP every 10 years or TD every 10 years, clinical trials first, you know, we talk about them because earlier they used to think too many doses of pertussis are not good, but clinical trials support that second dose of TDAP is immunogenic also, and it's not reactogenic also. But they found that the anti-pertussis antibodies decline rapidly after the first year, suggesting that the protection wanes. And antibody decay, therefore, you know, there is no additional, following additional doses of TDAP. It's not that when you give TDAP repeatedly, the next time or the next to next time, the TDAP will give you a better protection against pertussis, which may last longer. So every time you give TDAP, the pertussis levels will fall by 3 to 4 years of age. This is one study, not a very good study because the antibodies they studied only for 3 years after booster vaccination of adults with TDAP. The duration of the vaccination or protection after vaccine is not known. That's why they did the study. And they found that after 3 years of age, adults who were 19 to 64 years, in both the groups, GMTs of the antibodies decreased by 3 years level. And the seroprotection rate for diphtheria and tetanus remained high for both TDAP vaccine, 96%, 97%. But for pertussis, they were less. So, but still, they were much above the level which is required for protection. So this is not a very good study, so we'll go over this because it's studied only for 3 years. This is a good study which was done 10 years after the booster immunization, and after 10 years of the booster immunization, all the components were studied separately, and we see the PT component, after 10 years the protection was to the tune of 64% in adolescents and 48% in adults. So, and all the other components, FHA, PRN, FIM, the protection was 97%, 94%, 100%. So what they said was that protection, antibodies against all the other components does remain well, except for PT, which is probably the most important component, where it dropped to 68 and 48% for adults, adolescents and adults respectively. So this is the conclusion of this summary, not my talk. In conclusion, they said that TDAP and TD induced high levels of antibodies against diphtheria and tetanus, which persisted at levels correlated with protection up to 10 years of age. Pertussis antibodies following TDAP generally exceeded pre-vaccination levels throughout the follow period. So although the pertussis antibodies were more than what they were in the pre-vaccination period, but the waning was there, especially for the PT component. The other components we saw remained very good. And to boost PT antibody levels, we should be giving adults additional TDAP boosters every 5 to 10 years, and TDAP should be given. This is another study from Canada. Here there were 3 studies, groups. In one group, 3 lots of TDAP were there, 11 to 54 years of age. In study 2, they compared adolescents 11 to 13 years along with hepatitis B vaccine. And in the study 3, TDAP and TD were given separately to 19 to 60 years of age. And all of them were followed up, and they were brought back for studying again 10 years post-immunization. So this is regarding the adolescents. They achieved tetanus and diphtheria seroprotection after immunization. And as you can see, 100%, 90%. So this was expected. In the previous studies also, we saw tetanus and diphtheria gave good protection. This is for adults. Again, diphtheria and tetanus, again, very good protection. What we are talking about is, this is the same in graphical form. So what you're talking about, pertussis antigen immunization after TDAP. So in this study, in these 3 studies combined also, they saw that PT component became less, 74, 68. And whereas the other ones became, FHA, FRN, and FIM were good. There are 2 subgroups here. One is the LLQ. LLQ is the lowest quantifying value. Here, it is still 78%. If LLQ was increased to 4 times, so that means the level should be more than 4 times to the minimum quantifying value, minimum value you can measure. Then the levels fell to, protection levels fell to 64%, 63%. So the levels were there, but what are protection levels, we don't know. So minimum quantifiable levels do persisted for PT also, but if you make it 4 times the minimum level, then it became 64% and 65% respectively in the 2 different groups. Similar thing was there for adults also. If you have LLQ as minimum value, it was 92, 93%, but if it was 4 times the minimum value, it became 68 and 43% in 2 different groups. So, and all other components were persisting. So again, in this study, they've shown that PT is the component which falls gradually over a period of time, whereas the other components, immunities remain. And if we think that PT is the main component giving us protection, then here the values do fall. And the same thing in a graphical form. So in this study, they concluded that antibodies to the antigen of TDAP persisted for 10 years. These results support the recently reiterated recommendations that TDAP should be given to people above 10 years of age for TD or TDAP because tetanus and diphtheria antibodies persist. It's a reasonable interval, that 10 years is a reasonable interval, and the replacement of TD vaccine routinely recommended for routine administration every 10 years with TDAP could reduce the reservoir of pertussis. This is their conclusion. Could reduce the reservoir of pertussis and may help to protect the young infants who are at greater risk of morbidity. So then we come to that point of replacing TD with TDAP. What will be the economic impact? Because obviously the cost is much more, and here there were static cohort model was done. And what they suggested was replacing TDAP with TDAP for the decennial booster would result in high cost of QALYs saved based on reported cases. However, if the area has a large number of pertussis cases, then probably it may be worthwhile, but the number of cases they have in US, it is not worthwhile to change from TD to TDAP because it will not be beneficial financially. Again, because in our country, we do not have this data of exact incidence of pertussis, we can't say whether TDAP would be value for money or not, but in US, they've concluded that it's not. Then another point people have to consider is HCPs. You know, whether HCPs should be given. First we saw the general population, then after that we saw this, then HCP is important because HCPs are more exposed to getting pertussis. Why should we consider that HCP should get pertussis? It's not, first thing we should remember is it's not a substitute for giving prevention and control measures, including, you know, antimicrobial prophylaxis. So we should not say that you've taken TDAP, so all these other methods are not required. There is also no supporting evidence that additional TDAP doses will prevent disease transmission in healthcare setting. Because infants are at greater risk to severe or fatal pertussis, healthcare workers who work with infants or pregnant women should be prioritized. So if you have to give HCPs the DTAP vaccine every 10 years, it should be mainly to people like people working in nurseries or pediatric wards or pregnant ladies. But other TDAP, other HCPs, it's still not clear whether it should be given or not. If we feel that there is an increased risk of pertussis in healthcare setting as documented by, you know, repeated healthcare-induced transmission of disease, then DDAP could be given. Additional TDAP could also benefit individual healthcare personnel because the interruption of pertussis transmission may not happen. So this is one point which you need to consider, that if you give TDAP, he still may be transmitting the disease. And that is why in 2005, when AC recommended that single dose of TDAP followed by TD was fine, and 2014 they reviewed and they still say that after TDAP, a single dose of TD should be given to all healthcare workers also, except for the ones who are caring for newborns, small children or pregnant women. You know, this is a very interesting study from Australia where the healthcare workers were given WP, who had taken the complete course of WP initially, and now they were given TDAP. And in this study, they demonstrated that, you know, the pertussis immune memory was maintained up to 12 years after TDAP vaccination in WP primed Australian adults. And Australia is one country where they give TDAP to all healthcare workers every 10 years. And that's why they said that we still support the current recommendation of repeating TDAP vaccine to all pediatric HCPs, as we saw in the previous ACIP guidelines also, that people who are taking care of newborns, pediatricians, and gynecologists maybe should be given. So here in Australia also they do the same thing. And interestingly, WP primed Australian adults, when they were given TDAP, the pertussis antibodies did last for 10 to 12 years.
So
then 3 minutes more.
Yeah, he finished fast, so I have his time also. So TDAP also is also associated with cocooning. You know, so before we had the pregnancy vaccination, cocooning is what was followed. But cocooning has its own logistical and financial challenges, especially in our country where lots of people are taking care of the newborn. And people think that who are up to date with TDAP, it's fine. Otherwise, it's a good opportunity to give TDAP to these adults also. But it's not a very cost-effective method because, as we see, TDAP is not very good in prevention of household transmission from person to person. But it's a good opportunity to vaccinate all adults who are taking care of the newborn. Then lastly, it comes to vaccinating during each pregnancy. So when the mother has had TDAP before becoming pregnant, they found that it does not give good antibody levels to the newborn. So it was concluded that all pregnant women should be given TDAP vaccine every time she becomes pregnant, whether it's 1 year or 2 years after that. And because if you've taken it before, the antibodies levels, protective antibody levels do not last for more than 2 years. So it should be given to all women. The only thing they thought was giving TDAPs too early every year, 2 year may cause side effects, but then adverse events were very similar to single dose. So repeated TDAP did not cause much problem. The one point which came up was that, you know, vaccination of pregnant women does it interfere with primary vaccination of the newborns? It does, although the exact impact is not known. But by the time the child gets the 4th booster, the levels were comparable. So all children who actually were born to mothers who had received the TDAP vaccine, and the children were given 2, 3, 4 month schedule, these were the ones which were studied, and they found that antibodies to diphtheria were a little lower, as also compared to a little lower for PCV13 also. But the ACIP concluded that, you know, the potential benefit of protecting the the newborn from maternal antibodies is still better. Only thing is we should ensure that the child gets the 18-month booster also. So a little less level is still worth it. Interestingly, there was a study which says that TDAP vaccines associate with 42% lower risk of dementia. And after reading this, I thought I will take the vaccine soon. Although it is said that it could be there with other vaccines also, it may be a non-specific immune response, but the study was only with TDAP vaccine and adults. 42% is a big number, reduction in dementia. Yes. Adverse events were very less, hardly 7% adverse events were there, and since in adolescent adults the adverse events were very similar, so not much to say about that. Then one other interesting thing was that about TDAP and other vaccine combinations. You know, when the TDAP is given with hepatitis B vaccine, they found that erythema and swelling was a little more. When TDAP was administered with men's the CRM vaccine and the influenza vaccine, this is, however, the trivalent influenza vaccine, the immune responses to two of the three pertussis antigens were slightly lower, but the clinical significance is still not clear. Although for adults above 65 years age, when we were given Boostrix and trivalent influenza vaccine simultaneously or separately, they were safe and immunogenic. So ACIP concluded that increasing burden of pertussis is there in America. The proportion of cases prevented with recommendations of TDAP as compared to TD were hardly 3 to 5% more, and data does not support the general recommendation for a routine second dose of TDAP. And this public health impact would be very limited as compared to financial cost increase burden. So finally, I would also like to say that same infants all should receive a TDP, WP or AP. Adults who have never received TDAP are also should have a second dose of TDAP. After TDAP, everybody should take TD boosters every 10 years, and women should take TDAP in each pregnancy, 27 to 36 weeks of gestation, even if they've taken one dose before getting pregnant. Interestingly, in US now, TDR supplies are limited. Serum Institute people can send it to them because they're now using TDAP instead of TD just because the supplies are limited. And they say that this is not a permanent solution. We'll go back to TD once they are available. Thank you.
Thank you so much, sir. Thank you. So with that, we are end of our last session today, and that is an open session, audience question. And for that, I will invite Dr. Jitendra Gavane, sir. He is attached to MGM Hospital. He is the head of pediatrics and Department of Pediatrics. And then we have Dr. Varun Wadhwa, sir, with us, Dr. S.G. Kasi, sir, and Dr. Rohit Agarwal, sir, and Dr. Chetan Shetty. Please. So it's very heartening to see almost 80% of the hall is still full, and I think everybody is just gearing up to ask a lot of questions. Yes, sir.
So, friends, we are coming to the last session, and this is for you to ask any question. So we will move around with the mics. Please feel free to ask any question on any vaccine to the delegate. So 4 or 5 people, volunteers, please move with the mic. And by then, Jitendra will also conduct so that he will ask the question, but we'll feel free to ask questions as you want.
So we'll take the questions from first bench, middle, and the last, one by one, so that everybody gets a chance. We'll start from the... and also the online questions. So one by one we'll take.
Audience expert नहीं sir, audience. Yes sir. So thank you Mumbai IAP for giving us opportunity, and we will make most of this opportunity because I think Amruta told me that hall is booked till 6-7 o'clock, right? So we can take as many questions. Yeah. Okay. So let us go systematically asking all doubts from each vaccine. Before that, I want to ask Nitin Shah sir one question. Sir, you are called as a vaccine Shah. And sir, you are expert in hematology, cancer. So every compartment in brain is there, and RAM of each section is more than 20 GB, right, sir? So how you manage that?
So there are three things you have to do in life to come up. One is kam khana, gum khana, and nam jana.
Oh.
Okay, and other thing, whenever you read any article, I make it a point to make 4 or 5 slides. So I have a master slide deck where everything is there on any vaccine. Then I cut paste from that as I need. So that's the only way you remember what you have read. Otherwise, if you just read and then after few months you will forget it. So make an excerpt of what you read. That's the best way. Now, not only vaccine, hematology, oncology, whatever subject. Yeah.
So Nitin Shah sir, right from our residency days, is our chat GPT. Once you chat with him one question and immediately answer comes with a lot of references also. Thank you for that, sir. So experts, I think I will not specifically say who will answer. Let us start with the basic BCG vaccine, which is the first vaccine we give to the children. Now, this is most of you are past ACVIP chairmen and ACVIP members. So our questions will be towards ACVIP also, sir. Okay, although you are at different audience also, many ACVIP people are there.
Of ACVIP, yeah.
So, sir, now is it a high time to discard BCG vaccine altogether? Because low and middle income countries, if new good vaccine comes, then we can save a lot of money. That is a study by CDC and other agencies, and the M72 candidate vaccine is in pipeline. So what is the status of that vaccine, sir?
I think it is too premature to dump immunizations, vaccinations against tuberculosis in the low-income countries. So far, the only vaccine which is licensed for use is a conventional BCG vaccine. Well, I will not call it a useless vaccine because it has almost a 80% efficacy against
0 to 80,
post-primary complications.
Yes, sir.
Post-primary complications, 80%. Prevention of primary complex, 0 to 80%. That range is there for prevention of primary complex. But prevention of, say, miliary disseminated tuberculosis is close to 80%. Now, if you look at the newer BCG vaccines that are coming, they are basically classified into 3 groups. Prevention of infection, prevention of disease, prevention of recurrence. Prevention of infection is a BCG replacement vaccine. Prevention of disease is a booster vaccine which we are going to give to adolescents and young adults. And prevention of recurrence is what we are going to give to people who have already completed therapy so that they don't get a recurrence.
Right.
Of all these vaccines, the only vaccine which is likely to enter clinical usage in the not too distant future is the VPM 1002, that is RBCG, which is going to be a BCG replacement, that is prevention of infections. It's only when that vaccine becomes licensed for use, then the conventional BCG is dropped. Till then, we just cannot think of stopping BCG.
So once EUA gets authorized to serum, then we will stop conventional BCG, that means?
I think yes, once we get favorable phase 3 reports. It's still the phase 3 results have just begun. I mean, it may take at least another 3 years before you get the results.
But sir, in
2 years follow-up for that.
In practice, especially after the COVID period, lot of TBMs and lot of MDR TB cases are coming, and almost everyone has taken BCG vaccine in their at birth and all.
See, BCG, the protective efficacy is estimated to last around 15 years and not longer than that.
Correct.
So someone who has taken as a child, if he develops disseminated tuberculosis or at 20, 22, 27, you cannot blame the vaccine. It is other factors which are responsible.
No, 27 years we are not treating, sir. We are treating up to 18 only. Okay, sir.
The incidence of BCG adenitis and how do you?
I'm coming, sir. Yeah. So, Chetan, sir, can you take what is? Yeah. That same question I'm taking. Yeah. So, what is BCGiosis and BCGitis, and how to treat that?
So BCG adenitis, which has been commonly been told that if it is lymph node swelling, which is ipsilateral, where you have given the site on which you have given the BCG and the same side, if it is majority of the time it is axillary, but it can be supraclavicular and cervical also very rarely. So if there is swelling that is we consider the BCG adenitis, because the same bovine virus have been caused for this. Now, if it is occurring to other than this particular drainage site, that is called maybe a disseminated or BCGiosis, because usually it is an immunocompromised host which we find that this kind of BCGiosis. BCG adenitis, if it is simple swelling, nothing, child is playful, don't do anything. Okay? If by chance, because there are chances that that will be okay by its own, it will resolve by its own maybe in 2 months, 3 months or 4 months time. Now if there are suppuration, usually it may go for suppuration, in that case you need to drain it. Now you drain by using a ZAD technique, because then otherwise you may have a sinus formation, you aspirate it. And there are all the chances you might have to go for once or twice or thrice aspiration. You might get filled up. So once you remove that particularly, you drain it, then you don't send it for just say reporting, gene expert or something, because you might get the BCG bacilli, right? So they are the bovine strain. So that doesn't require your antituberculous treatment. Yes, you might require sometimes, you have to drain it. If it is infected, you might have to give the antibiotics. But usually it just gets better with the repeated or once or twice aspiration. So that is BCG adenitis or BCG abscess. Now BCGiosis or disseminated BCG, that is where we have to work up further for immunocompromised state, and you have to treat it very seriously with antibiotics, and further work has to be done. So that is about.
So AKT is required in BCGiosis?
Pardon?
AKT?
I think that is required once you find out what is the reason, because immunocompromised host can cause that particular. It is BCG is not the culprit. Maybe a tuberculous bacilli is culprit.
Rohit sir, you want to add? Mike, Rohit sir is adding to that.
Yeah, immunocompetent host, BCGiosis. How to proceed? Not adenitis. With regard to therapy, after the drainage has been given, therapy. So how to proceed? Immunocompetent, not immunocompromised.
The term BCGiosis is only in immunocompromised.
When it is disseminated in immunocompromised, it is called as BCGiosis.
So you can only get local lymph node, local swelling,
it is itis,
which will be like what this is. But once you have distant side, at the opposite side, liver, spleen, lymph node, chest, abdomen, do two things. Do lymphocyte subset analysis to rule out SCID, and if that is normal in a seemingly normal child, do an MSFD workup. That is Mendelian susceptible to mycobacterial disease, and I'm sure one of them will be positive.
Yes, sir.
Therapy, then they have to be treated as like
it has to be treated, Right. If it is BCGiosis, it is definitely not the bovine. It is definitely the Mycobacterium tuberculosis, and accordingly, as this thing, you have to treat.
No, it is
even
bovine.
if it is bovine.
It is bovine, but it has got
still,
it has got released all over the body.
Disseminated. Yeah.
And for this, instead of aspiration, I would say excision biopsy is a better option to rather than doing IND, because in that chances of forming sinuses are much more better, more rather than getting the excise and remove the whole with capsule.
So it's always non-dependent repeated aspiration. No, non-dependent repeated aspiration is the treatment which you can do on OPD basis.
Yeah.
There are criteria for diagnosis of BCGiosis. One is a clinical syndrome compatible with a systemic mycobacterial infection, where prolonged fever, cough, etc. Second thing is demonstration of AFP in at least 2 non-contiguous structures, or you get a blood culture which is positive for mycobacteria. These are 3 criteria for diagnosing BCGiosis. BCGiosis, as Dr. Nitin said, occurs only in an immunocompromised host, never occurs in an immunocompetent host. All BCGiosis has to be treated with antituberculous chemotherapy. The only condition is Mycobacterium bovis is resistant to pyrazinamide, so your ATT should have something apart from pyrazinamide.
Okay. Any audience question regarding BCG doubt?
How do you distinguish from BCG iris? Because that is a hyperimmune response. Where only thing is that is the iris localized or generalized like BCG?
BCG iris is a hypersensitive reaction. It can be generalized. BCG iris is not an invasive BCGiosis. It is a hypersensitivity reaction.
Yes.
There is no need for any change in therapy.
So online question we will take.
So there are few online questions to the panel. First, very basic. Child has been given or not given BCG, not sure. So no documentation, no scar, whether to repeat or not.
No documentation and scar also not there.
You can repeat it once and then forget it. Then you don't look at it.
So
BCG scar is a surrogate marker of BCG has been taken up.
Yes.
So if it is not there, if you know that you have given, then you may not give it. But if it is no history is there not there, if scar is not in, you can give it once. That's only.
Sure. Another one, INH resistant BCG, it is available in India or not available
No.
as yet? Okay.
Not available. So few of the NRIs are coming back from abroad and staying back here. So their children have not received BCG. So what is our stand?
Till what age?
We give it. We give it up to 5 years. We give it.
5 years.
The WHO says it up to 5 years.
I want to ask Kasi on that question. I want to ask Dr. Kasi one question. Suppose a 15-year-old or 16-year-old
Exactly.
from US comes, will you give BCG?
If he has come here for the first time, I'll do a pre-BCG man too. If it is negative, I will give BCG.
Perfect.
Sir, one more question.
No, I think this is important because you should
Very
understand the guidelines from UK and USA are very clear. They have said that children up to 17 years are eligible for BCG if they are going to stay for more than a month in a TB endemic area. And there are countries which are defined as TB endemic area, and as you will all agree, India is one of them.
Sir, I think one more question. This comes from, travelers abroad. They have seen BCG vaccination given not on the arms but somewhere else. So there are a lot of requests coming from parents nowadays. So what should a pediatrician do?
No, I think the recommendation is only on the left side of the arm. Other sides, they are not been recommended scientifically. And there are chances of people have given on the thighs by mistake, and here and they have developed children, they have developed the limb tendinitis following that. So ideally it should not be given apart from the what recommended the left, left side of the arm, upper arm.
So there is one more.
Sir, that is for the cosmetic region, cosmetic purposes, but I think that practice should not be encouraged.
One question to either of them. What happens if you give 0.5 ml BCG by mistake as hepatitis B intramuscularly?
I have had at least 4 cases like this. It will form a localized abscess. It will remain localized. The abscess will form 4 to 8 weeks after the BCG vaccination. Follow up with an ultrasound, repeated aspiration like a BCG tendinitis. Absolutely no antituberculous treatment.
Very true.
Everyone, please hold the mic close to your mouth. The online people can't hear.
By chance, you have given it and there is no reaction. What does that mean?
The vaccine will work. You don't have to repeat the BCG.
Or you forgot to dilute, actually you only injected the saline.
I'm very true. See, this is a real.
If you make a mistake of giving BCG,
this is very common mistake, sir.
Very
Yes.
likely that you actually broke the syringe, took out 0.5 and give
Yeah.
hepatitis B.
No. This thing has happened, as I asked in a question, one of our colleague, that usually hepatitis B and BCG both have been lying by the side. So he, by mistake, first injected BCG here. And then he realized he didn't do anything, and then he gave BCG here. Now what will happen? So nothing happened till now, 6 months have passed.
Don't tell anyone about it.
He shared with me, I just said, just keep watch on what is happening. Almost, I think 4.5 years to 5 months, 4.5 to 5 months have passed. Nothing has happened. He's just...
The other thing, that a monovalent hepatitis B vaccine, which has no preservative, that fellow gave it intradermal instead of BCG.
No. BCG he gave and BCG here.
No, I understand. So that he realized his mistake. But also similar mistake where both syringes were filled up, the BCG given IM and hepatitis B intradermal, what happens? Hepatitis B will work. In fact, intradermal is the best source of
hepatitis B will work. Okay.
No, but sir, you can ask your question.
But Chetan, these are not hypothetical questions. This happens even in corporate hospitals.
Yeah, that is true. But what I tried to see the literature, they say every time there has to be reaction what Dr. Kasishar mentioned. But in this case, nothing has happened till 4 to 5 months.
Sir, your universal dose of BCG.
Loudly, sir, loudly.
Universal dose of BCG 0.1 ml should be given to every newborn, or premature should give half of it.
So, sir, he's asking below 2 kg, can we give BCG, and premature babies half dose should be made.
If the baby is stable, you can give.
So same dose.
Yeah, same dose.
Same dose he's saying.
So last question about BCG now.
If you are given a mistake on the thigh and then nothing has happened, because it has gone intramuscular, the BCG has, basically if it's given intradermal, then the reaction.
So last question about BCG. Is there any difference between the onco BCG and the conventional BCG that we are using?
Onco BCG is used for local therapy of bladder cell cancers. It
That is
has a
recommended.
concentration at least 100 times of conventional BCG. I have had two children where onco BCG was given instead of conventional BCG. Both of them had a very accelerated reaction, pustule within 24 hours, took a long time to heal, no dissemination, no treatment was given.
Okay, sir. We will move out from BCG. Another vaccine which is given at birth is hepatitis B. Now it is mandatory to give birth dose of hepatitis B. So, what about sick children or birth expected child or preterm baby who is born? Government insists to give to everyone. So, how to go about it?
You have to give earliest. As for whenever the baby is stabilized, then you have to give it. And there is first exposure to healthcare professionals, you have to offer it. Because not only we are worried about the vertical transmission, but we are worried about the horizontal transmission. That can come at any time. So once hepatitis B, the child is stable, you are about to discharge, you have to give it. Or if patient is discharged.
No, it is not at discharge now, sir. It is at delivery room, in fact. Government mandate
First,
says.
let the child, newborn get settled.
I think the recommendation says either the criteria should be minimum 2 kg for the hepatitis B to take over, or chronology age should be 28 days if the premature.
No, that's gone, sir.
Now,
Now,
BCG can be given to all healthy.
No,
hepatitis B can be given to all infants once they are clinically stable, irrespective of the birth weight and the gestational age.
Okay.
Today, if you see the 2017 position paper on hepatitis B, the WHO has clearly recommended, since all of us use combination vaccines where we're giving 3 doses at 6, 10 and 14, for uniformity, you give the birth dose even in preterm babies and do not differentiate between preterm and full term.
So, sir,
only
that
place is, of course, even if the baby is unstable, say a 1.2 kg is unstable, if that mother is HBsAg positive,
That
you
we
will
have
give
to
the
do.
vaccine and you will give
Yes,
immunoglobulin right away.
So, sir, we practically land up giving 4 doses of hepatitis B, and sometimes at 1.5 years also, if pentaxim not available, then hexaxim we give. So 6 doses. Is it justified?
Why hexaxim pentaxim? Give a quarter of X and IPV, na?
He is a strong protagonist of the WHO.
So, my question was, should we go back to the 016 schedule of hepatitis B?
I think 016 is the best, but any number, 4, number 5, or even the 6 doses of hepatitis B doesn't make any problem to the child. You can give safely.
I think let's be very clear about this schedule. Remember, for hepatitis B, we are not chasing antibody titers. We
Yeah.
are looking at seroprotection rates.
Correct.
Okay, whether as long as you give 3 doses of hepatitis B vaccine with a minimum gap of 4 weeks between doses, the seroconversion rates is in excess of 95%. Once you have seroconverted, you have long-term protection. So I think to say that 016 is immunologically superior, but practically it makes no difference. Now, on the other hand, there is a concept in immunology that if you have higher antibody titers, your B memory cell titers are also higher. See, if you look at it the other way, but does it make any difference clinically?
No.
There is no data, but theoretically it should not.
I think the question was also on overdosing.
Yes.
Rather than, so
Yes.
I think that answer comes from beautiful study done in South Africa by Professor Madi's group. They took one arm DTAP based combination hexavalent, birth dose 3 hexavalent primary and 15 months also hexavalent. Other arm they had DTWP and Hep B, birth dose 3 DTWP Hep B separately and 15 months again Hep B. And they found that there was no increased side effect by giving 5 doses. And in fact, the titers of anti-HBsAg at the end of the 5th dose were 40,000 units. They will not see 1 but 10 lifelines. So
Correct, sir.
absolutely no harm in giving extra dose.
Okay.
Just to give an example, suppose you have taken 3 doses but you don't have documented and you have an exposure to hepatitis B.
Mhm.
You can do titer, but if you don't do, then you have to necessarily give them 3 doses more.
Correct.
Suppose you have given someone 3 doses and they have not responded, you give 3 more doses. So giving extra dose is never harmful for vaccine
Okay, sir.
hepatitis B.
Okay, so Vadva sir, you wanted to say something? Oh, okay, covered it. Any online question on hepatitis B?
No, sir.
Okay. So, sir, whenever ACVIP meeting comes up and lot of rumors starts floating into pediatricians that this new change has will come or is going to come. So we heard that now ACVIP is thinking of introducing one wholesale vaccine in primary schedule. Is it true or is it scientific?
Well, personally, I wish ACVIP does that, but there is no such move at all. Believe me, I think we should put this whole controversy to rest. Believe me, whatever you talk, you have die-hard WP fans, you have die-hard AP fans.
No, we are combining both, sir.
They will not change. So I think we should stop discussing this. What do you say?
Two experts are sitting here. One is die-hard of DTAP, one is a die-hard fan of DTWP. So no debate and no this thing.
That means one dose of wholesale. Okay.
We should be discussing WP primed individual. First dose of WP and then followed by AP.
That's what I am asking, sir. Yeah.
No, I think this whole concept of giving one WP dose came from the Australian study by Sarah Sheridan, where during an outbreak of pertussis in Queensland, they looked at the immunization status and they found that the attack rate was lowest in those who were primed with WP. It was highest in those who were primed with AP. It was next to lowest in those who received a mixed schedule with the first dose WP.
Okay.
So from this, the concept arose that if you're so hesitant about using all WP vaccines, at least give the first dose so that you are skewing the entire immune response. And believe me, studies have shown that this skewing of the immune response persists for 20, 25, 30 years. So there's a lot of benefit, but as I said, I mean, everyone has taken their sides now, and any amount of arguments is not going to change things.
Online question? Ha. Sir, Sani sir.
Can I make one,
Ha sir.
See,
Ha sir.
One please. The question is that when you are giving isolated only DTAP and DTWP, the matter is different.
Yeah.
But in combination vaccines, when you are giving with hexa or penta, IPV acts as an adjuvant. The RNA, ssRNA of IPV vaccine, that acts and that converts into the DTWP components converts into the toll 7 and toll 8 and by TH1 mechanism, and that's why it becomes almost equal.
No, but this is not proven for humans. It's only an animal model.
It was
only animal model. Okay.
So till it is proven for humans, we will not take
Okay, sir.
That takes care of.
So I just wanted to ask one question, that DPT correlates of protection is antibody level. However, it works also by T cell protection because there is a tremendous boostability. Now, Dr. Vadva just said that when we give at 10 years, we do pertussis antibody levels. How scientific it is? Because what would be really important to know whether the protection still is long lasting or not, to measure the T cell memory response by pertussis and not antibody levels. And most of these long-term studies are based on antibody response. So is there a fallacy in that?
There is no correlate of protection for pertussis, but for purpose of comparison of vaccines, a titer of 1 in 40 is taken as a correlate of protection only for comparing two vaccines. That's all. But there is no correlate of protection for pertussis.
So there are some effectiveness data of Tdap vaccine, and it is known that the vaccine efficacy is at the most up to 2 years after the last dose. The third year onwards, it becomes statistically not significant. After 4 years, it is 0. So the Tdap against pertussis will work only for 3 to 4 years and not for 10 years. So whether you should give it every 3 to 4 years, if not for pertussis, for dementia, that is a question.
No. What I meant was, since the correlative protection is not there, that's why for all adults they say take at least one dose of TDAP. So suppose you've not taken, you come at 25, 30 years. Otherwise, what is the point of giving TDAP at 25, 30? Give TD only because P will last only for 3, 4 years. After that, what? So they say one dose because they're not sure about the correlative protection. Maybe T cells will help, and still it is clear, at least take one dose, and after that take TDA every 10 years.
Okay, sir.
How early can the DPT booster be given?
How early can be DPT booster given?
If the child who has received 3 primary doses, how early
6
can
months
you
from
give
the
the
last
boost?
dose, no? 6 months from the
6
third
months. So 6 weeks, I mean 14
6
weeks
months
plus
from
6
the last dose.
14 weeks plus 6 months.
No, he's asking the last dose of primary series was over at 14 weeks. Now they want to know whether how early can the first booster be given?
Earliest would be 6 months, no?
6
Between
months.
6 months from the last dose.
See, theoretically, you can give it as early as 4 to 6 months after completion of the primary. But the reason why you make a schedule is you want to give the vaccine when the antibody titers are falling below protective levels. Okay? From that point of view and from the logistic point of view, we are giving it at 15 to 18 months.
Yeah, but why you want to give it at 6 months after the last dose, Dr. Yevle?
Just a question.
You want to fast forward.
There was a question that suppose a child has to be given IPV and standalone IPV is not available and you use a combination vaccine containing DTAP. Would that dose given at 9 months be taken as valid booster for DPT?
I think you shouldn't play around with the schedule too much.
Yeah.
We have IPV.
Too much.
We have covalent IPV.
No, so I want to ask seriously, Dr. Evile, is it the same doctor who gave BCG intramuscular?
Same. Sir, Amin bhai.
Why is there so much of paradox when you're saying that your DPT, your pertussis levels, antibody levels will go down in 3 to 4 years, and the other hand we are saying give a pregnant patient every time she gets pregnant. So why is there so much of contradiction?
You are giving a pregnant woman not to protect her, but to protect
For the baby.
Every time. And we are not worried about the overstimulation with DTaP that you're giving every time.
No.
You require high antibody titers in the infant, which will persist at least till 4 to 6 months.
Yeah.
And for that, unless the mother is given every year,
Every pregnancy.
It will not work. Pregnancy it will not work. I mean,
Sir, India crossed China, sir.
I mean, it happens now.
Right. So, Vaidya sir,
So I want to ask
last
one
question from Vaidya sir.
That
Sir.
because you give this TDAP every pregnancy, is it that the reason why women are more sharper than men?
It is the only mother or the total family member, because cuckooing of the effect which was there.
No, they have compared all the regimens for prevention of infant pertussis. Maternal immunization is the most cost-effective
No,
intervention.
previously this concept was very much of cuckooing the things.
Cocooning is not cost-effective. USA finds it cost-effective, but Europe and Canada don't find it cost-effective.
Vaidya sir.
Well, who's going to give the protection immediate
Regarding
contact?
Dr. Yevle's question,
Haan.
we had a lot of discussion.
Yeah.
Now there are two
Same
concepts.
parents,
There are
so-
two concepts.
Haan.
Minimum age of vaccination of that and minimum duration
Right.
gap between two. So what he was telling in ACIP, American, they advise first booster minimum age is 12 months.
Okay.
You can give at 18 months. Minimum age is 12 months.
Because, sir, they
but
give
there
at
should be
2,
gap
4
of-
and 6 months,
but
no?
Should be gap of 6 months between last dose and
So
the
exactly,
booster.
they give at
But,
2, 4 and 6 months.
The problem here is that we are giving third dose at 14 weeks.
Yeah.
Then should we wait till 12 months or should we give 6 months after that? That is the priority. That was the discussion, sir. So we were telling that minimum at 1 year we have to give the booster.
Dr. Rajendra, I think Gavan is
Dr.
correct.
Vaidya, let us make it very
unka
clear
246 hai, sir.
seriously that in USA they use 246.
246.
They don't give booster at 12 months. They give it at 15 months, right? They say if it's given at 12, it is valid. Means some people make mistake and giving early is valid. So it's not by choice, it's by default. So same way for us, 16, 14, after the 6 months is given is valid, but that's not mean that we give it like that.
Even if you give it at 1.5 years, there is the option of combination vaccine available. So where is the difficulty?
No. Dr. Kasi, every year is same as every pregnancy in India.
So moving on, sir.
What is the incidence of injection abscesses following all these immunizations? And how do you tackle them? Is there an incidence of atypical mycobacteria at the site of injection abscess?
Any incidence studies, sir?
No, so there are several patients who have had tuberculosis abscess in the muscle where DPT vaccine was given, but that's not because of DPT, that's because of contamination. So that is what we should worry about.
All, yeah, so contamination.
DPT, Hep B, whatever vaccine given, and there's an abscess you think is a nodule following DPT, you actually drain it and it is MTB.
Sir,
it can still happen because the skin is contaminated.
Sir, my question will be there. ACVP takes a lot of these problems. When anaphylactic reaction occurs and a death occurs, it is the duty of only a doctor or the company who has manufactured. There has to be something regarding the company who manufacture. Poor doctor just gives the injections. and then the penalty, and the next day you get a publicity in the paper also. So some action requires to be taken on a pharma company also about the same.
No, sir, then the batch number and everything is...
See, anaphylaxis is a serious AEFI. It has to be reported within 24 hours to the concerned authority. The concerned authority will then progress and, investigate.
Yeah, in that batch number, everything comes, sir.
As a practitioner, as a practitioner, you manage the anaphylaxis and report. Your job is done.
You are not held responsible, Dr. Bipin Shah. AEFI guidelines are there. As he said, serious AEFI. Report, and then it goes to the district health office, and he has to investigate. Even the manufacturer is also held responsible. He is also concerned.
But on a very serious note, many pediatricians do not have resuscitation kit in their...
That is true, sir. That is true. Very true. So whosoever is vaccinating the child in his chamber, he should always have a resuscitation kit.
Dr. Jitu, just for records, in your delegate kits, there is an AEFI management chart. Please hang it near your clinic.
Yeah. So one of the Mahapedicon, we give resuscitation kit as a delegate bag, sir. Yeah.
Sir, there is one more question.
Yes.
Sir, is it absolutely safe? Lidocaine spray before prick.
Huh? Lidocaine spray.
Yeah, why not? Lidocaine spray.
Lidocaine spray. Yeah.
So again, in your delegate bag, there are 2 isopropyl alcohol spray which also have little lidocaine.
Wow.
It doesn't matter, I mean.
Okay, moving on to next vaccine is a IPV vaccine. Lot has been said and discussed about IPV vaccine. In spite of our recommendations, government started with fractional IPV 2 doses, and with pressure by senior people, now 3 doses are recommended at 9 months. They are saying 3rd dose of, but fractional only. So in between, what we were doing were like the child who comes to our clinic with 2 doses of FIPV, we were offering 1 full dose of IPV. Now there is no need, right, sir? Because he is going to get FIPV at 9 months. So the protection level suddenly goes from 60% to 97% with fractional, with 3rd dose. So is it a booster or 3rd dose?
2 doses of IPV, fractional or intramuscular, with the first dose given after 14 weeks, with a minimum interval of 16 weeks between the 2 doses.
2nd and 3rd.
Gives close to 100% seroconversions against all the 3 polio serotypes.
Very good.
Okay.
Yeah.
Once you are seroprotected, you're protected almost throughout your life against paralytic polio. So this is enough.
Right. So in now commercial practice, there is no role of polio vac now, because everyone.
Yeah, in this particular situation, I don't see any benefit in giving an additional IPV dose.
Correct, sir.
Unlike when you're giving 6-14 years, there was some role, but not now when you're giving an additional dose at 9 months.
Yes.
So, sir, then you are saying that if a person has received this 2
doses
or 3 doses, as a matter of fact, for FIPV, he is not going to get a paralytic polio in the lifetime. Then why we are offering IPV 1.5 years to 4.5 years?
Exactly. Now
because we are worried about waning of immunity.
No, it's not waning. See, there are 2 aspects. One is protection against paralytic polio. The second is protection against transmission. Okay. Now, for protection against transmission, there was a belief that higher your serum antibody titers, there is oozing of IgG into the lumen of the intestines and the pharynx, and confers local immunity. In fact, there have been some studies, at least 2 studies that has been quoted in our 2020 recommendations, done in 1990s, which showed that there was some inverse relationship between the serum antibody titers and the amount of polio virus that is excreted after you give a challenge dose, indicating that higher the serum antibody titers, lower the excretion and better the intestinal mucosal immunity. However, this concept is not universally accepted. So from that point of view, by giving higher and higher, more doses and getting more higher and higher antibody titers, I don't know whether it really has any purpose in doing that.
So,
4.5 years booster.
Sir, question for you, sir.
The only thing is, it may be for
Sir,
preventing CVD-PV.
Yeah.
The higher titer will definitely, against the type 2, it will be protected.
Dr. Praveen,
by giving booster as well as the second.
Intestinal immunity following either a dose of OPV
Or
or a
IPV.
dose of IPV does not last longer than a few months, maximum 1 year.
Correct.
Studies have shown that.
What is the question?
So, sir, Chetan sir was asking like 1.5 year.
Sir, let me explain.
4.5 year tetraxim. Some countries giving Tdap with IPV.
Absolutely.
Now, is there any role of like that if it is lifelong 100%?
Because if you see, there is definitely waning of immunity against IPV, all the 3 types, as you grow old.
Yeah.
So there are studies done in Portugal and in several other countries, including Malaysia, where they have shown that the titers to type 2, type 3 disappears much faster than type 1 and type 2. And whether that will make you prone for adult polio, we don't know. But adult polio is a serious risk in a fully vaccinated child, especially if someone adult who has not been vaccinated at all. Like when I was, I think 2010, Tajikistan had a huge outbreak of polio, 400 plus cases, and almost 10 to 15% of them were in adult. And
Correct.
when I was president in 2006, there was a outbreak of wild polio in Namibia, 76 cases, all in adult. It was funny sight that the entire population was given a pulse polio vaccination. So I am a propagandist of giving one IPV in the second decade too, besides giving the 5 doses of IPV. So I mean, that's my take.
So are we expecting this vaccine to come?
So I have been telling Sanofi and GSK both that you should do a quickly sero-epidemiology study in India. Nowadays India is polio free and we are not giving type 2 at all for last several years. And there are several people, and there are only 2 rounds of OPV if at all. So there is hardly any cross herd immunity or herd protection or herd immunization.
Right.
So this is the right time that whether how many of us adults have lost antibody.
Yeah.
One of the DNB student can do this. This is a path by breaking study, and then they can bring that vaccine because it's already there. Adacel IPV and booster IPV.
Yeah,
is
it is
there.
available.
So it's only that lethargy of these companies to do something in India, you know.
Okay. So coming to
One second. What
sir.
Dr. Nitin says, but as usual, to differ a little from you, studies in American recruits, soldier recruits, during an outbreak of polio, all those had received polio vaccine, none of them developed paralytic polio, even those who had no detectable antibodies in their blood. So it means probably you require much lower levels, or you don't require pre-existing antibodies to protect you from paralytic polio. So I think this is where there is some ambiguity.
Yeah, so that's the question. No one has been able to prove this, whether all that adult polio that happened in these countries where all were unvaccinated, because they were all adults. So obviously if they were not vaccinated, they were exposed to oral polio vaccine left, right and center. So it's anyone's guess. I would not want to get adult polio. So I will take the vaccine. And those who follow me, please follow my advice.
Sir, so same question. All of us should take 1 dose of polio vac. Last time also I asked same use. So should we take 1 dose of polio vac ourselves?
So I told everyone, before you destroy your TOPV, take 1 oral polio vaccine and give it to all your family members. That's the last chance for type 2 boosting, because IPV was not available that time standalone. Now that you are standalone IPV, absolutely not. Suppose you are going to a polio afflicted country and you have to take an oral polio or IPV. IPV is allowed in adults.
Right.
So
should we take? Yes.
We take so many.
Have you taken, sir?
I have taken.
Okay.
The next
We are blind followers of you, sir.
Next vaccine conference should have it in
all
the
these
kit.
people who travel to African countries, why are they asked to take OPV? Why not IPV? They should be taken IPV.
And sir, what we have observed is last 1.5 year, almost 2 years, there is no round of pulse polio also in India. So have we done with the oral polio affair? नहीं, pulse polio नहीं हुआ सर. कभी हुआ है सर? नहीं हुआ है सर. अच्छा, हाँ. That is mop-up round, not pulse polio.
No pulse polio round has occurred.
हाँ, no pulse polio after. हाँ, नहीं mop-up round है वो सर.
So we'll
we have to continue that round, sir.
I think as of now we still need it because we still require some amount of mucosal immunity because we want protection against CDPV, so pulse polio has to continue.
No, but most of the children have not received third dose of IPV, sir, fractional IPV yet. So second, vaccine-derived polio.
Let's not, your IPV is not going to prevent.
Sir, we have 5 minutes more.
5 minutes?
Yes, sir.
Okay. Okay. Yeah. So, no online question on that, no?
No, nothing.
Yeah. Coming on online questions, take.
Sir, next is on pneumococcal vaccine. So pneumococcal vaccine, the question is single dose of pneumococcal 13 vaccine in kids more than 6 years, 6 to 18 years basically. Is there any recommendation? Not vaccinated before.
So it is licensed to give it above 6 years now in a country, but it is not required, what we discussed.
Western countries is up to 17 years, it has been recommended one single dose of PCV13, but basically it is not required in immunocompetent healthy children in our setup.
So next is about influenza, whoever wants to take it, sir. Influenza, the recommendation is up to 5 years, the first round. What about 5 years and...
No, he said...
5 years and above, because adult vaccination is recommended.
See, I think Western world, they are giving throughout
to everyone.
But in India, it is recommended compulsory below 5 years of age, and after 5 years, those children who are at high risk or in special situation, like the children of COPDs or whatever, asthma, all those immunocompromised children, they definitely require above 5 years of age.
Sir, you want to add?
What I wanted to say was follow the WHO guidelines, less than 5 years, above 65 years. 5 to 65 if you are a healthcare worker, if you are pregnant, or if you have any comorbid conditions, especially children with asthma, diabetes, kidney, heart problem.
So no routine recommendation?
No.
Okay. Sir, another one, this is not related to influenza, but recently there was an adenovirus outbreak moreover. So there was a question whether it is related to the Covishield vaccine which was carrying a vector.
No.
Not really.
You can't say like
Madam, yours.
I would like to ask that a sizable portion of our pediatric population go for vacations for 1 or 2 months to endemic areas like meningococcal or Jab B. So can you just enlighten us about what do we do? Do we vaccinate, not vaccinate? A part of this answer was given by Dr. Kasi, but we would like more clarification about it.
See, if they are traveling, say, first let's take JE. If they are traveling to an endemic area in a high transmission season, that is monsoon, immediate post-monsoon, then worthwhile giving, but you have to complete the schedule before, at least 2 weeks before the child travels.
That too in a rural area, no? If they're going to
It is rural area. I think that rural-urban divide is going off in JE now. Basically in the high transmission season, or they are going to indulge in activities where there's a greater chance of them in coming into contact with JE vectors. Like they're staying in rural areas, going for hiking, etc.
Playing with
so
pigs.
that is as far as this thing. Meningococcal vaccine, meningococcal infection in India, the level of endemicity is too low to recommend routine vaccination. If there is an epidemic going on, it would be better to advise them not to go rather than to give the vaccine and send them. Because meningococcal vaccine is not an outbreak response vaccine. Meningococcal outbreaks, immediate contacts, chemoprophylaxis, not vaccine. Vaccine is not an outbreak response vaccine, meningococcal vaccines.
Meningococcal in India means only northeastern countries, they are going to say students, recruits in that.
Yeah.
So, no, he's talking about
So people coming from Mumbai to Navi Mumbai should take G vaccine.
Few very quick questions, sir. Few about HPV vaccination. HPV vaccination more than 25 years of age. Which brands are recommended?
So here in India, it would be only HPV 4.
Okay, only one. So Gardasil basically.
Gardasil 4.
Gardasil 4.
So there is another question. 2 doses of Cervarix was given at teenage and now 35 years. Any need for boosters with 9? No need. Okay.
If they want to spend money, they can take. It's legally allowed, but no, not required.
So, sir, about Shingrix, I think Kashi sir can take this. So, age 70 years now. This is one of the pediatricians asking live. Age 70 years now. No vaccination before for varicella. never had infection, so should take Shingrix or
As
not?
early as possible.
As early as possible.
Sir, Kasi sir, you were saying about Kola strain, why 2 doses of killed vaccine are recommended, because that vaccine 2 doses, it boosts up the dose and then weaning becomes prolonged. Why ACVIP is so much reluctant for extrapolating same for typhoid vaccine?
I think Mumbai is Navi Mumbai and Mumbai is a stronghold for 2 doses. Am I right?
Sir, actually entire India, sir, is giving.
No, you come to the south, very few use 2 doses.
Huh.
Tell me, I'll tell you.
Yes, sir. Yes, sir. And no vaccine dialogue is complete without a mention of COVID vaccine. So now intranasal booster has come by serum as those who have not taken booster dose. So should we also take as a healthcare worker?
I think if you have taken 2 primary and 1 booster,
गवर्नमेंट में आया ना सर? नहीं सॉरी भारत का.
Innovac is by Bharat Biotech. See, if you have taken 2 primary
Incovac.
doses of a COVID vaccine and 1
One booster.
Your booster has stimulated the T cell immune response. Now, your T cell immune response is not going to get boosted by taking more and more boosters.
Yeah.
1 or 2 doses, and that's the peak of the T cell response. There is some waning, but very little waning. Now, if you're giving further boosters, you are boosting the antibody titers against the original strain,
Right.
not against the prevailing strains. And you know now, the Wuhan strain antibodies, they don't even touch
Exist
the
also.
Omicron variant.
Correct.
So I think 2 priming and 1 booster, and after that, forget it.
Okay. Sir, newer vaccines in pipeline, we are waiting for paratyphi and chikungunya. Dengue, sir, explained well. So when are they expected?
It's a long time.
Dengue will come first.
See, chikungunya, Bharat Biotech has started phase 3. So I
Phase
don't
3,
think
they are
it
in
will
phase
go 3
3.
years.
Yeah. So I think that's the end of the audience
So we
round.
have a lot of online
I thank you all.
questions as well,
Yeah.
but we'll have to wind
Yes.
up the session because a lot of faculties have to take the flight as well.
Yes.
Yeah. So
Thank you so much. I would ask Dr. Shikha to give memento to Dr. Agarwal, please. Dr. Agarwal. Yeah. Just please wait for 2 minutes, just 2 minutes. And to Dr. Jitendra Gawane as well. I'll just ask Dr. Nehal to give our give a vote of thanks to everyone.
We can take all faculty, all 14 faculty, please come up the stage so that we can take a group photo. Yeah, vote of thanks भी करो, लेकिन इन लोगों को flight पकड़ना है ना इसलिए.
So I'm very sure that after this very interesting, interactive and informative vaccine CME, most of our quizzes and queries about the old and concerns and curiosities about the new have been done for. We have learned, unlearned and got educated, and of course now we are going to go on vaccinations also. So on behalf of the organizing team and team IAP Mumbai, I would express my heartfelt thanks to our expert faculties of the scientific program today. It was truly an awesome academic feast, which has helped both active and passively in boosting up our knowledge about the vaccines and vaccination today. No CME is successful without a very enthusiastic and an interactive audience. A special thanks to all our delegates for acting as adjuvants in keeping today's program very lively and interactive and keeping it power-packed right till the end. The online people are still sending questions. Thank you very much, online audience as well. We express our sincere thanks to the pharma sponsors for making this event possible today and contributing to this directly or indirectly. Many thanks to the team of Geo World Convention Center for giving us the opportunity of having our CME here today. Dr. Bipin Shah sir has been very instrumental all the time for helping us in getting the most relished food throughout this thing. So thank you very much, sir. It would be wrong to forget the untiring efforts of our office staff, Nilesh and Vinod, and they truly deserve a good special thanks and a round of applause. Dinesh and his team, Digital Info Media partners for AV today, thank you very much for making this possible at the virtual and the physical platform. Our excellent MOCs for today. So Dr. Sikha Agarwal and Dr. Tanushri deserve a good round of applause for sticking to the time, and thank you personally for allowing me those 8 minutes more. So last but not the least, the 100% success efficacy from the manufacturer to the beneficiary, recipients, has been possible only because of our mastermind and, of course, mastermind, scientific convener and vaccine stalwart, Dr. Nitin Shah, sir. Big round of applause. And of course, under the constant supervision and able guidance of our President, Dr. Rajesh Shokhani, sir. And of course, the Herculean efforts of our Treasurer, Dr. Amruta Shirodkar. And of course, we have our entire organizing team committee members and our other EB members who have directly and indirectly really helped us to make this CME very... Boli, sir. Khavano pella. So, wishing you all a very happy Sunday evening. Thank you once again, all of you. Thank you very much. There is tea and coffee served outside. Anybody who wishes to have it and go. हाँ, अभी तेरा ये भी ले ले, जीतू.